Good morning from Prague, and welcome on the second day of this course, the EXMINT5. And thank you to everybody who sent the questions yesterday, and it was a very nice discussion. And we recorded these questions for brainstorming for the future as well. And I like to invite the first speaker today, who is Diana Souza from Lisbon. She's already with us. Can you hear me, Diana?
Yes, perfectly. So
Perfect.
Thank you very much. Good morning, everybody.
Good morning to Lisbon. And we will start with stroke mimics and uncommon causes of stroke. So Diana, please go ahead.
Thank you. So yes, so today we will start with this very exciting topic to compensate that it's in large areas of the world, it's still quite early, such as in Europe. So in this lecture, we will cover two very large topics, actually. So mimics and chameleons, which we already mentioned yesterday. It's very important in the emergency setting to have this in mind. And also some uncommon or less common causes of stroke that are important even for the interventionalists doing the procedure. So these are two very large topics. So we will try to cover what is most important for some of these groups of patients. And of course, we want to know the truth about the patient. So both the diagnosis and the cause is something that is extremely important. So starting with the stroke mimics and chameleons, as I said yesterday, a stroke mimic is a clinical picture that looks like a stroke, but actually is not a stroke. So usually it's something that looks like a sudden onset of focal neurological deficits, but actually is not a stroke. And then the stroke chameleons is even more difficult because at the beginning, it does not look like a stroke, but then you are missing a clinical diagnosis of stroke. So this is very challenging because these patients might not be referred to you as the physician taking care of stroke patients, but it's important not to miss them whenever possible. And actually, this is quite common. So this is not something that you will see from time to time. No, this is something you see every emergency shift, the patients coming with stroke mimics. And of course, you have to be sure, because especially if you are the physician taking care of these patients, it's very important that you do the right thing. So you may argue that it's like in this situation. So you do TPA, the patient is not a stroke and you have a complication, and that's very bad. Or you don't do the treatment and you miss a stroke that could have been treated, and then it's very bad again. So the only answer to this and the only solution is really to be sure of the clinical diagnosis. And so this is why it is so important. And that's why the neurologist, again, is so serious. So starting with another clinical case, which I always think is the best way of approaching this type of clinical discussions. So this is a case of a patient, a 35-year-old man. He was lying in bed, confused. He had facial asymmetry, so he had a left side facial drop, and he was not moving his left arm and leg. And so his wife, Mrs. Jackson, she called the emergency services, and she explains this. And then the emergency services come. They give the patient oxygen at a high level, and they activate the stroke code, and they take the patient to the next stroke center. They are very concerned because it really looks like a stroke. It's a young patient. They rush to the stroke center. On the way to the hospital, they still do everything they should do, including checking the blood glucose. And actually, it's 35, so it's very low. So they give the patient dextrose on water, and he improves. So at the hospital, when he arrives, he is already normal. And so what you do as the stroke physician taking care of these patients? Actually, hypoglycemia and hyperglycemia are important stroke mimics. Both can cause a clinical picture that is all similar to a stroke and are very easy to treat. It's just correcting blood glucose. So it is mandatory that you do glucose in all patients. Really, that this happens in clinical practice, and it's so easy to miss if you don't do the blood glucose test. So this is really something you should always do, even in patients eligible for TPA and so on. Another possible manifestation that, of course, if you see it, you really have to check is Korean balismus, which is a very typical manifestation of this entity called non-ketotic hyperglycemia. You may see this on the CT. So if you see this, no, it's not a petechial hemorrhagic transformation. It's the typical imaging presentation of this clinical picture, and usually patients present with involuntary movements of the opposite side. Patients also typically respond to treatment. So it is, as I said, mandatory that you always check for blood glucose before proceeding to treatments. Then another clinical case. So in this case, it's again a man, 47-year-old. He was again found in bed, confused, and he could not move again the left arm and leg. This time he was found by his son, and they were planning to go fishing by 5 a.m., but he was not showing up. So his son came to the bed and found him like this. So it's a wake-up neurological deficit. And then he calls the emergency services, and they found the patient confused, slurred speech, left side paresis. They were quite certain this was a stroke, a young patient. So again, they really rushed to the emergency department for treatment, and they start fluids. At the hospital, the stroke physician comes to the witness, so to the son of the patient, and asks about what happened before. And actually, and this was missed by the paramedics, he mentions that his dad's left hand had been jerking a little when he first went to wake him up. And also he mentioned that he noticed that his dad's eyes were slanted to the left, and you remember the paresis was at the left side, and he drooled a little as well. Now the patient is improving, and now you can even talk with the patient. And now you ask him if he has history of epilepsy, considering all this, and he actually has. And he has stopped taking medications recently. And before, in another seizure, he already had an episode of hemiparesis after the seizure. So this is something that even happened already before. So the emergency physician explains that it is very important to take the anti-epileptic drugs, that probably this was a seizure followed by transient hemiparesis. And then you replace the levels of anti-epileptics, and the patient is discharged, and definitely this is not a stroke. So the thought paresis is something well known and actually very common also in the emergency setting. So some patients after a seizure, usually, or either a focal seizure with motor signs or a tonic-clonic seizure, they recover with hemiplegia or hemiparesis. This may take just a few minutes, up to half an hour, but some patients, it takes really days to improve, which is called a typical thought paresis, but that may happen. This is what is key is the history of seizure or seizures. Of course, if you have a bite mark on the lateral side of the tongue, you may suspect also of a seizure. If the patient is confused or somnolent more than expected for an hemispheric stroke, that is also something that can be suggestive of a seizure. But of course, in these cases that the paresis go on for a long time, you need to do the differential diagnosis with stroke and seizure, because sometimes seizure is already is also the presentation of an ischemic stroke. It may be an acute seizure related with stroke, and that is not a contraindication to thrombolytic therapy. So if the patient is not improving, then you have to do MRI or something to really to confirm whether it is a stroke and a seizure. Also, the seizure can also occur during the presentation of the patient or while you are in the emergency, and that doesn't mean it's not a stroke. It may still be. For the differential diagnosis in these more challenging cases, it may be helpful, of course, to do the CT if you have previous cortical brain lesions. That may be the cause of the epilepsy. And of course, if you do perfusion, either CT or MR perfusion, you may find hyperperfusion if you have really acute seizures, or hypoperfusion if you are already on the post-ictal state. And you may find some typical changes also in DWI, typical of the status epilepticus, even diffusion restriction, like here this is flare and here is diffusion restriction, and this is related with seizures. And you see the typical changes also on the perfusion with hyperperfusion. So may be helpful to do advanced imaging in these very challenging cases. And if you have an ongoing status epilepticus, you may have even this diffusion restriction and this hyperperfusion. So have that in mind, that it may be related with seizures and not with stroke. Of course, there are many other stroke mimics. Also, functional disorders may be very challenging. We see here the Hoover sign. Of course, there is an exclusion diagnosis, probably not even a diagnosis that you can make in the emergency setting. You can just suspect and then do all the workup in order to be sure that it is really a functional disorder. Migraine, especially migraine with aura, may be a stroke mimic. Of course, you have to have in mind encephalitis, infectious diseases of the brain, also because the risk for TPA is increased in this case. Tumors, but that you will see usually on imaging, and then other types of rare types of stroke, like posterior reversible vasoconstriction syndrome or PRES. Also hypertensive encephalopathy drugs. So there are quite a high number of differential diagnoses that you have to consider in the correct clinical picture. Actually, the most common is really seizures, syncope, infectious disorders, especially systemic disorders, actually more than central nervous system infection, because especially older patients tend to have encephalopathy associated with infectious disorders, then the functional disorders, headaches, and then brain tumors, metabolic changes, and other more less common causes of focal signs, including peripheral vestibular disorder, which is also very common in the emergency setting. Of course, many people try to have kind of a simple way of doing this, of checking for stroke mimics. It's not that simple. Again, you have to have the patterns of clinical symptoms, find what's wrong within the pattern. And but of course, there are some signs that are predictive of having a stroke mimic, and some signs that are very predictive of having really a real stroke. Of course, if you have a seizure at onset, it's more likely that you have a mimic. If you have profound changes in consciousness, it's more likely that you have a mimic, because hemispheric strokes should not have major changes in consciousness. If the patient is improving and now can walk, probably it's a stroke mimic. Patients with cognitive impairment also are more likely to be a stroke mimic. Of course, if you don't have lateralizing signs, if the signs do not equal the vascular territory, which is also, as I said, very important if there's something outside of the usual clinical picture. So there are quite a few things that have been found to be predictive of stroke mimics, but at the end you have to have your clinical experience and to find the diagnosis. What is good news is that if you miss a stroke mimic and you do TPA, usually in most patients this is safe. So particularly in patients that don't really have an acute neurological disorder like an infectious disease or tumor, then a structural change in the brain, then usually like in functional disorders and so is usually safe if you miss and do TPA. So in conclusion, for this first part, there are a large number of disorders that mimic strokes, and it can be serious if you don't do the diagnosis, both because you can do incorrect treatments and also because in the future, the patient will have a wrong diagnosis. So the emergency setting is the gold opportunity to do the right diagnosis while you see the patient. It is very important to have a comprehensive history and throughout physical examination. To do all the available tests, including glucose, imaging, everything you may need to make the correct diagnosis. And of course, you still have to be fast because if the patient is eligible for reperfusion therapy, you have to do it as quickly as possible. But also you have to have a high index of suspicion for mimics. So if you are suspecting of a stroke mimic, then it's better to avoid that the patient receive unnecessary and dangerous therapies. So let's go to another very exciting topic, which is the uncommon causes of stroke. And why is this important for you as well, as a future interventionalist? So what you will treat is mostly these two first boxes. So you will treat patients with embolic stroke and patients with non-embolic stroke, but also non-small vessel disease, because small vessel disease is not approached by endovascular treatment, right? So mostly you can divide your patients in two groups, those that have an embolic large vessel occlusion and those that have a non-embolic large vessel occlusion, which is related with some kind of vasculopathy at the vessel you are treating usually. It can be intracranial artery stenosis for traumatosis. It can be other types of vasculitis, other types of vasculopathy that are not related with that traumatosis, and also, for example, dissection, either at the cervical level or at the intracranial level. And then the embolic stroke is probably the most common, and usually the embolus comes from the heart, but you may also have paradoxical embolism, non-thrombotic mediated embolism, or a thrombus coming from another artery, like in carotid atherosclerosis. So these are the patients that you will treat. So starting with the embolic occlusions, atrial fibrillation is definitely the most common cause and probably one of the main reasons why endovascular treatment works so well, because these patients are really easier to treat comparing with patients with vasculopathy and even other causes of embolus. Of course, you may also have other sources, heart sources of thrombus, valvular disease, rare causes like tumors of the heart, and it is important also to consider for endocarditis. These patients are not eligible for TPA, so it's very important that you consider this cause, and then patients may be eligible for endovascular treatment, but of course, because of the infection and the inflammation around the vessel may be also more complicated. Then you may also have plaques from the aortic arch, from the carotid, and paradoxical emboli, especially in young patients. Then for causes of vasculopathy, you may have intracranial atherosclerosis, which will be the most common, but also vasculitis, dissection. And there are then some causes in which probably you don't want to touch, like vasoconstriction, fibromuscular dysplasia, and moyamoya syndrome. And thrombectomy failure is much more likely in these patients with a non-embolic occlusion. So have that in mind, that it's also important for you to know what is the cause of the occlusion. Of course, common causes of stroke is a whole book, several books. There are many causes of stroke. Some are very challenging to diagnose, also from the imaging point of view. I'm seeing here, for example, MELAS. Of course, many other causes of thrombotic state, like cancer-related strokes, drugs, infections. So there are quite a lot of causes. How can you recognize the stroke etiology, especially if you are doing the intervention? So such a short time, between door and groin puncture. So in such a short time, how can we find the etiology? Actually, there are quite a few signs you can check even in an emergency setting. For example, recent history of varicella or zoster infection that may suggest a vasculitis, and that is probably then a complicated treatment. Patients usually that had TIAs, especially if they are all similar, before having the large vessel occlusion stroke, usually this means immediately that there's something going on in the vessel. So you should be cautious because there is probably a local vasculopathy. If you have patients with history of trauma, headache, connective tissue disorders, think about intracranial dissection, also much more challenging. Then patients that have, of course, heart disease is more common that they have an embolic large vessel occlusion. If you have a young female, oral contraception, pregnancy, etc., probably it's a paradoxical emboli. And if you have a patient with fever and high CRP, then think about endocarditis. And again, this is very important to know in the emergency setting. These are some of the signs. So for the vasculitis, for the connective tissue disorder, for the cutaneous changes in endocarditis. So this is again another example of a young female patient with focal signs. At the admission, she had improved, but of course we still do CT and CT angio, and you see this wall thickening around the carotid artery. You see it's quite abnormal. And actually, she had this history of back pain and fatigue, weight loss, low fever. She had anemia and a very high sedimentation rate in the blood analysis. And you lower a bit your CT angio, and you see that the aorta is also thickening. There's also this thickening around the wall. So you do an ultrasound and you see this very typical sign, the Maccheroni sign, around the left CCA and the internal carotid artery as well. So this is very typical of an inflammatory disease of this aortic branches and the aortic arc, which is very typical, also confirmed with PET, which is very typical of Takayasu arthritis, which is a granulomatous large vessel vasculitis, more common in young women, more common in Asians. And it's important to consider this diagnosis because the treatment is specific. And some hints from the physical examination, for example, if you check blood pressure in both arms and you see a difference, probably it's involvement of the branches of the aorta that go to the arms. So the patient did steroids and she improved, and also the ultrasound. So of course there are quite a large number of vasculitis. The most common is probably temporal arteritis, which you do see quite a few times per year. Then there are less common types, both for small vessel, for example, this vasculitis that have eye involvement, or more large vessels like temporal arteritis and Takayasu arthritis. Of course, you also have infectious causes and secondary to systemic diseases. In this case, there is a high risk of vessel injury. So if you suspect for some reason a vasculitis in a patient, be careful with the treatment, or even consider not to treat if it is a bad case, because the risk is increased of reocclusion and also dissection and thrombosis. Here we have a typical case of a patient with 60 years old with right side hemiparesis, aphasia, CT angio-normal, CT normal, you do thrombolysis, and then you check the D-dimers and it's extremely high. And you do the MRI and you see quite a few lesions in several areas, not only the symptomatic brain lesion, but then several small lesions all across all the other hemisphere and also the posterior circulation. So of course, you have to check for cancer-related thrombosis, and in these cases, both with several lesions and high D-dimers, and this patient had a lung cancer. So this may happen up to 10% of ischemic stroke patients. The potential mechanisms are these abnormalities in the coagulation system, endothelial dysfunction, even marantic endocarditis, Liebman-Sachs endocarditis may happen, and also local causes. The most common is lung, but also pancreatic cancer is very much associated with thrombotic state, also breast, stomach, colon, and this is not rare. So if you see multiple embolic events or very high D-dimers, then consider this diagnosis. Another cause of hypercoagulability is that is not related with cancer, but it's an acquired thrombotic disease, is antiphospholipid syndrome. It is also important to consider, especially in younger patients, especially females with explained history of spontaneous abortion. And you have to check for the typical lab pattern. Then there are more rare causes like cryoglobulinemia associated with hepatitis and paraneoplastic syndromes. For uncommon causes of stroke, of course, in the emergency setting, you still have to consider some of these causes, particularly reversible cerebral vasoconstriction syndrome. So if you see this kind of lesions, more common in the posterior circulation, if you see, you do the angio and you see that there are several vessels that are that have stenosis, then consider this. Of course, you may do endovascular treatment, but it's different from the large vessel occlusion treatment. It's a treatment for vasospasm, so be careful with these cases. You may also have drug-related stroke. It's not that rare. Eclampsia and puerperium, you should think about different causes like those related with hypertension during pregnancy, so eclampsia, preeclampsia, cerebral angiopathy, related with pregnancy, so RCVS kind of diagnosis, dissection, and of course cerebral venous thrombosis. It's also more common in these patients. Then if you see strange embolus, it may be myxoma or endocarditis, and be careful also with the genetic diseases. These are quite rare, but also they have a different presentation like MELAS or CADASIL. So in conclusion, stroke mimics are common in the emergency setting, and it's very important that you have a detailed clinical history and careful with brain imaging and the interpretation. And also large vessel occlusion is not a single entity, and that is probably one of the missing pieces we have in understanding better the different results of endovascular treatment, is because these are different diseases. This is quite an heterogeneous etiology, and sometimes we have vasculopathy and other causes that it's more difficult to treat with endovascular treatment. So consider this if you have the reperfusion failure and complications, then maybe a vasculopathy. So stroke is an emergency, we have to be fast, but we still have to take care of the stroke mimics and the uncommon causes, so be careful and good luck.
Okay, thank you so much. And my question would be, you mentioned also the probability of age and some of these diseases you mentioned in your lecture. It's, I mean, age dependent. And what would you say to us about the stroke in children, since there are some viral diseases, and we have these patients from time to time, and the problem is with the pediatrician neurologist that that might be a delay in the logistic of these patients, in diagnosis and then the treatment. What's your experience in this?
Yes, it's much more challenging. Of course, there are patients that respond similarly to endovascular treatment. I remember a recent patient with a heart disease, severe heart disease, and of course, this was an embolic stroke, and so the response to endovascular treatment is good. But you should consider that in children, many patients are stroke mimics, more than in adults even, and also that even in patients that have large vessel occlusion, other etiologies are much more common, including infectious vasculopathy. So you have to be careful. Of course, if it is a patient with heart disease, a non-embolic cause, probably it's quite similar. And like, of course, it's a smaller patient, so from the technical point of view, I imagine it's a bit different. But from our point of view, it's the same. If you are successful with treatment, probably that's a good thing. But especially you have to be careful with stroke mimics and with vasculopathy, especially infectious vasculopathy, which is not rare in these patients.
How can one rule out all these stroke mimics, especially vasculitis, in an emergency situation when the patient can't give you your past history? How can we be quick in ruling these out?
Yeah, that's the key question. Sometimes it's possible, sometimes you just find the diagnosis later, right? So what you have to be very careful is to find the signs that you are dealing with a different case. So you have to check, for example, if the patient has a fever, and that is something that probably the relatives say. And probably you can measure in the patient and see if the patient has fever. You can measure CRP and quickly see if there's an increase. And so if you see something like this, immediately you have to consider, is this endocarditis? Maybe you can ask your colleague in the cardiology to do a quick echocardiogram just to see if there's any vegetation, any changes. So you may start to think about that, and you should, of course, discuss that with an interventionalist, because that information is important, and especially it is important for the stroke physician in order to avoid, for example, TPA if you suspect an endocarditis. So it's not always possible, but if you are taking really attention and paying really attention to these signs that something is different from what should be, then you may get there quickly, even if not before the treatment. Still in the emergency setting, it's possible. But of course, it's not always possible, and sometimes you just find that it's a vasculopathic disease when the interventionalist says, "Oh, there's constant reocclusion, and I cannot take care of the patient," and so you start searching for the other signs and building your clinical diagnosis.
Mm-hmm. And another question here: if someone have poor NIH stroke scare but good area of penumbra. Oh, sorry, that I overlooked that once again.
Yeah, has a high NIHSS.
No, that's that. I just move my that David sent us. Can acute secondary focal seizure be first presentation of TIA as well? It might look even more like a TOTS paresis, since it goes away after some time too. Is there any data, knowledge about this? How frequent this scenario might be?
So you mean being a mimic for a TIA, right?
Yeah.
Yeah,
Well,
it's
first presentation of TIA, that's a secondary focal seizure, is the first presentation of TIA.
Yeah, it's uncommon, I would say, but of course the differential diagnosis is quite challenging. because a TIA, you may not even see the signs in the patient, and you may not have a lesion in the MRI or the CT. So at the end, when the patient has involuntary movements and TIA, it's very difficult to say if it was a seizure in the TIA or just a seizure or just a TIA. There is an entity called shaking TIA. Actually, the current evidence suggests it is not a seizure. It is just movements related with the ischemic process, which also happens, and is usually related with hypoperfusion, so hemodynamic stroke, so related with some stenosis or transient occlusion, causing hemodynamic failure. Sometimes these patients present with neurological deficit and movements, involuntary movements of usually of the arm, and this is called shaking TIA. Of course, at this point, it's not impossible that you have seizures and TIAs. Of course, the pathological process is the same as an ischemic stroke, but I would say it's less common.
Okay, so we are a little bit behind the schedule. I have here several questions. I leave it for your next lecture discussion. And at the time being now, thank you so much. And we will switch to the St. Gallen, Switzerland, to Pascal Mordassini. So, hi, Pascal, can you hear us?
Hi, yes, I can hear you. Can you hear me?
Perfect, yeah, all right.
Good.
So you have your topic is selection patients for intravenous thrombolysis. So please go ahead.
Yes, thank you very much, Tony, again for inviting me. I worked many years in Bern, and I just now in summer moved to St. Gallen, which is another big hospital in the eastern part of Switzerland, and it's again a pleasure for me to be able to participate in this course. The first talk I'm going to have now is about the clinical patient selection for intravenous thrombolysis, and I put it in a way that I will talk about the on-label treatment indications. There will be a second talk where there is more the off-label indication that I'm going to address. So let's start. So there are some milestones in acute stroke treatment. In 1995, intravenous thrombolysis was introduced into clinical practice with a positive randomized controlled trial, so-called NINS trial. In 1997, there was a randomized controlled trial about intra-arterial thrombolysis, which was also positive, which is called the PROACT-2 trial. So intravenous and intra-arterial thrombolysis have been established as treatment options for acute ischemic stroke until the end of the 90s. In 2008, there was a very important study in my view. It's not just because I used to work many years in Bern, and this study was performed in Bern and in Zurich, but it's one of the first studies who showed the potential huge benefit of endovascular stroke treatment in comparison to intravenous thrombolysis alone. What they did was they compared patients that were treated in Bern with intra-arterial thrombolysis. They compared those patients retrospectively with patients that were treated in Zurich, who were only treated with intravenous thrombolysis, and they were looking retrospectively, and they were choosing patients with a dense media sign, and the difference in good outcome was 30% in favor of intra-arterial thrombolysis. So there were very strong indications that intra-arterial or endovascular treatment might be highly efficient and more efficient than intravenous thrombolysis in large vessel occlusions. And then, of course, you all know in 2015, several randomized controlled trials were published establishing the evidence for mechanical thrombectomy, mainly using stent retrievers, its superiority over intravenous thrombolysis alone. I think these are important milestones to keep in mind and to know about. So intravenous thrombolysis is the gold standard. It's the clot buster. It was FDA approved for the treatment of acute ischemic strokes in 1996 after the NINS trial. However, if we look at the whole population, only a minority of ischemic stroke patients are eligible for intravenous thrombolysis. There's some data showing that only around 8% of all strokes are eligible, mainly due to the narrow time window and mainly due to contraindications, increasing the risk of cerebral or systemic hemorrhages. It is efficient, we will see that, but we know that it achieves early perfusion in maybe half or less than half of the patients in large vessel occlusions. We will come to that in my second talk in more detail. So this was the NINS trial, published in the New England Journal of Medicine in 1995. What did it show? It showed a 13% absolute risk reduction for dependency, meaning a modified Rankin scale of 0 or 0 to 2, compared to placebo, with a number needed to treat of 8. So it seems to be quite a good treatment. A couple of years later, they tried to broaden the time window and to see whether intravenous thrombolysis can be applied also after 3 hours. The NITS trial has chosen 3 hours as a time window, and that's also why the FDA and in Japan, intravenous thrombolysis is approved within the 3-hour window and not within the 4.5-hour windows. ECAS was a European study and showed that even within the 4.5-hour window, there was still a significant risk reduction. It's not that impressive anymore, but still there's a treatment effect. And that's why in Europe, the time window for the application of intravenous thrombolysis is 4.5 hours. We know that the effect of intravenous thrombolysis is time dependent. The longer time has passed after stroke treatment, the less likely will be the odds ratio for good clinical outcome. But nevertheless, if you look at all the intravenous thrombolysis trials, the big trials, the randomized controlled trials, it's clear there is a treatment benefit of intravenous thrombolysis, and it's a standard of care in all eligible patients within 4.5 hours after symptom onset. This is also written like that in the 2018 American Heart Association and American Stroke Association guidelines, that patients who are eligible for IV TPA should receive IV TPA, even if endovascular treatment is being considered. This is a very important question, and we're going to address this also in more detail in the other talk. So another important factor, of course, as I said, the important factor, of course, is time to treatment. We have to shorten time to needle time. We also talk about time to needle time in the intravenous thrombolysis, but it's just a small needle for the venous application and not the big needle for the arterial puncture. And it has been nicely shown that this is important, and this is also a matter of training and experience. This was the group of Helsinki who nicely analyzed their data, and you can see the more intravenous thrombolysis they performed, the shorter the door to needle time became. So there's clearly a treatment effect in your in-hospital pathway, and you have to train and implement that in order to be able to quickly administer IV TPA, quickly establish the diagnosis. And of course, then we have endovascular treatment with all those randomized controlled trials looking at mechanical thrombectomy. And here we have a similar effect. Again, if we look at the whole population of those patients that were included in the study, we also have this time-dependent effect for endovascular treatment, which is around 7 hours. But again, this doesn't reflect individual patient state. But also here, several studies have shown that you can be faster and quicker and improve your hospital delays in order to be fast and improve your perfusion times. So one of the main issues, one of the main or most important things to look and strive for is shortened time to perfusion. Sometimes it's good to monitor that. In Switzerland, we have a nationwide stroke registry, this is the Swiss Stroke Registry, and all the metrics and all the timelines have to be documented, and then they are monitored. And if something changes, and if you're too slow, people will ask you questions, what's going on here? And the way we did it in Bern at the time was to implement a stroke clock on an iPad. And you can nicely see here, time is running, time is praying. And one of our colleagues, Simon Jung from neurology, who designed it, He even implemented a count for neuron loss, so just to further motivate all the people involved in this in the chain of actions. So the indications for intravenous thrombolytics is the treatment of acute ischemic stroke within 4.5 hours after symptoms after stroke onset and after exclusion of intracranial hemorrhage. There are several absolute and relative contraindications for the administration of intravenous thrombolytics because they increase or may increase the risk of cerebral hemorrhage. Of course, if you already have an acute or subacute bleeding in association with the stroke, on neuroimaging, symptoms of signs of subarachnoid hemorrhage. If you have an IRR, if you have anticoagulants, we come to that in a minute. Low platelet counts, prior stroke, hypoglycemia or hyperglycemia, hyponatremia and hypernatremia, and so on and so on. We already heard about endocarditis, pericarditis, tetanus vasculitis, known giant aneurysms or vessel malformations, and also severe traumatic brain injuries. Of course, acute gastrointestinal bleeding or oncological diseases and abdominal aortic aneurysms are also relative contraindications. So is intravenous thrombolysis safe for everybody? There have been many studies looking at different subgroups of patients for intravenous thrombolysis, and they have been shown that it's effective in all of those varieties. So all ethnic groups, also in cervical artery dissections, in posterior circulation stroke, of course, also after recent stroke, in minor silent subacute stroke, patients also presenting with severe hypertension, also in different levels of glucose and in an INR up to 1.7 after recent myocardial infarctions, after seizures. It's still better to thrombolyze a patient in doubt if you have a stroke mimic, if you're not sure whether it's an intravenous a stroke or a seizure. As in asymptomatic aneurysms, moderate leukoneurosis, like leukoarosis, and moderate microbleeds. So we have clearly seen in clinical practice a paradigm shift from where we looked for reasons not to thrombolyze, and we looked for contraindications, and we shifted it to thrombolyze whenever possible and to look for reasons where we can thrombolyze and to minimize contraindications. So which patient is at risk for bleeding complications, which is the most feared complication, of course, of intravenous thrombolysis? So there is a score, the so-called SEDAN score, was developed by the group in Helsinki. S stands for the glucose level, E for early infarct signs on admission, D for dense or hypertense cerebral artery sign, A for age, and N for NHSSK. You're getting points, and with the increasing number of points, the maximum is 5, also the risk of symptomatic intracerebral hemorrhage will increase. And this is a short, quick score where you can roughly estimate the potential bleeding risk. If you have 0 points, it's around between 1 and 2%. If you have 5 points, it's more than 15% of bleeding rate. So the SEDAN score looks at all symptomatic intracranial hemorrhages, but what about fatal intracranial hemorrhages? And it's quite safe regarding mortality. So if you have a low NHS score, the risk is 0. But still, it's still safe or comparatively safe, even if you have a severe stroke. So that's why this is not a contraindication for intravenous thrombolysis. We talked about the time window. So is intravenous thrombolysis also safe and efficacious after 4.5 hour window? And there have been some hints in previous literature here from the IST3 trial, where they looked at patients who were treated over 4.5 hours after stroke symptoms. There were some patients that were included like that. And it still seemed to have a benefit, a treatment effect in this patient group. So it was certainly worth looking more in this direction. And the next step was to look for intravenous thrombolysis in wake-up stroke. Can we do intravenous thrombolysis in wake-up stroke, where the exact time we do is unknown? Wake-up stroke is a very important subgroup of stroke. Around 20% of all strokes are wake-up on one hand, but on the other hand, we also know that wake-up stroke, in the majority of cases, they occur just before awakening and not 5 minutes after you go to bed in the evening, and then you wake up with a stroke in the morning. Most of them are during the early morning hours before awakening. There has been an MR trial, wake-up trial, randomized controlled trial, looking at this question. And the key in this trial was to guide image decision-making by MR patient selection, and looking for an MR DWI flare mismatch. So what is this meaning? So if you have an infarct on DWI, but you don't have demarcation on flare, you can include this patient. But if you have a DWI lesion and you have a corresponding flare demarcation, you cannot include these patients. They excluded patients in the trial who were going for thrombectomy and also with a very age NHS score, and the primary endpoint was a modified Rankin scale of 1 or less after 3 months. And the trial was positive, so there was a clinical benefit for thrombolysis in those patients, although numerically the intercerebral hemorrhages were slightly increases, but not in a significant way. Another big issue is, of course, intravenous thrombolysis and oral anticoagulation. And here we have to a little bit split oral anticoagulation into the vitamin K antagonists and the novel oral anticoagulation. So let's start with the vitamin K antagonist. There's been a large observational study with more than 23,000 patients treated with IV-TPA, and they were looking at the patients who were on the warfarin, so vitamin K antagonist, and they nicely saw that the bleeding rate started to significantly increase around about an INR of 1.7. Below that, it's somewhere between 5%, and then it starts to increase to 10% or even more. So from this study, the recommendation arises that patients with an INR of more than 1.7 should not, IV-TPA should not be administered, because we are not sure about the bleeding rate, which might be increased. So what about the direct oral anticoagulants, the DOACs and NOACs? These are novel medications, but they're used more and more frequently, and we have some limited data on IV thrombolysis in patients who are under those medications. It's not a lot of data, but it might give us a hint to guide our treatment decision. Also here, again, a large registry with more than 42,000 patients included for IV thrombolysis, and 251 were under DOAC, and there was no significant increase in symptomatic intracranial hemorrhage. There's another older studies where they stratified according IV thrombolytic patients according to the status of anticoagulants. And if you look here, patients who had no oral anticoagulants, that kind of similar bleeding rates like patients who were under the novel anticoagulants. Again, not a lot of patients included. And also here, if you look at the subgroups, if we have an INR more than 1.7 in with the vitamin K antagonists, we have increased bleeding rates. If you have an INR of less than 0.7, the bleeding rates are not that much increased, and they are similar compared to the novel anticoagulants. So for the time being, the conclusion is that in adult patients with acute ischemic stroke, alteplase started within 4.5 hours of symptom onset and appears not to increase the risk of symptomatic intracranial hemorrhage. If warfarin is used with an INR of less than 1.7, if DOACs are used, however, the data on DOACs is still limited. So the current recommendations say that alteplase should not be administered to patients taking direct thrombin inhibitors or direct factor XA inhibitors, which are the novel anticoagulants, until laboratory tests are normal or the patient has not received a dose of these agents for more than 48 hours. And you can do laboratory testing to see the activity. And there have been a proposal for certain thresholds where you still can administer IV-TPA where it seems to be safe, but this is not yet very proven data, but this gives you a good overview on how to deal with these patients. Another issues might be microbleeds. So, you know, they're treating more and more elderly patients, and there is an increasing frequency of several microbleeds. So are those patients at an increased risk of suffering from intercellular hemorrhage after intravenous thrombolysis? So this is also studies with almost 2,500 patients, and meta-analysis including 9 studies. And what they found, they were looking at the bleeding rates, the bleeding events in patients where they had any number of cerebral microbleeds, and patients who had no microbleeds. And there were an increase in risk for bleeding. So they looked into more details, and they further stratified that the patients in more than 10 microbleeds and less than 10 microbleeds. And here there was a significant increase in bleeding risk. Nevertheless, stroke is a severe disease, and intravenous thrombolysis is an efficient treatment. So the current recommendations are that in otherwise eligible patients who have a small number, small means 1 to 10 number of cerebral microbleeds on MRI, IV intravenous administration is reasonable. And in other patients who have more than 10 microbleeds on MRI, IV-TPA might be associated with an increased risk of symptomatic intercellular hemorrhage, and the benefits of the treatment are uncertain. So treatment may still be reasonable if there is the potential for substantial benefit. As I said, stroke is a very disabling disease. So here we have to balance the risk of intravenous thrombolysis compared with the risk of microbleeds. However, oftentimes this is not affecting us that much in the acute treatment decision because according to the guidelines, we do not need to have an MR, and some of the microbleeds, of course, they are only visible in the MR and not that much on the CT, which we're mainly using, of course, in the acute phase. So is it efficient in everybody? Intravenous thrombolysis, yeah, there are again this pooled analysis, and we already saw that over different time windows with a decreasing efficiency, yes, but it's still efficient. Also, age is important. It's also efficient in elderly patients. So during the first studies, you had an upper age limit for patient inclusion, and accordingly the guidelines are following those inclusion criteria, and we're stating that in elderly patients we do not have data, and that's a relative contraindication. This has changed now, and again also with the broad spectrum of severity of stroke of NHSS. So for the time being, the treatment approach for acute ischemic stroke is time and location dependent. Intravenous thrombolysis is a standard of care for all eligible patients, especially with peripheral intracranial occlusions. And endovascular therapy plus minus intravenous thrombolysis, of course, is the standard of care for all patients with large vessel occlusions. So thank you very much.
Thank you. It was a very comprehensive survey. And I have questions for you here. That's some evidence that you can safely lyse on warfarin. I mean, this is not the correct question I have here. I mean, that's something different what I have here. Sorry. I mean, again, some evidence that you can safely lyse on warfarin or the anticoagulation therapy. If mechanical thrombectomy occurs in absence of IV thrombolysis or TPA, is there evidence outcome compromised?
So you mean if a patient has oral anticoagulants and we go for endovascular treatment?
Yeah, I mean, yeah, anticoagulation.
there is no clear evidence that there is an increased bleeding rate. So oral anticoagulants are for sure not a contraindication for endovascular treatment. Of course, as you of course have to keep in mind, patients under oral anticoagulants, of course, they have a reason for that. They might be more elderly, they might be more comorbid, and so on. So this will more influence also the patient outcome. But I'm not aware of any data showing that the risk of the procedure as such is increased.
Yeah, I mean, there is, I mean, in some areas they don't have available mechanical thrombectomy, and that the only thing that is the IV thrombolysis. And we know that these patients, this group of patients who have already been on anticoagulation, which is effective at the time of stroke, they do worse in comparison to the whole population. So somehow they are compromised, and that might be. But I mean, still, the indication is, and there are some antidotum to drug for direct anticoagulation. So we can use these and then use just a regular protocol.
Yes. The problem always there is you need to have the laboratory examinations. There are some point of care tests, but it's not available everywhere. So it takes time until you get the laboratory measurements, and then you have to have the antidote. Yes. Yeah. And again, in those patients, usually they have comorbidities, of course, and the comorbidities, of course, are also important prognostic factors. I come back to this point in my next talk, because we have to separate those patients from who are ineligible for intravenous thrombolysis and going for mechanical thrombectomy from patients who would be eligible for intravenous thrombolysis, but we skip it for whatever reason and go directly to mechanical thrombectomy. These are different patient populations in terms of comorbidities, and therefore also in terms of clinical prognosis.
And there is a reverse situation. If you have, I mean, available mechanical thrombectomy, there was several studies which studied the possibility to skip the IV thrombolysis and go directly to mechanical thrombectomy. Can you just in brief make a comment? What was the conclusion of these studies?
This will be the topic of the next talk, okay, which I call the off-label use of intravenous thrombolysis, and probably also the not use of intravenous thrombolysis. So I will go into detail into this topic in the next talk.
All right. So thank you now, and we will be back with you in 30 minutes again. And now we will switch to Ostrava, and we have here Ondra Volny, who is a neurologist, and he will speak about the medicamentous therapy in the stroke prevention. So Ondra, can you hear me, please?
Yes, I can hear you.
Oh, perfect. So good morning to Ostrava, which is in North Moravia, part of Czechia, and please go ahead.
Okay, thank you for having me. It's my pleasure to be a part of EXMINT this year, even though it's still online. The topic of my presentation is medical management of stroke, and I will focus on secondary stroke prevention. So let's dive in. I have nothing to disclose. The objectives of my talk will be to understand the role of platelets in ischemic stroke. Also, I will briefly talk about the mechanism of action of different antiplatelet drugs, and also a little bit about anticoagulation, because I know that anticoagulation is the topic of subsequent talks. Another topic of my presentation would be the concept of the secondary stroke prevention in a non-cardioembolic TIA or minor stroke, and also I will focus a few slides on secondary stroke prevention of non-cardioembolic major strokes. We will discuss the benefit of dual antiplatelet therapy in TIA and stroke prevention. I will briefly talk about the concept of triple therapy, which was studied and which is also studied right now. And I will briefly talk about the major clinical trials, and also because we have some new recommendation how to prescribe statins for our patients after strokes. So just a brief pathophysiology, what is happening if there is some disease of endothelium or atherosclerosis. So normally platelets represent an interface between hemostasis, immunity, and inflammation, especially in atherosclerosis. Healthy endothelium normally expresses CD39 and CD73, and these enzymes break down the prothrombotic ATP and ADP into anti-inflammatory adenosine, thus preventing platelet activation and subsequent aggregation. Healthy endothelium normally produce nitric oxide and prostacyclin, and these small molecules lead to decrease of intracellular calcium, and also they suppress conformational change of glycoprotein 2B3A, which is required for binding to fibrinogen. And if we talk about prostacyclin, so prostacyclin normally inhibit platelet function by elevating cyclic AMP levels. What happens if there is endothelial injury? So endothelial injury leads to platelet adhesion. The first thing what's happening, it's uncovering of multiple proteins, especially collagen and von Willebrand factor. And affected endothelial cells produce endothelin, which leads to activation of other enzymes and increase in ADP, thromboxane A2 and thrombin, and platelet aggregation. And subsequent platelet recruitment, and again, more and more aggregation. As you can see here, multiple proteins and multiple epitopes on the surface of platelets are involved into this process, especially glycoprotein 2B3A, and I will be talking a little bit about desintegrins or inhibitors of glycoprotein 2B3A, and also glycoprotein 1A2. This is just a summary slide for you. I know that this one is super busy, but this is just a brief overview and summary of different targets of antiplatelet medication we use in stroke, or we also use in stroke-related intervention. The most common are aspirin, and I will talk about aspirin. Others are clopidogrel or ticagrelor, and as you can see in the red and blue windows, these drugs affects different processes and different pathophysiological steps of platelet activation and platelet aggregation. This is just highlights of most commonly used antiplatelet drugs in secondary stroke prevention. So I will be talking about these top 3 drugs we use in secondary stroke prevention, which is aspirin, clopidogrel, and ticagrelor. As you can see here, aspirin and clopidogrel are irreversible drugs. They irreversibly block the function of thrombocytes in comparison to ticagrelor, which is a reversible inhibitor of ADP P2Y receptor. All of them are very rapid in absorption, and some of them might be administered even intravenously, like aspirin. Aspirin also reaches the peak plasma levels within 30 minutes. I also summarized the loading dose of the medication we usually use in everyday clinical practice. What is also important, some of us are resistant to drugs, and especially the clopidogrel resistance is pretty common in people of Asian origin. I also summarized the major clinical trials which studied these drugs. If we talk about aspirin, so early aspirin therapy after stroke lead to an absolute reduction in the rate of recurrent ischemic strokes by almost 1% and reduce the rate of death or dependency by 1.3%, which is the result of MAST-1 trial, which was published in 1995. We have some strong evidence about clopidogrel as very potent antiplatelet medication, and strong evidence that long-term use of antiplatelet monotherapy, aspirin or clopidogrel, results in 13% relative risk reduction of ischemic stroke, MI, or vascular death. And some of the new trials, Socrates and Thales, which were published, so ticagrelor, which was studied in Socrates trial, and this trial was published in 2016, proved that ticagrelor was not superior to anopirin for secondary stroke prevention. It was a composite outcome, but post-hoc analysis showed some superiority in patients, especially with carotid disease. And Thales trial, which was published in 2020, the risk of the composite of stroke or death within 30 days was lower with ticagrelor aspirin. So it was a combination, it was dual antiplatelet medication about patients with mild ischemic stroke. So usually patients who are not treated with IVT, with NIH stroke scale less than 4 or less than 5, or high-risk TIA. But the incidence of disability did not differ significantly between the two groups. So in following slides, I would like to talk about short-term secondary stroke prevention and long-term secondary stroke prevention. If we use the term short-term secondary stroke prevention as neurologists, we usually mean the period of time between 3 to 4 weeks. And the period of time which is extending 4 weeks is long-term secondary stroke prevention. The major trials, breaking trials, which proved that secondary stroke prevention in high-risk TIA or minor stroke with dual antiplatelet therapy is effective were Chance, Point, and Thales trial, all of them published in New England Journal of Medicine. This is just a summary table summarizing these trials. As you can see, these trials were published between 2013 and 2020, so it's just a few years since revelation of these trials, and all of them prove that short-term secondary stroke prevention with dual antiplatelets therapy in minor strokes and TIA is effective and reduce the risk of subsequent stroke or subsequent major stroke. If we look at the Chance trial, so the primary outcome was strokes, and you can see that there was almost 35% risk reduction of stroke, and the secondary outcomes also significant were a composite outcome of stroke, MI, and death from cardiovascular causes. This is the hazard ratio. So if you take a look on this graph, you can see that the combination of clopidogrel and aspirin lead to reduction of subsequent major stroke in the group of patients on dual antiplatelets medication. And if you look at the beginning of the graph, so you can see that the highest risk, and we know this also from the epidemiological trials, so the highest risk of subsequent stroke in high-risk TIA or minor strokes is within first 5 to 7 days, as you can see here. Point trial was another trial which also proved that combination of two antiplatelet medication is effective, it's safe, and reduce the risk of subsequent stroke. In terms of outcomes, so the primary outcome in Point trial was a composite outcome, and ischemic stroke was a secondary outcome. If we take a look on outcomes of Chance and Point trial, you can see significant risk reduction of subsequent stroke. So this is just a comparison of these trials. And Thales trial published in 2020 also focused on stroke and death as outcome of the trials. And you can see that again, the combination of ticagrelor and aspirin was effective, reduced the risk of stroke, and was also safe. This trial involved many patients. You can see in the group of patients with ticagrelor and aspirin, it was over 5,500, and the same in the aspirin group. And again, the hazard ratio, statistically significant risk reduction of subsequent stroke in dual antiplatelet medication group. And just for you, the number needed to treat was 92. So 92 patients need to be treated with dual antiplatelet medication to prevent one major stroke. I would like to point out that the exploratory outcomes have not been adjusted, so we cannot make clear conclusions from these analyses, but this trial was very important for secondary stroke prevention. These are the take-home messages for you if we talk about short-term dual antiplatelet medication. So what is the timing? We should initiate dual antiplatelet medication as soon as possible. If the patient has a TIA or minor stroke and has no TPA, we can start the medication within few hours. What is the sufficient loading dose? Aspirin 160, clopidogrel 300 or 600, and ticagrelor 180. The duration of dual antiplatelet medication in this group of patients is up to 4 weeks. And after that, it's enough to follow, or it's enough to stay on aspirin or clopidogrel monotherapy. So what is the best single antiplatelet therapy for long-term ischemic stroke prevention? So if we talk about patients who were on dual antiplatelet therapy and then we want to continue. So I would like to point out that aspirin and clopidogrel are almost similar and they are used worldwide. But we also have some data from individual patient data network meta-analysis, which was published in 2019 in stroke. This meta-analysis involved over 40,000 people, 6 RCTs. Most of them you are very familiar. And they compared commonly prescribed antiplatelet agents. Their outcome were different: vascular events, ischemic events, and also safety outcomes, which in case of antiplatelet medication, of course, is bleeding and intracranial bleeding. And most of the patients were followed up for almost 2 years. If you look here, I would like to point out just a few things. So most of the trials started the antiplatelet medication within months, so not within a few hours as we used right now in secondary stroke prevention of TIA or minor stroke. But these data are more for patients who need subsequent long-term secondary stroke prevention. And if we look at treatment effect estimates and efficacy and safety, you can take a look on combination of aspirin and clopidogrel. So if we continue on this medication for a long time, which is sometimes, or which is used and recommended in patients with MI and stenting, so in myocardial infarction patients, so these patients, even if they don't have a stroke, has increased risk of major bleeding, which was also proved in this network meta-analysis. And if we take a look onto this graph, so based on this meta-analysis, clopidogrel showed a favorable balance between efficacy and safety across a wide range of patient subgroups, including patients with comorbidities, including patients with higher BMI, and also with history of MI or other vascular events. But in clinical practice, if we continue on monotherapy right now, I would say that we decide patient by patient if we use aspirin or clopidogrel. So another topic I would like to just briefly talk is short-term triple antiplatelet therapy. So there was a trial published in Lancet, studied if in this group of patients with TIA or stroke, if there is a benefit of triple therapy, which was a combination of aspirin, clopidogrel, and dipyridamole. As you can see, the randomization was within 48 hours, and TPA, thrombolysis, was not an exclusion criterion. Primary outcome was recurrent stroke or TIA within 3 months. And there was no difference in frequency of stroke or TIA, but there was a significantly increased risk of major bleeding, even intracranial bleeding. So take-home messages for you if you think about triple antiplatelet therapy. So in 2022, it's not recommended for short-term use, so less than 4 weeks after stroke or TIA. It's not recommended for long-term use in stroke, and trials with triple therapy in secondary stroke prevention are ongoing, but they use different drugs. And I will be talking a little bit about oral factor 11A inhibitors. Maybe you heard about asundexian or milvexian. So this is the coagulation cascade. So it's one step before activation of factor 10 to factor 10A, which we target with NOACs or DOACs, as Pasquale talked in his talk before me, apixaban, rivaroxaban, or edoxaban, and thrombin, which is affected by dabigatran. So right now we have 2 studies published on dual pathway inhibition. First of them is axiomatic SSP trial, which was phase 2 randomized trial using milvexian, so oral factor 11A for secondary stroke prevention in patient receiving aspirin and clopidogrels for 21 days. And the milvexian group failed its primary endpoint, which was a composite outcome, including vascular events. Another trial, which was already published, is Pacific Stroke trial, which included over 1,800 patients. It was a 2B trial, randomized, double-blind, with dose-finding scheme, and tested again factor 11A inhibitor asundexian for secondary stroke prevention. And there was a post-hoc analysis that asundexian 50 milligrams daily provided superior protection against the composite outcome of recurrent stroke and TIA relative to placebo, especially in patients with atherosclerosis. And this is what we know from animal studies, that factor 11 is involved in atherosclerosis and atherosclerotic strokes. So just a summary for you: for short-term antiplatelet therapy, we have evidence that there is a clear benefit of dual antiplatelet therapy, aspirin and clopidogrel, for 21 days or up to 28 days in secondary prevention of non-cardioembolic TIA or minor stroke. Right now, the triple therapy is not recommended, and major clinical trials were published in New England Journal, Point, Chance, and Tallis. Long-term non-cardioembolic stroke prevention, monotherapy with aspirin or clopidogrel is enough, and major clinical trials published in early 21st century, Capri, Charisma, and Match were the major trials. Now, another topic which we should discuss is the hypolipidemic treatment. Again, especially in patients with proved atherosclerosis, with the history of TIA or stroke, we should treat the patients with hypolipidemic drugs. Right now, it's recommended to target the LDL under the 1.8 millimole per liter. We have evidence from multiple trials. First was the Sparkle trial, which showed that atorvastatin high dose 80 milligrams or rosuvastatin 20 milligrams plus diet lead to lower incidence of recurrent stroke in patients with carotid stenosis. Another trial testing different drug called ezetimibe treats stroke to the target, published in 2020 in New England. If the statin therapy in combination with diet is not enough, we should add ezetimibe to this medication to again lead to the target LDL. And we also have evidence from Fourier trial, which was not primary focused on patients with ischemic stroke, but right now we have very potent medication called PCSK9 inhibitors, which are monoclonal antibodies, and they lead to very, very significant decrease in LDL, even under 0.8 millimole per liter. I will just talk briefly about the oral anticoagulants, DOACs, which is the secondary stroke prevention in cardioembolic stroke. So if we prove atrial fibrillation, right now we have 4 very potent drugs and very similar in their efficacy and safety: apixaban, dabigatran, edoxaban, and rivaroxaban. As you can see here, most of them are direct inhibitors of factor Xa, and they have different dosing schemes and different, let's say, different pharmacodynamics and pharmacokinetics, but are very important drugs in secondary prevention of cardioembolic strokes. We have some data from the past. The first trial comparing NOAC with aspirin was Everose. It was the superiority trial and proved that there is over 50% risk reduction of stroke or systemic embolism in patients on apixaban, but the risk of bleeding was not increased even in case of intracranial bleeding. So for you, apixaban is more effective in AFib stroke prevention than aspirin. So in patients who had a stroke, who had atrial fibrillation, they should be treated with apixaban. Also, there was another trial called Aristotle, which compared 2 anticoagulation drugs, apixaban and warfarin, which was used in the past and which is also used right now. And this trial, which was designed as a non-inferiority trial, showed similar rates of ischemic stroke. So both these drugs are efficacious, and the efficacy is pretty similar, but in case of apixaban, there was significant reduction of hemorrhagic stroke and significant reduction of major bleeding in comparison to warfarin. So this is the evidence that we should be using apixaban over warfarin in AFib stroke patients. These are just highlights. NOACs are more effective than aspirin in secondary stroke prevention in patients with atrial fibrillation. So in patients with atrial fibrillation, we have to use NOACs, and they are at least as effective as warfarin in secondary stroke prevention and in prevention of systemic embolism. And based on patient characteristics, we can, let's say, customize the treatment. Let me talk just briefly about glycoprotein 2B3A inhibitors because they might be used in some specific situation. So glycoprotein 2B3A antagonists or disintegrants are drugs which were synthesized based on venom of these snakes. So tirofiban or agrastat, it's a small molecule, it's a reversible inhibitor with a pretty fast onset of action. It's excreted by kidneys, and if you want to reverse the drug, you have to discontinue the drug. So we have some evidence from trials in acute coronary syndrome which studied different loading dose, and then continual infusion in patients with acute coronary syndrome, in patients who were managed medically, and also patients undergoing PCI. So right now we have evidence in MI patients, not in the stroke patients. There were some trials focused on a combination of tyrofibin as glycoprotein 2B3A inhibitors and IVTPA alteplase. But this trial was terminated prematurely. You can take a look on the trial called Mr. T. The primary efficacy outcome was MRS 0 to 1, and safety outcome was symptomatic bleeding. So this trial was terminated, and we don't know the results yet. There is also a registry which is focused on IA, intra-arterial administration, or tyrofibin in patients who are treated with EVT. It's a prospective registry in Germany, and they use tyrofibin in case of intracranial stenting or in multiple thrombectomy passes. This is just a registry. It was published in 2013. You can see that the number of patients was pretty low, and the incidence of fatal ICH was relatively high. But the dose of IA tyrofibin was not specified in this paper. So how about using IA tyrofibin after failed EVT? There was a registry study in China, and they administered low-dose IA tyrofibin in patients with residual thrombus after AVT, and again there was intracranial bleeding as the primary outcome. They didn't show significant increase of intracranial bleeding in this cohort, and you can take a look on this publication. But right now, IA tyrofibin is not recommended outside of the clinical trial. Eptifibatide, integralin, again, it's a reversible inhibitor. It's a small molecule with relatively, again, fast onset of action, and it's excreted by kidney. We have, again, some evidence from acute coronary syndrome trials and a non-STEMI infarct. Again, these trials studied different doses of eptifibatide. In case of ischemic stroke, there are 3 trials, CLEAR, CLEAR-ER, and CLEAR-FDR trials, which combined TPA with eptifibatide, so clinical trials. And there are also ongoing trials of eptifibatide and TPA, and eptifibatide and endovascular treatment. So the MOST trial, multi-arm optimization of stroke thrombolysis, is still recruiting. The results were not published yet. And EPOCH trial, the eptifibatide in EVT treatment, it's recruiting, but the status is unknown. So what current guidelines mention about efficacy of IV glycoprotein 2B3A in ischemic stroke? So their effect is not well established, and we should not use this medication outside of the clinical trial. And in ESSO guidelines published in 2021, eptifibatide has some RCTs with reduced doses of IV alteplase. So the dose of IV alteplase was not 0.9 per kilo, but it was less than 0.6. And there was no increase in ICH, and tyrofibin has no RCT as an adjunctive therapy to IV alteplase or in endovascular treatment of stroke. So key points: current studies are underpowered, and we should not use the treatment outside of the clinical trial, but tyrofibin and eptifibatide may have a role in treating the reocclusion during EVT, especially in patients with acute intracranial stenting or angioplasty, or in emergent carotid stenting. So thank you for your attention. It was my pleasure to be here. Thank you, Professor Krajina, for inviting me, and I would be more than happy to answer all of your questions. Thank you very much.
Okay, thank you. It was a fantastic survey. And I have here a couple of questions regarding the resistance. Any of these studies look at whether patients were resistant to aspirin or clopidogrel?
I'm not aware about the aspirin resistance, but I'm pretty sure that the trial studying clopidogrel, which was focused on Asian population, studied the genetics of cytochromes which are involved in metabolization of clopidogrel. So if there is a question on this, and this is my email, so I can send the paper with some highlights.
Okay, thank you. Another question: we had a company offer equipment to assess for ACA and clopidogrel resistance for our lab. Is anyone using this in clinical practice? Stroke.
So yes, so right now we don't use this as a, let's say, in all of our patients. Let's say that if we have a patient with non-cardioembolic TI or minor stroke, we start with dual antiplatelet medication. We can measure if there is a significant decrease in anti-aggregation activity. I agree, but in our center, we don't do that right now. It's not recommended by guidelines. It's useful, let's say, in patients who has stroke recurrence on dual antiplatelet medication. So when I measure if there is a resistance, it is in a case that I have a patient who is on dual antiplatelet medication and has a stroke.
Okay, otherwise it might be used these, laboratory machines before the intracranial implant, the flow diverter stents, and that's something which we consider today as a mandatory. And just a brief comment to the eptifibatide. It's a reasonable cost, maybe at the same as the agrastat or tirofiban, and we treat or use this in case if we have any fresh thrombus occur during our neurointerventional procedure. So I think I strictly recommend this and encourage everybody if got the peri-procedure clot inside the intracranial artery. This is the solution and the treatment with very low frequency of complications or almost no complications and very high effect. Okay, so thank you very much, and have a nice day to Ostrava, Silesia.
Thank you very much.
Thank you, and we will switch back to the St. Gallen, to Pascal Mordassini. Okay, Pascal, can you hear us, please?
Can you hear me?
Yeah, now yes.
I can start my slides.
No. In between, if I can, I have a question for you regarding the streptokinase. Can streptokinase be used in place of RTPA, especially if there is a cost is a bigger barrier? Have you any experience with streptokinase?
No, but funny enough, I mentioned a little bit the milestones of stroke treatment at the beginning of my talk. I mean, the very first try with a fibrinolytic drug was streptokinase, I think already in the 50s or 60s. But since then, I think it disappeared.
I mean, we used it during the 90s of last century for local thrombolysis and the peripheral arteries.
I think in stroke, I think it's funny enough. I think there is even, if I remember right, that there is a paper from the 50s or 60s looking at streptokinase in stroke. I think this was one of the first papers or first drug that has been tried to be used in ischemic stroke.
And if there is a contraindication of IV RTPA, would you consider the intra-arterial RTPA? I mean, today everybody prefers mechanical thrombectomy, and consider the intra-arterial as an additional adjunctive therapy if something goes wrong or for peripheral embolization only.
Yes, of course, mechanical thrombectomy, of course, would be the first choice, but again, not every vessel can be treated like that, and if it's a significant deficit, intra-arterial treatment, I think is still valuable. It tends a little bit. There is not a lot of data. We used in Bern intra-arterial treatment with urokinase quite often. In patients after intravenous thrombolysis, or even in patients who had oral anticoagulants in a reduced dose, and so far we didn't have major issues, but this is also absolutely off-label, and there is only few data on that. But strictly spoken, if you go for the PROACT 2 criteria, for example, for intra-arterial thrombolysis, of course, oral anticoagulation would be a contraindication.
Okay, thank you. So go ahead if you are ready with on and off-label IV thrombolysis treatment.
Yes. Okay. Thank you very much. So I continue now with the off-label topic regarding intravenous thrombolysis. And I already mentioned it, there are several limitations of intravenous thrombolysis. There is this rapidly decreasing efficacy with time. And this is quite impressive if you're able to administer intravenous thrombolysis within 90 minutes. You have a number needed to treat of 4.5. If it's between 180 and 270 minutes, it's already the number needed to treat is already more than 14. So this is definitely a very important limitation of intravenous thrombolysis. The second major limitation is, of course, poor declinization rate in large thrombi. This very famous paper from the group from Kiel, from Germany, where they showed that if a clot is round about 8 to 10 millimeters in length, the risk of having this clot dissoluted and to achieve recanalization, like in a clot like that, with intravenous thrombolysis is 0 or close to 0. And of course, the further limitations we talked about, relative and absolute regarding time windows, contraindications, comorbidity, and so on. So for the time being, we have seen this slide. Intravenous thrombolysis is the standard of care in all eligible patients, especially, of course, in peripheral vessel occlusions and endovascular treatment, plus minus intravenous thrombolysis in large vessel occlusions. So the question is, of course, is intravenous thrombolysis always necessary? And is it beneficial prior to mechanical thrombectomy? And that's what we call bridging. And yes, there are arguments in favor of bridging. RTPA can be started earlier. So that's the drip and ship model. So a patient is first transferred to a peripheral hospital, a peripheral stroke unit. The diagnosis is made, IV TPA is started, and then the patient is secondarily transferred to mothership patient. These are the so-called drip and ship patient, and their intravenous thrombolysis has been shown to be efficient. So now we're not talking about those patients primarily because there the effect is clear, but we're going to talk about the patients who are directly referred to a mothership center, to a thrombectomy center. It may facilitate recanalization. There might some kind of enzymatic digestions. RTPA may improve reperfusion of small vessels after mechanical thrombectomy. And mechanical thrombectomy may be delayed or not be feasible. So at least you have intravenous thrombolysis on board and you could treat your patient already in a way, in case, for example, your angiosuite is broken or transport. There are some transport issues, for example. However, there are also arguments against bridging. We have talked about the limitations of intravenous thrombolysis, the increased risk of hemorrhage. It may also produce thrombus dislocation, so transform a more proximal, more easily treatable occlusion pattern by endovascular means into a more peripheral, more difficult to mechanically treat occlusion pattern. RTPA, of course, is also costs money, and it can also cause other life-threatening complications than intracranial hemorrhage, like angioedema, which fortunately are rare, but they may occur. And of course, RTPA can delay endovascular therapy in some patients. Of course, we're trying not to do so that everything runs smooth. So that's what I just explained before. We are now not talking about the drip and ship patient that are transferred from a stroke unit to a stroke center, but we rather talk about the so-called mothership patients. So those patients who are directly referred to a stroke center, the diagnosis is established, you start your IV treatment, and then you go directly to the angio to mechanical thrombectomy. And here's the question indeed, whether we cannot skip intravenous thrombolysis and go directly to mechanical thrombectomy. And there are three major arguments to discuss that. So what's the pre-interventional reperfusion? What's the reperfusion success? And what's the symptomatic intercellular hemorrhage with or without intravenous thrombolysis? Let's talk about pre-interventional reperfusion. There is data in the literature looking at the prevalence of reperfusion before mechanical thrombectomy in large vessel occlusion, and it's roughly about 10%. However, in this study, they put everything together, so there was no distinction between occlusion site, thrombus length, whether this was a drip and ship or mothership patients, but roughly about 1 in 10 cases show some kind of reperfusion. We also see that there is a time dependency. We looked a couple of years ago at our patients in Bern, and of course, in the mothership patients, where you have even fewer time for the drug to work, the rate of reperfusion in ICA occlusions is very low. It's a little bit higher in M1, and of course, it's getting much higher in more peripheral occlusions. And you can also see in blue, the drip and ship paradigm, that there is quite efficient, especially even in M2s, 12%, and then of course in the more peripheral lesions. So we also looked at what happens, what do we mean whether there is reperfusion after intravenous thrombolysis. So there is no, we don't know, we roughly knew how much it occurred, but what is the quality of these reperfusions? And we looked at the overall change of occlusion site in more than 700 patients, and around 10% of patients in this mothership patients, the occlusion site changed after the application of intravenous thrombolysis. In around 3%, it just moved a little bit more distally, but it was still an M1 occlusion and still TK0 or TK1, so not a big change. In around 6%, yes, there was a better reperfusion success, at least 2A. Around half of them were even TK2B, so it's around 3% of cases. And in around 2% of patients, we transferred the occlusion pattern in a worse occlusion pattern after administration of intravenous thrombolysis. So what about the reperfusion success if we add intravenous thrombolysis? And here again, that's what we tried to emphasize before. We have to distinguish between two groups of patients because they're different. The patients who would be eligible for intravenous thrombolysis, but we skip intravenous thrombolysis and go directly for mechanical thrombectomy, or patients who are ineligible for intravenous thrombolysis and we have to go directly for mechanical thrombectomy. And we did this meta-analysis and we saw that overall there was a non-significant different rates of successful reperfusion, but there was a non-significant trend for higher rates of successful reperfusion in the intravenous thrombolysis eligible patients who went for direct mechanical thrombectomy. So if there is no difference in overall reperfusion, so was there a difference in TK3 rates? Because maybe intravenous thrombolysis was helping nevertheless to reopen residual peripheral occlusion. But here in this data at that time, we didn't find any difference. There was no effect. So what about the complications, symptomatic intercellular hemorrhage? And here also we have to keep in mind that there are even other factors that are related to symptomatic intercellular hemorrhage and that are risk factors: cardioembolic stroke, poor collateral status, the delayed treatment, larger infarct volume measured as, for example, with the aspect scores, patients with diabetes and with high NHSS. And also here, there was a non-significant trend overall for higher rates of symptomatic intracranial hemorrhage with intravenous thrombolysis and mechanical thrombectomy, which is kind of what we would expect. I mean, we give a thrombolytic drug, so this might increase the bleeding rate. So now we looked at all the surrogates of pre-interventional perfusion, the perfusion success, and the occurrence of intracranial hemorrhage. But at the end, what counts is the outcome. So what about outcome? Was there any significant difference in outcome in the literature to be found? And we saw that there was overall a non-significant trend for lower rates of functional outcome in patients going to direct mechanical thrombectomy. And there was a non-significant trend for low rates of functional outcome in ineligible patients. Again, these are patients that are different because they have a different risk profile. They are sicker, they have more comorbidities, atrial fibrillation and previous strokes are more frequent in this patient group, and of course this is affecting prognosis. So what we ended up is with an individualized treatment decision. So in mothership patients, again, time dependency of intravenous thrombolysis is an issue. Large thrombi, such in carotid T, we know that there is a low efficiency and there might be a risk of perfusion worsening if the carotid T thrombus is splitting up and causing now an embolic shower or several M2 or even ACA occlusions. We have talked about other factors that increase intracranial hemorrhage. So in patients who have in addition microbleeds, striatal infarction, diabetic or large infarcts, maybe this is a reason to withhold intravenous thrombolysis. And in tandem occlusions, where we are very likely to stent and need other anticoagulation or antiplatelet drugs. So at the time when we put this together, there was kind of a clinical equipoise because there were some hints that this might not be useful. So there was a clear need to further investigate that. And why is it relevant? So if we skip intravenous thrombolysis, maybe we can achieve the equal equalization results. We may decrease the rate of hemorrhages. We may avoid thrombus migration. We may even have the similar or even better outcome. And of course, we can also reduce the cost by skipping RTPA. And as you know, these questions have now been addressed in several randomized controlled trials, looking at direct mechanical thrombectomy in mothership patient compared to intravenous thrombolysis and mechanical thrombectomy. These are 4 studies here in Europe, performed in Europe and in Asia, in Japan. You can see the studies are different. Also, from terms of the patient population, of the ethnicity, but also in terms of the administration dose of IVTPA. In Japan, IVTPA is just approved for a dose of 0.6 compared to Europe and China, where it's 0.9 milligrams per kilogram. You also see a difference in the occlusion side, and you also see some difference in the time metrics between those studies. But it has to be looked at and in a meta-analysis. And if we look at those studies together, the 90-day functional outcome or functional independence was not significantly different with EVT alone versus intravenous thrombolysis plus endovascular therapy. And the problem also with these studies is that some of them were designed as a superiority study and some of them were designed as non-inferiority studies. And you have to define those margins where you apply statistical significance. And here you can be more strict and less strict depending on how you set these margins. And the risk difference for function independence was around 1%. And of course, it depends on how strictly you apply this non-inferiority margins, but it was not a lot. And also the risk difference between endovascular treatment alone versus IVTPA plus endovascular treatment was also 1% for modified Rankin scale 0 to 1, and also for cerebral hemorrhage. So this meta-analysis suggests that endovascular treatment alone is non-inferior to IVT plus endovascular therapy for several, but not for the most stringent non-inferiority margins. So it depends what effect you expect. If you take the strict ones, non-inferiority is not necessarily proven. And there was a fifth study, SWIFT Direct, which I'm mentioning a little bit more explicitly because we were involved in that at the time in Bern. It was a study that was organized by Bern, and these were the results looking at the primary outcome, and we were very astonished. We had a clear, significant difference between the two groups. The bridging group was significantly did significantly better in terms of clinical outcome compared to the direct mechanical thrombectomy group. So here we have a clear hint that the bridging therapy is better. And we can also, we were asking, so why? I mean, we already suspected that it's not because of pre-interventional reperfusion. You can see it's only 1% or 2.5% in the IVTPA, so this is not the reason. But we had an extraordinary high reperfusion rate, successful reperfusion rate in this study, 97% in the IVTPA and over 90% in the direct mechanical thrombectomy. So these were very experienced centers with very high reperfusion rates, and again, still low hemorrhage rates. Yes, it was significantly improved with IVTPA, but this is still in the range of bleeding rates, what we know from IVTPA alone trial. So our conclusion was, for our trial, SWIFT Direct did not show statistical non-inferiority of direct mechanical thrombectomy over intravenous thrombolysis plus mechanical thrombectomy. So this was a non-inferiority trial, and we failed to show that. So this trial has failed. Good outcome was high in both treatment arms, with the point estimate in favor of IVTPA plus mechanical thrombectomies, 65% versus 57%. And the pre-interventional perfusion was very low in both treatment arms. Post-interventional perfusion was very high in both treatment arms and was significantly higher in patients with intravenous thrombolysis compared to direct mechanical thrombectomy. And the rates of intracranial hemorrhage were low in both arms, but were significantly lower in the direct group compared to the IVT group. However, even in the IVTP group, they were in the range of what we know from the literature and what we were expecting. So if we summarize all those trials and try to get a conclusion out of it, overall functional outcome was similar, with a slight trends favoring bridging thrombolytics and a significant increase in final reperfusion, roughly an increase in 4.4%. Overall, symptomatic hemorrhages increased roughly by 2% in the bridging group, but that was non-significantly lower. And of course, the workflow is a little bit, of course, not in advantage of IV thrombolysis. You lose some time to randomize a patient, and then you go to thrombectomy. So there's only a short time of intravenous thrombolysis to act. So maybe we even underestimate a little bit the action of intravenous thrombolysis. So pending individual patient data, meta-analysis intravenous thrombolytics retain an important role alongside endovascular thrombectomy. And this was also reflected in the latest recommendations by the European Stroke Organization and EXMINT. So directly admitted patients to thrombectomy capable center for an acute ischemic stroke without 4.5 hour symptom onset who are eligible for IV thrombolytics. The societies recommend that intravenous thrombolysis plus mechanical thrombectomy over mechanical thrombectomy alone. And also the same accounts in an expert consensus in wake-up stroke. So if a patient qualifies according, for example, to the wake-up criteria for intravenous thrombolysis, even if he's first transferred or directly transferred to a thrombectomy capable center, intravenous thrombolysis should be applied. However, as I said, there is some heterogeneity in these studies, and we don't know, we didn't get yet all the answers we were expecting to, because we nevertheless think there are some patient subgroup that might still maybe benefit from skipping intravenous thrombolysis. So what about large ischemic core? We have to look in detail on them. What about the tandem occlusions or where stent is required? They didn't randomize the studies for those patients. What is about the very large proximal occlusions? So we need to have more specific data on this patients in order to be able to further gain knowledge to appropriately tailor the treatment approach. But until then, regarding to the recommendations, we should apply intravenous thrombolysis. And these are the open questions. So who are the specific patients who should and should not receive IVT pain and mother-sheath Zeppelin before mechanical thrombectomy? And now meta-analysis with post-hoc subgroup analysis of those trials are underway, and we're looking forward to the results. Maybe we get some answers for some of those patient groups. Another issue is we talked about intravenous thrombolysis with altiplase and its limitations. So is there another drug available that is maybe more efficient? And there is a very interesting drug, and this is tenecteplase. And tenecteplase is a mutant of altiplase. It's approved for the treatment of myocardial infarction since 2000 by the FDA. And it's interesting for neuro because everywhere in the world, metalase or tenecteplase for cardiological indication is cheaper than altiplase, except for Switzerland. In Switzerland, it's more expensive. So for the rest of the world, from the cost perspective, this might be an attractive dose. But also in the handling of the dose, you can apply tenecteplase as a bolus. You don't need an infusion. That makes it very easy to handle. You know, with intravenous altiplase, you give a bolus, and then you have to do a perfusion of the remainder of the dosage, which makes it a little bit more complicated to handle. There have been several studies now with TNK for the treatment of acute ischemic stroke, and we of course look a little bit especially about the studies including endovascular treatment patient, and this is Extend IA TNK. So they looked at the effect of TNK in patients before undergoing thrombectomy. It was a randomization between TNK and altiplase, and the outcome was, the primary outcome was a surrogate, was the reperfusion success at the first angiographic run. And this study was positive for tenecteplase. It showed a significantly higher successful reperfusion in the first angio run compared to altiplase, and this also transferred to a better clinical outcome. So TNK was superior to RTPA in early rectalization prior to angiography in patients with LVO, and also influenced functional outcome. There have been other studies who looked at TNK with LVO but did not undergo mechanical thrombectomy. And also here we have it seems to be a similar effect, that TNK seems to be more efficient even without mechanical thrombectomy in patients with LVOs. So these are the current guidelines of the American Heart Association. Tenecteplase as a single bolus has not been proven to be superior or non-inferior to altiplase, but might be considered as an alternative in altiplase in patients with minor neurological impairment and no major intracranial occlusion. This goes back to the intravenous thrombolytics trials at the time. And the European guidelines state that LVO-related ischemic stroke patients eligible for intravenous thrombolysis before mechanical thrombectomy. Most experts suggest that tenecteplase could be an alternative. But again, we don't have enough data for that. It's for sure more and more interesting drug, and there are several other studies now running, and we hope to get more information about that in the future. I think in general we should distinguish between two indications for TNK. So if we use it in unselected patients or patients without proven LVO, minor vessel occlusion, and no imaging workup yet, so we don't know the occlusion pattern. There seems to be overall an increasing evidence of non-inferiority of tenecteplase. We will see whether we get more data supporting this. And the second clinical setting is the use in LVO patients potentially undergoing mechanical thrombectomy. And there we have some evidence that tenecteplase is superior to alteplase, and especially if the treatment time or the treatment delay to thrombectomy is very short, for example, as in mothership patients. And also here, an advantage would be that TNK is more practical. You just give the bolus, you go on, you go for mechanical thrombectomy. You don't have to take care about perfusion, the perfusion anymore like in alteplase. So this is a summary, a little bit about the differences. The cost, as I said, in Switzerland is more expensive, but in the rest of the world, it's usually cheaper. It's more convenience. Safety, there are some safety issues. There are studies showing that if you apply TNK in a higher dose, there is a significant increased bleeding rate. If you apply it in the lower dose, it seems to be as safe as alteplase. Efficiency in no LVOs has still to be further proved, and efficiency in LVOs undergoing mechanical thrombectomy, there are some strong hints to be benefit. So thank you very much.
Thank you, Pascal. And I have here some questions. Maybe you already answered them. Is there any difference in the outcome in using alteplase and tenecteplase in patients taken for thrombectomy?
Yeah, there was this randomized trial I just mentioned, and the primary endpoint was the angiographic result at the first angio run, and there was a significant difference, almost double of vessel reperfusion. And there also it transferred into a better clinical outcome because you have a better reperfusion rate, you have a better clinical outcome. So that's so far the randomized evidence. But again, this was not a clinical outcome in this study was not the primary outcome, but we have some hints that this might be the case. One issue is still the dose, as I mentioned. There are two different doses applied in the studies, a higher and a lower. And it seems to be if you apply the higher dose, the bleeding rates increase significantly, which of course would have a negative effect on clinical outcome.
Does using thrombolysis increase the risk of arterial complications at the time of mechanical intervention, especially in gaining arterial access?
You mean in terms of catheterization or in terms of increased
puncture,
bleeding
the groin and
at the puncture site?
Yeah.
Honestly, I don't have data on that, but I don't think. I mean, we puncture patients under intravenous thrombolysis with 8 or 9 French in the groin. So I'm not afraid of that. I cannot give you any numbers on that, but I don't think it's significantly high. I think this was never a big issue.
Yeah, I mean that's exactly the same experience. I mean, about 60% of our patients in my hospital are given the IV thrombolysis, and we, I mean, like to use ultrasonography to guide the puncture, and use the 9 French sheath since the aspiration today is the #1 for that. So I mean, regarding the other complications of angiography, I don't see the difference in this. And we have established that time is brain. Doesn't that loss of time undergoing IV thrombolysis increases the core infarct? So is there any delay because of IV thrombolysis? I mean, that's should not be any delay.
No, of course, intravenous thrombolysis should be, of course, administered as fast as possible. I mean, there are some centers where patients are already triaged before they come to the hospital, then they're going to be transferred directly in the CT scan and not somewhere in emergency. And basically, when they did the CT scan, they have excluded hemorrhage. They already start intravenous thrombolysis, giving the bolus, so it can be very quick. But of course, intravenous thrombolysis, waiting for a nurse, being able to prepare intravenous thrombolysis, and then preparing the perfusion, of course, should not be delayed, should be well organized. In Bern, we had a dedicated stroke nurse who was following the patients from the emergency, and she had everything in a rucksack and everything ready, so that the intravenous thrombolysis could be applied immediately.
If you have a peripheral distal thromboembolism after mechanical thrombectomy to peri-Rolandic area, would you use the intraarterial RTPA even if the patient already was given the IV thrombolysis? And approximately at which doses, at which boluses?
Yeah. I think this is if this is a really an eloquent branch, as you mentioned, and if you think I cannot get them mechanically and it's too dangerous, I think intra-arterial administration of thrombolytics is still a good approach. It gets a little bit of revival nowadays. I have never used RTPA for intra-arterial thrombolysis. I'm from a center where we use urokinase. So I have no personal experience with RTPA, but you can do it in a reduced dose, for example, half of the dose. We used urokinase in half or a quarter of the normal dose, and with urokinase we didn't have obvious issues. We managed to recanalize around 30% of those patients without increasing bleeding rates, even after intravenous thrombolysis.
Yes. Okay, so thank you. And you have one more lecture today, which starts at noon approximately. So we will be back with you at that time. So thank you. And now we will have a 20 minutes break and be back in 11 a.m. of Central European time here. So 20 minutes break. Hello, welcome back to the second morning session. And we will start with Diana de Souza from Lisbon. So, Diana.
Hello again.
Okay, I can hear you.
Can you hear me?
Yes. Yeah, and now
Okay.
even see you. Okay, so
Great.
this is patients referral, triage, and transport from the point of neurologist in the large city.
Exactly. So now we will discuss this very interesting topic of how to organize locally the stroke network. So what is the problem we have? The problem is that we have complex stroke patients, so stroke patients that need specific treatments that are only performed by some trained physicians and teams. And these treatments are a large vessel occlusion, so because you need the interventionalist to do the endovascular treatment, and also an aneurysm repair that you may need. Especially if it is a ruptured aneurysm, you may need emergent treatment by a neurosurgeon or by an interventionalist again, and large malignant stroke in which you may have an indication for decompressive craniectomy, and in that case you need a neurosurgeon and dedicated stroke unit or intensive care that will handle the patient in the next hours. So that these centers that have all these facilities are usually called comprehensive stroke centers, and of course the number of comprehensive stroke centers is much inferior compared with the number of stroke ready hospitals or stroke units, hospitals that have stroke units. So reperfusion therapy, we know that we have come a long way since the 90s when the first thrombolysis treatment started. So before that, actually, there was no specific treatment for patients with stroke. You just, did the CT, did the diagnosis, and patients were left there just, doing some secondary prophylaxis with antiplatelets. So by this point, the outplays, so the thrombolysis started. However, it took really a very long time between the first trials approval and especially implementation of this treatment. So you see the 95, there was this FDA approval, but then still in 2007, less than 2% of all stroke patients receive thrombolysis in the European Union, according to the CITSMOST registry. So very difficult to implement, although it is just an intravenous treatment. And then by 2015, we had the Mr. Clean trial and all the other landmark studies that stopped at the same time and really showed how effective endovascular treatment is. And then we had the second challenge, which was to implement this in a broad scale. So this was performed in some centers, but not in many. And just a few years later, by 2018, we had the new trials showing efficacy, also very similar efficacy up to 24 hours. And now we have all these trials with low aspects, low NIHSS, with different, without the use of advanced imaging. So we are still broadening the indications for endovascular treatment, and probably we will have also distal occlusions, patients with ranking higher than 2, etc. in the next years, which are still being assessed in trials. So lots of patients and increasing number of treatments performed. That's what is seen but also by the markets in the next years to happen. So increasing number of procedures and devices used. We see here again estimations from the companies doing these techniques. Also, thrombolysis, we now have an extended time window since 2019 from some trials that altogether have more or less the same conclusion, that using some kind of advanced image, either MRI or CT perfusion or MR perfusion, we can also select patients for thrombolysis outside of the classical time window. But we need this kind of more advanced procedure. So how should we organize such a complex treatment with the need of advanced imaging, if interventionalists, how should we organize this? So we have some guidelines on how to classify centers. This is from the European Stroke Organization, already from 2018. What is a stroke center? Is the center, the comprehensive stroke center, is this center that has this neurosurgical and vascular intervention. So all the chain of care is possible in these centers. But we need to be fast also for thrombolysis, right? So, and for ICH, we need to have patients treated in the closest stroke center, stroke ready center, because we know that for TPA, as well as for endovascular treatment, the time to treatment is very important. For example, for endovascular treatment, the ERMIS collaboration really showed that for every 9-minute delay in symptom onset to reperfusion, 1% of patients have a worse disability outcome. And you see, it's just 9 minutes. It's a very short time. And just 4 minutes delay between the emergency door and reperfusion, so in hospital time, something that is really dependent on your local workflow, 1% of patients have a worse disability outcome. Just 4 minutes in your own practice means 1 in 100 patients being disabled. So it's really important that we optimize the stroke pathway, both outside of the hospital and within the hospital. And you see here the graph, and it's quite clear that both the mortality and the worse outcomes really increase with time to reperfusion. So even if the patient is within the time window, you really have to be the fastest possible. And if you prefer odds ratio, it's quite clear as well. So we should note that in the ERMIS collaboration, so the meta-analysis of all these landmark trials of endovascular treatment in the early time window, the median symptom onset to groin puncture was 3.8 hours, and the median symptom onset to reperfusion was 5 hours. And I question you if this happens in your center. So this was still the landmark trial, so probably we can improve this. But even in the earliest trials, is this something you can do in your center, or is it that you have worse metrics than this? And so the basic paradigm is that because most patients will not have indication for endovascular treatment, that all patients are assessed in the primary stroke center. You check if the patient has LVO or not, if the patient has indication for TPA or not. And then if the patient has a large vessel occlusion and indication for endovascular treatment, you will send the patient to a comprehensive stroke center. Of course, there are many challenges, and many of these challenges, because the door in, door out, so the transfer to another hospital is oftentimes very difficult, takes a lot of time. Also, sometimes the primary stroke centers may not have the best metrics, and the patient may get really delayed in this process. So there is this idea that maybe at least patients that have a high probability of having a large vessel occlusion, maybe we should send the patient directly to the comprehensive stroke center. But then, of course, the comprehensive stroke center gets lots of patients, and that is challenging also, because then the patient has to go back to the primary stroke center, probably to the stroke unit, if the patient has no large vessel occlusion, no indication for treatment, because it's just impossible to keep all the patients in the large center. Also, you are delaying TPA in these patients because they are not being treated close to the center they are, so they have a long route to the comprehensive stroke center, and so TPA is delayed. So the main advantage of this drip and ship paradigm is really that you have a short time to TPA, and that is important still. This is the next estimation from Jeff Saver on the delay to TPA, and for every 15 minutes delay, you have 4% lower odds of walking independently at discharge, 3% lower odds of being discharged to home rather than to an institution, mortality, hemorrhagic transformation. So really doing very early treatment with TPA is also very important, especially for patients not having large vessel occlusion, which is actually the majority of patients with ischemic stroke. Also, there are several patients, and everybody doing emergency has that experience, that are not eligible either for TPA or for endovascular treatment. And also all the stroke mimics, all the other patients without indication for treatment, if you send all the patients to the comprehensive stroke center, is really a very large number of patients. Of course, you may also argue that, especially in comprehensive stroke centers that do not have the interventionalist on site, that you have to call the interventionalist. If you have a good pre-hospital notification, or inter-hospital notification, so when you receive the call from the other hospital saying that this patient has an indication for endovascular treatment, then you gain some time, because while the patient is being transferred, the interventionalist is also coming to the hospital, and okay, so that's not such a large delay, but still the evidence shows that there is still quite some delay, even in these hospitals that have that you have to call the interventionalist. There is always some delay, even comparing with the other paradigm. So mothership always saves some time for patients with indication for endovascular treatment. Here you can see again data from the Mr. Clean trial, and of course you have randomization here that is not happening anymore, but still there is a delay with inter-hospital transfer. And that was confirmed also in the Stratis registry, so patients from real world data, and you see again transfer 300 minutes and direct 190 minutes, and it's always the same, it's always some delay. And the outcomes will reflect that. So patients coming from another hospital will have a worse outcome than patients coming directly to the stroke center. Of course, there is this possibility of some interaction, so maybe other factors from the comprehensive stroke center and the experience compared with the primary stroke centers, but really, sorry, it's quite clear. Sorry. It's quite clear that at the end, what matters is really time more than anything else. Time from onset to treatment is really what matters. It's not so much that the patient is managed at one center or the other, it's really time to treatment. So how should we organize this? First, we need to test the metrics of the primary stroke center. So it's not the same to send to a stroke center that has good door-to-needle times or worse, not door-to-needle times. So here you can see some models that were designed for specific regions, which is really what makes sense. So this has to be discussed locally. And you see that for patients at these regions in California, the drip and ship is the best option for the red areas, the mothership for the green, and either is the same for the orange ones. And you see that this distribution of colors very much changes according to the performance of the primary stroke center. So if a stroke center, a stroke unit has good time, door-to-needle times, so 30 minutes, then it's still a good either option, or even drip and ship is better in large area. But if the door-to-needle times at the primary stroke center are 90 minutes, which is really very bad, then it's better to just to go to the comprehensive stroke center almost everywhere, even very far regions. So it's very important to know if what are the performance of these primary stroke centers to define the best pathways. And even for more, difficult regions from the geographical point of view, we see here Alberta, so snow and different conditions, but still, and mountains and so on, but still, depending on the time of the primary stroke centers, it gets very green. So mothership is the best option, again, if the primary stroke centers are not performing well. So this is something to have in mind. Then the other aspect to have in mind is how the patient is presenting. So it's quite intuitive that if we have a patient that you really suspect it's a large vessel occlusion, maybe it's better that that patient specifically goes directly to the comprehensive stroke center. However, many scales, pre-hospital scales, have been tested, and still you see that the performance is never optimal and is actually quite similar across all scales. So you always will miss some patients that will go to the primary stroke center but are still large vessel occlusions, for example, patients with low NIHSS, for example, and you will still take patients, for example, with bleeding or clinical picture that mimics really large vessel occlusion but are not a large vessel occlusion. You will still take some of these patients to the comprehensive stroke center without their benefits. So it's challenging, and there is no perfect pre-hospital scale to do this triage. The RACECAT trial was probably the most complex study assessing this specifically, whether it is better to have a mothership or a drip and ship model. They used the scale, which is the RACE scale, which is a nice scale to use for pre-hospital triage. And still, you see that this is the performance of the scale, and that clearly it's with more than 4, it's highly likely that you have a large vessel occlusion. But still, the trial was not able to show very clear differences. But you should note that Catalonia has a very good stroke network. So actually, they have very good door-in, door-out times for patients transferred. And that, of course, is one of the reasons probably why the difference is not so clear. So this is always something that is tested locally and depends on the local networks. So because it's not different in a specific place does not mean it's not the best option in other areas. So it depends on the local metrics, on the local geography, and all the local systems. So this is an interesting study, but it's definitely not an answer that it's valid everywhere. The external validity is quite limited. Then there are another possible strategies. This is an interesting strategy, which is the direct angiography. The direct angiography may happen directly, so a patient comes without imaging, has a clinical picture suggestive of a large vessel occlusion, and you don't do CT, you just take the patient to the angio suite, you do the flat panel CT, and you just check for bleeding, and then you just do the angio. And you see if the patient has large vessel occlusion. So you will do an angiography in some patients without large vessel occlusion, but you gain some time by not performing the imaging. Also, you may do this in secondary transfers, and that we do it quite often. So if a patient has a stable clinical picture and is coming from another hospital already with a diagnosis of large vessel occlusion, in many centers, these patients are taken directly to the angio suite without performing again imaging. It depends also on the time and the door-in, door-out time. So what really matters is to test your local situation, as we were discussing, and you know your local situation. It's always different from the other hospitals, and while we are working, we really feel all the challenges of working in a specific place, and so we are always the best, those working in the field, to know the problems. So I challenge you to think about your local situation. So how speed and accurate is your field triage from your hospital care? One interesting possibility is to train people both in your hospital, but also even pre-hospital people to really to teach them. Every time you receive a call, it's an opportunity for education, and also, of course, courses and specific strategies. And pre-notification, also think how good is your pre-notification and what can be improved in your local center. Also, do you, I ask you, do you have any specific criteria to bypass a primary stroke center? If not, would you consider that, for example, high risk scales, etc., if that makes sense for your local situation? Also, it is important then to think about the in-hospital, so the intra-hospital pathway. So how is your CTA? Is it fast or not? Do you do perfusion? What is your transportation time when you need to send the patient outside if you are working in a primary stroke center? How is your transport? So do you do it with a nurse and the doctor? What about if the patient is doing TPA at the same time? Do you have, the team ready? Do you just need an ambulance? Do you have the ambulance and the team always ready? Have you considered the possibility of shipping the interventionalist, which is another strategy? And there are many things we can do to improve image sharing with the other hospitals is very important, sometimes more challenging than it seems, especially with the new regulations. Also, as I said, to test with the primary stroke center, how good are their metrics, really to have a good communication with the comprehensive stroke center, and improve your transportation. Then, if you work at the comprehensive stroke center, it's very important that you have a well-organized team, that you guarantee that you may have beds if you need more beds with, for example, the intensive care, other departments. If your stroke unit gets full, it's oftentimes that you need help from other departments. How to organize when you send the patient back. Sometimes this is quite challenging. So the patient has no large vessel occlusion, or you don't have beds. So how can you send the patient back? How is it organized? And of course, it's very important to solve these problems, to have a good discussion with the interventional team to improve times, to improve the discussion within the team with the stroke nurses and all the elements of the emergency, and also to talk with the primary stroke centers. It's very important to have a good communication. Teleradiology, image transfer, how to organize the transfer protocols, and the lack of beds. That is very good to have topics for a meeting with the primary stroke centers, just to organize and to keep good communication and all the things flowing, and just to know all the problems. So the primary stroke centers and the comprehensive stroke centers are allies in this treatment. It's crucial that there is this good communication, and also sharing of medical records is very useful. So if that is not happening, is something it's good to promote. Regular teams, as I was saying, is a good thing to organize. Also case reviews, having common registry data, or at least sharing the results of the registry data from all centers. These are all things that can really help to identify the opportunities for improvement, and will help you to have a better system in place. Another thing that can be organized is telestroke. So if your primary stroke centers, if you work at a comprehensive stroke center and you have primary stroke centers that need help or are not performing well, for example, with TPA, a good thing to organize is to have a telestroke network with them. And when they get a patient, if they need to discuss, they can film the patient, they can share the images, they can have your advice whether to do TPA or not, whether to send the patient or not. And that probably after some time, you just don't need it because they learn, and that is very helpful, and there are very good examples of how this can be organized. So just to finish, to share our experience in Portugal, it is a small country, almost 10 million people, really concentrated in the more close to the sea. It's the biggest concentration of people is here. There are not many people here in this region, which is definitely this region has a lack of stroke units and a lack of access to treatment because they are still a bit far from Lisbon, but they have to come to Lisbon for treatment. So in Lisbon, we have not enough interventionalists at one center to do all treatment every day to this very big region up to the south, which is over 4 million people. So we have like a rotation system. We have some comprehensive stroke centers doing treatment at different days. And so this is how it was organized, this rotating system across the different centers around the metropolitan region of Lisbon. But for example, in Coimbra, the situation was a bit different. They have a single endovascular treatment center, and they have a very good telestroke network, and so they help all these centers around, and they all ship the patients to Coimbra after discussion, which is also a very good solution. So you see that it's very important to organize the situation locally according to the available resources and the available metrics. You can have a more drip and ship protocol or more mothership protocol depending on your resources. But what is really important is to keep this professional partnership between the primary stroke centers and the comprehensive stroke centers, because every patient deserves to be treated and with the best level of care. And to do that, you need to discuss and to organize to improve functional outcome at the end. So thank you very much. And again, I'm happy to take any questions. Feel free to send me an email after the course, or if you have any question that you would like to discuss. Thank you.
Okay, thank you very much. And I had a question here for you. Those patients given IV thrombolysis who were transported directly to angio suite instead of CT scan. So, I mean, I do believe that the IV thrombolysis is always given after a CT scan, at least native CT scan. And that's a question about the direct patients sent to the angio room.
Yes, so that's not the case for patients. I mean, for TPA, you need at least to exclude bleeding. And for that, you have the flat panel CT. So these patients still had a flat panel CT. But of course, you know, for a proper exclusion of bleeding and to a very thorough assessment of the exclusion, it's important to, you know, to do what it's supposed to do. So this is still experimental. The direct to angio suite is something that was tested in Catalonia, and is something that may be performed in secondary transfers, but has a primary approach, is still experimental.
Istvan Sikora, who is on this program as well, he's got, they counted the minutes who a neurologist in emergency spent on phone. And you know that sometimes if you don't have enough doctors to, I mean, exchange during the day maybe and during the week, that might be something like an overwhelming of phone calls, since they have to make a quick decision, not seeing the patient yet, since these are usually in primary centers, and ask the radiologist available to look in the CT scan. Would you make a comment on this, how fast how it works, and if there is a team which is, I mean, set up each day or each week, and if they review the cases who had a poor outcome and look at the reasons for that and maybe change a little bit the strategy?
Yes, I'm very fortunate. I work at a center. We do endovascular treatment every day. We don't need to transfer any patients anytime. So we do 24/7 all the time. So I don't have the experience of having to transfer a patient to another center in my hospital, but I had before, and still even receiving the patients from other hospitals, which happens many times in our center. It's quite a lot of time at the phone. It's crazy. So there are now some applications that help this process. So if this is set up, you are connected with the primary hospitals. They send the information, you receive it, and all the alarms for the patient coming and so on. So there are ways of improving this, but in most hospitals, it's still like that. So the patient comes, I have to call to the CT, I have to call to the emergency, I have to tell everybody. So I do like 1,000 phone calls per day if I have a lot of patients coming, and we have to connect with the primary hospital and discuss. And it's indeed, the communication is a challenge, and we lose a lot of time doing this. And so ways to improve this are very welcome. Of course, now with the data protection and so on, sometimes it's more difficult to set up this kind of systems of communication than before, but at the end it should be possible, and it really improves the workflow. That's important.
Okay, thank you. And maybe since we didn't manage to answer all questions from yesterday, and I like your introduction regarding the status of stroke therapy in Europe. And there is, since the part of our the participants are from Asia, do you have, or are you aware if there any comparison between the situation in Europe and Asia? Is there any society which covers the registry and the situation in Asian countries?
Yes, I'm not aware exactly of studies assessing access to care in Asia. But there are studies, for example, from China on there is an increasing access to thrombolysis, for example, but the situation in China is different, I think, regarding reimbursement of TPA. So that was a challenge, at least before. And there is the Australasian Society for Stroke, which I think has this coverage, also Australian and Asian countries. And I'm sure there are also the Japanese society, Chinese society, etc. So the Indian society as well. So there are societies, of course, stroke societies in all these countries. I'm not aware of a very large study assessing this in a broad scale in Asia. I think that's interesting. And of course, having the local metrics is very important, but having a picture of the broad regions is also important to assess disparities and to have models for good care, which may inspire other similar countries in the same region to take the same measures. So I think it's always very useful.
Okay, so since this was your last lecture, thank you very much for your contribution to this course, and hope see you in person in Prague next time. So thank you very much, and have a nice day to Lisbon.
Thank you very much. You too. Best wishes for a nice course for everybody.
Thanks. And now we will switch back to Czechia, and we have one of our distinguished speaker. He's the head of radiology department in the North Bohemia, and this stroke center is the busiest center in Czechia. And so welcome, Filip Cihlář. He's now online. Filip, can you hear me, please?
Hello.
Okay,
everyone.
Perfect. So coaxial and multiaxial technique. This is our first technical lecture on this course. So go ahead, please.
So thank you for inviting me to this meeting. It's nice to be here, and let's talk about catheterization technique. Endovascular therapy is performed using several types of delivery instruments: an access sheet, a guiding sheet, or a guiding catheter. It represents system in the sense that the selected guide wire, aspiration catheter, stent retriever, or etc. Must fit with each other. ACES has several goals: to secure puncture site, deliver therapeutic catheters and maintain access for serial angiography to control the procedure. Simple coaxial or multiaxial technique is the way how to do it. I want to talk about the basics, combinations of devices, and finally, I want to mention some tips and tricks with devices. First, it is necessary to mention the basic terms. So, ACES sheets are described using the French system, but the feature described is an internal diameter. This explains how 6 French device can fit through the 6 French sheet, and keep in mind that a 6 French sheet creates approximately 7 French hole in the artery. Conversely, guiding catheter are described by their outer diameter using French system, and keep in mind that 8 French guiding catheter has less than 7 French internal diameter, and balloon guiding catheter has even smaller lumen because of the dual lumen with inflation and working channel. So 6 French lumen or less. As would be mentioned, a 6 French sheet has an inner diameter of 2.2 millimeter, outer up to 3 millimeter depending on the type. The opposite is true for the 8 French guiding catheter. On the left, you can see the conversion table between the basic units, French, inches, and millimeters. We use the short sheet for standard procedure. A sheet up to length of 45 centimeters can be used in case of significant tortuosity of the pelvic arteries. The diagnostic catheter is then easier to manipulate in aortic arch. The long sheet can be used to assess the carotid arteries. The diameter depends on the catheters used, and we use it especially in severe tortuosity and calcifications on the way to carotid artery to protect balloon of the balloon guiding catheter. In my opinion, balloon guiding catheter is the most effective catheter. This is a frontline approach in arterial circulation in my institution, and another option is a dedicated long sheet, especially in posterior fossa. Some of the latest aspiration catheters can only be inserted through a dedicated sheet. The reason is the large outer diameter incompatible with balloon guiding catheters. An exchange maneuver can be avoided by using special 6 French diagnostic catheters. We are performing exchange maneuver over the long wire. Goal is to deliver guiding catheter tip as high as possible at this level, and you can see that we can achieve the maximum distal position of the balloon guiding catheter tip in combination with introducer of the sheet, and balloon guiding catheter tip nicely follows the introducer at this level. There are a large number of aspiration catheters on the market. We can divide them according to the inner lumen into 3 basic categories. Medium catheters with lumen height below 5 French, for the large bore aspiration catheter with lumen around 5 French and outer diameter up to 6 French. This is probably the most used category, and super large bore aspiration catheters are a promising development launched last year, and I want to mention that inner diameter has an incredible 6 French. Each catheter inserted into the supraortic vessels must be connected to a positive pressure flush. Flushing prevents air from entering the brain arteries, and at least 3 flushes must be prepared for the procedure, in my opinion. This will prevent the delays during thrombectomy, and the procedure is faster when you can change the flushes during the procedure. There are no recommendations for use of heparin during thrombectomy. The reason for not using heparin in thrombectomy are anticoagulation, prior IV thrombolysis, and very fast procedure. Heparin can be given as an IV bolus and its dose cannot be controlled if it's in flush. So it's better to avoid it, heparin in flush. Catheters can be used in several combinations. The most simple is the monoaxial procedure, but appropriate anatomy is required. A typical example is basilar artery occlusion, hypoplasia on one vertebral artery, and the presence of posterior communicating artery allow to reverse the flow in the basilar trunk. During so-called remote aspiration thrombectomy, you can achieve complete recanalization. Biaxial procedure with a balloon guiding catheter and microcatheter is the cornerstone of thrombectomy. The use of an aspiration catheter without a microcatheter is possible but not common. It is much more simple in posterior circulation. So, short example, you can see hypoplastic right vertebral artery, occlusion of the basilar artery, balloon guiding catheter in place, and inflation of the balloon, and remote aspiration can achieve complete recanalization, as you can see here, because you reverse the flow in the artery. But bilateral patent posterior communicating artery is a key factor for success. And you can see aspirated embolus during remote aspiration thrombectomy. Standard setup of biaxial system is balloon guiding catheter, epsilon connector, microcatheter, epsilon connector, and stent reaver prepared for implantation. Here you can see the biaxial system, the microcatheter and J-tip wire during insertion into the M2 segment on the right side, and there is a tip of the balloon guiding catheter. J-tip wire is the safest way to avoid vessel perforation. So you can see that J-tip prevents the vessel perforation and navigation is easily, and microcatheter follows it to M2 segment. The latest generation of aspiration catheter can be inserted without the support of the microcatheter or wire, especially in vertebral system, as you can see here, and you are prepared for aspiration and recanalization of the basilar artery, and procedure can be very fast with this approach. The same situation in the anterior circulation, but sometimes it is difficult to cross the ophthalmic segment of the carotid artery, and you can need additional manipulation. But if it works, it is again very, very fast. So biaxial setup can be extended with a long sheet for better system stability, with microcatheter for easier insertion of the devices, and finally 2 microcatheters for difficult thrombectomy case, but we use it very, very rare. More complex setup is also very rare. Balloon guiding catheter, aspiration catheter, and microcatheter with stent reaver is the maximalistic approach, and goal is the first line or first pass recanalization. Balloon guiding catheter, aspiration catheter, and microcatheter. This is the triaxial setup. In this particular case, the ICA was occluded below the level of the ophthalmic artery, and I always introduce an aspiration catheter with backflow, which creates this. So we reduce the risk of embolus dislocation to the level of the circle of Willis, and I will show you later this case. So, example on the right side, stenting of the carotid artery, and you can see nicely nice advancement of the aspiration catheter over the wire and microcatheter, and on the there is nice nice entering of the aspiration catheter to to the M1N1 segment over the microcatheter. So example of the dual stentriver technique, and but I must say that we have not much experience with this technique. We prefer combination of stentriver or aspiration for difficult thrombectomy. It is usually possible to introduce two parallel microcatheters. Only catheters with a lumen of 0.027 can be a problem easily to insert in parallel, and step-by-step introduction of the stentrivers through a single microcatheter can be bailout technique. The situation was very simple a few years ago. Large bore 6 French aspiration catheter could not be inserted through 8 French cello or 8 French Merci balloon guiding catheter, and other catheters were not a problem. Medium bore aspiration catheters are compatible with most guiding catheters except 8 French cello and Merci, because this aspiration catheter has proximal diameter close to 6 French. So this is a reason for incompatibility. And the situation is significantly more complicated with new large bore aspiration catheters. Most of the latest versions are already compatible only with 6 French sheets, like this one, and exceptionally only with dedicated ones, like this one, IXS Infinity, Cerebase, and etc. So compatibility problems are much more common than in previous versions of the aspiration catheters. Next problem is the length of the catheters. Usable length of the balloon guiding catheter is between 92 and 95 centimeters. Total length of the catheter is around 100 centimeter, and total length with this total length of the system with epsilon connector is around 110 centimeters. It means that the working length of the 125 centimeter aspiration catheter is less than 15 centimeters. And it can be problematic when balloon guiding catheter has tip at the level of the carotid bifurcation because of tortuosity of the internal carotid artery. So length of the catheter is not enough to aspirate clot from intracoronary circulation in this situation. Conversely, if you use a longer version of aspiration catheter, 132 centimeters, its total length with epsilon connector is around 143 centimeters. And it means that standard microcatheter with usable length of 150 centimeters has working length less than 7 centimeters. So think about using of longer version of the catheters like Prowler or Trek 21. This is an example of devices. This is balloon guiding catheter, aspiration catheter, shorter version and longer version, and microcatheters. So you can see very short working length of 150 centimeter long microcatheter outside longer version of the aspiration catheter. And this segment is very short, yet it can be problematic in some circumstances. A longer microcatheter is a better option, as you can see here. But check the working length of the stentriver, because sometimes it's problem to deploy stentriver through this length of the microcatheter around 170. And you can see balloon of the balloon guiding catheter and aspiration catheter with a length of 125 centimeters. This is a nice example. Aspiration catheter cannot be advanced further due to excessive tortuosity of the vertebral artery. So you need a long working length of the microcatheter to reach the basilar tip with stentriver. So standard setup with microcatheter with 150 centimeters is not enough. Some tips and tricks. This was case with occlusion below the ophthalmic artery and patent carotid bifurcation. I want to mention that excessive aspiration in the extracranial ICA can collapse the lumen, even if the stent is implanted, as you can see here. So this is a wall stent, balloon guiding catheter, and with excessive aspiration, you can collapse the lumen of the carotid artery, and this situation will not allow effective flow reversal during thrombectomy. ICA was occluded at this level by balloon, and remote aspiration through balloon guiding catheter was not effective. Occlusion was at this level. Aspiration catheter is the next step, but occlusion is at the level of the embolus and at the level of the balloon. So volume of the large bore aspiration catheter and saline flush during insertion of the system increase pressure in this part of the occluded artery, and you can push the embolus distally. So I always advance aspiration catheter without saline flush with backflow or no flow. And this is situation after thrombectomy, complete recanalization without any distal embolization. And I think that aspiration is in this particular situation safer because you don't cross the embolus with stentriver and microcatheter and wire, and you is possible to avoid distal navigation of the devices. So balloon guiding tip below this kinking don't allow effective aspiration due to severe lumen deformation during stentriver retraction, as you can see here. So carotid artery like this is not possible to aspirate through the balloon guiding catheter. But under certain circumstances, the flow to the ECA may be reversed, as you can see here. So backflow in the internal carotid artery to external carotid artery. And this is a relatively good situation to prevent distal embolization in brain arteries. After retraction of the stentriver into the balloon guiding catheter, I detach the epsilon connector, and in this case, you can see almost zero return of the flow of the blood, and this is a sign of occlusion above the tip of the balloon guiding catheter. So very important is not to deflate of the balloon guiding catheter, and you must continue with cleaning of the carotid artery. During second retrieval, you can see a slow backflow depending on the withdrawal of microcatheter. This is sign of clot entrapment in the stentriver, and you can see the first part of the clot is here. However, after extraction, the backflow is still insufficient, and do not deflate the balloon and aspirate or do another retrieval. So you can see very slow backflow, and it means that there is still some occlusion. And this backflow is definitely a sign of successful recanalization, as you can deflate the balloon, and there is two parts of the embolus which was retracted. Balloon guiding catheter can be very effective as carotid protection during stent implantation after intracranial thrombectomy. You can see nice flow control in the internal carotid artery, and this is a good way to protect distal embolizations during stent implantation. Stiffer wire can be very effective in case of difficulty with advancement of aspiration catheter. The goal is to change the position of the catheter tip in the vessel, and you can see progression of the advancement into M1. And anchoric stentriver is the second option. As you can see, deploying stentriver and pulling and the tip of the aspiration catheter nicely follow the wire of the stent lever up to M1. But this is relatively expensive way how to do it. A very cheap way is to use a coronary balloon instead of a microcatheter or stent lever. Its weight reduces the ledge effect between wire and aspiration catheter, and rigidity of a PTA balloon helps in this situation. Some catheters are sold with special instruments like offset or wedge to improve trackability, and you can see again decreasing of the ledge effect between wire and lumen of the aspiration catheter. Another option is a coaxial set of aspiration catheters, again reducing the ledge effect. Conclusion: coaxial techniques allows safe and successful recanalization. Pay attention to the compatibility of the devices and choose your own combination, especially according to your local availability of devices. Keep the intervention simple and do not invent combinations of devices during the intervention. The goal is to be as fast as possible. So thank you for your attention.
Thank you very much, and I am very happy to to see this technical lecture about the multi-axial and coaxial system. I mean, today the aspiration seems to be number one, and I have a question for you here. That does no reflow phenomenon exist in cerebral arteries? Is it, if it is possible, does it have a treatment? So no reflow phenomena, which is quite well known in coronary arteries. Have you seen this in the practice?
I think that this is not often, and probably the use of some drugs is solution for this problem, I think.
I would suggest that the no reflow we would classify as a TICI1 or maybe TICI2A, just with minimal penetration of the contrast medium into the open artery or recanalized artery or partially recanalized artery. And I'm telling true at the same feeling as you have, that it's not frequent in cerebral arteries. And there are definitely the phenomena which is called re-embolization, and which could be in the territory which is already occluded or recanalized, or the new territory. And there is also the phenomena which is probably the microembolization. Since there is a choice study, they proved that better clinical outcome are in patients who received the intra-arterial thrombolysis after successful recanalization. So telling to, I have the same opinion that there is no, that's not frequent, and we don't see it, that so-called no reflow phenomena in cerebral arteries as in coronary. And I think it's quite important to be aware of the length of these devices, since sometimes if you check it during the procedure and are not familiar with these devices before, that it's expensive, since I mean these devices are not used, and they are these catheters which are quite expensive, put in a trash. How would you comment the hydrophilic coating? Since I think the large generation of aspiration catheters, and you demonstrate that it's possible to place it into the intracranial vasculature in the Willis, circle of Willis level, without any microcatheter, any guide wire.
I think it's fantastic because 5-7 years ago, if somebody tells me that it will be possible to introduce 6 French aspiration catheter to M1 without any additional device. It's like miracle because procedure is very fast. Procedure is I can say much cheaper, and it's very good for our patients to have this opportunity and these devices. And it works very well, especially in posterior circulation. But I must say that in carotid or ophthalmic segment, sometimes even if patient is young, it's not so easy to cross the ostium of the ophthalmic artery.
So what, since you already mentioned that you are a very busy center, what's the proportion of just the pure aspiration technique and a combination of aspiration and stent retrievers? Or is there any preference that you use in certain circumstances as a first choice as stent retrievers?
I must say that in posterior fossa, definitely aspiration is the first choice for every case, and in arterial circulation depends on personal preference. Especially younger guys do more aspiration, and my decision is usually I use stent retriever as first line approach, but it depends on anatomy. If the patient has tortuous internal carotid artery, it means that balloon guiding catheter usually is not sufficient during kinkings to aspirate adequately, and in case of large posterior communicating artery and good collateral flow during occlusion of the carotid artery, there is a relatively higher risk of the embolization or re-embolization during stent retriever retraction, and you can create embolization in the new territory. So if internal carotid artery is severe kinked, or there is large PCOM, I prefer the aspiration technique for these cases.
Okay, so another question: without heparin infusion in catheters, how we can stop further thrombus formation, if any? Since I mean, it's generally recommended not to give, not to add heparin into the flush. And have you seen any thrombus formation during the mechanical thrombectomy?
No. Because usually the procedure is fast, so the length of the procedure is around 30-40 minutes usually. So I think that there is not a big problem with thrombus formation.
I think that the mechanical property of the flush is more important than anticoagulation effect of additional heparin into the saline. How far do you recommend to take the guide catheter in the ICA? Is it different in balloon guiding catheter as opposed to the destination sheet, which is a long sheet? So the balloon guiding catheter versus the non-balloon catheter, how far into the ICA would you recommend to that?
With balloon guiding catheter, I recommend as far as possible you can go. It's better because it's better for aspiration. With destination or sheets not dedicated for thrombectomy directly, I stay at the level of proximal carotid, proximal internal carotid artery. If you use dedicated sheets, which has distal flexible segment, with these sheets you can go up to Petrous portion with any risk, I think.
And maybe a last question, since we are a little bit delayed. Does negative pressure affect outcome on the ADAPT procedure? How much pressure can we apply on aspiration catheter? Normally we use a 50 cc syringe. Can we use 2 syringes in sequence or parallel to increase the suction pressure?
I feel it's possible. We use usually one syringe, and this is enough, I think. But the 2 syringes is another option.
Yeah, but that's I personally prefer 20 cc syringe, and just feel if there is any resistance or no flow into the syringe. Just use this one, and 50 cc syringe sometimes could be even too much to aspirate through this. Okay, so thank you very much. It was excellent, and hopefully see you next time on the present.
Thank you.
So thank you. And we will continue a switch to St. Gallen. Oh, Pascal is here. Okay, Pascal, can you hear me?
Yes, I can hear you.
All right, perfect. So next topic is common stroke causes.
Yes, let me just start my slides. Can you see my slides in the presentation mode?
Yes.
I think.
Perfect.
Okay, good. So back again. Let's continue with the topics. The next talk is about common stroke causes. You already had a talk from Diana about the less common stroke causes, and now focusing on the common ones. So you know there are many causes for stroke, many known causes of stroke. We can start with microangiopathic lesions of the small vessels. We can have intracranial atraumatoses, which also may lead to large vessel occlusion. There is extracranial atraumatosis leading to arterial emboli. But if we have a stenosis and it's too high grade, it can also cause extracranial occlusion or hemodynamic impairment. The aortic arch is also a source of atraumatosis and embolic events as a cause of stroke. And of course, there are many cardiac sources for cardiac emboli, like arrhythmia, atrial fibrillation, valvular heart disease, PFO, myocardial infarction, and cardiomyopathy. And of course, there are the less frequent causes. Diana already went into detail, like, for example, migraine or certain drugs. I think as an interventionalist, you need to know the TOAST classification because it's used in many studies. TOAST divides is a classification for the subtype of stroke etiology. There is large arterial atherosclerosis, cardioembolism, small vessel occlusion, and then stroke of other determined etiology, and stroke of undetermined etiology. And you can see most of the strokes, 30% are large arteriosclerosis, around 25 to 35 are cardioembolism, and around 25% are small vessel disease, and around 20 to 40% are cryptogenic, meaning we don't find an exact or proven source of stroke, and that's quite a lot. And we will come back to this issue in the second part of the talk. So why is it important to know the etiology of the stroke? Yes, of course, you want to have a diagnosis and of course treat, but at the end, of course, the etiology defines also the prognosis of stroke and of the underlying disease. And as you can see here, the rate of survival after stroke in large artery disease after 90 days, for example, is much worse than in small vessel disease. So it's an important issue, important to know. There are some standard workup defined in neurological guidelines, for example, here in the guidelines of the German Neurological Society, including vessel imaging, echocardiogram, ultrasound, Holter ECG, laboratory examinations, checking for cardiovascular risk factor, vasculitis, and other systemic disease. So it's a whole clinical workup. However, since I'm a neuroradiologist, I wanted to look a little bit from the imaging pattern of different infarctions or ischemic lesions and try to get from this point of view to the potential sources or the differential diagnosis of etiologies. And these are the type of infarcts we can see on imaging: territorial infarcts, lacunar infarct, watershed or border zone infarcts, embolic infarcts just affecting one territory, or embolic infarcts affecting more than one territory. So let's start with the territorial infarcts and talk about territories. You all know from anatomy the different vascular territories in the brain, and they're always in anatomic atlases. They are like schematically drawn, but we know from autopsy studies that the extent of those territories is very individual and has a high variability, with large MCA territories and smaller PCA territories, and the other way around. And this has been shown in autopsy studies very nicely. And we can also kind of see that if we use a little bit of advanced imaging, such as ASL or selective ASL, to see where flow is coming from in order to better understand the extent and the distribution of certain vascular territories. This might be of importance, for example, here in these patients with embolic lesions in the left MCA territory, but also one in the right posterior ACA territory. We know he has an aplasia of the right A1 segment, and ASL shows us that the left MCA as well as both ACA territories are supplied by the left ACA. So therefore, an embolic source in the left ACA might be responsible for this stroke, and not necessarily more proximal embolic source, which would explain the lesions in several vascular territory, but indeed it's only one vascular territory. So for territorial infarcts, we usually look for proximal vessel occlusion, possible etiology as cardioembolic, atherosclerotic stenosis or occlusions or dissections. So carotid stenosis is an important cause of stroke. It's responsible for around 18% of strokes in general, and they cause around 38% of recurrent strokes. And the prevalence of high-grade asymptomatic carotid stenosis is around 0.1% in the population less than 50 years, so it's quite rare, but it increases up to 3% in men over the age of 80. In women, it's even rarer under the age of 50, but also increases to almost 1% for over the age of 80. It's important to discriminate between clinically symptomatic and asymptomatic, and between the degree of stenosis, because the risk of thromboembolic events depends on the grade of stenosis, on the morphology and volume of the plaque, and also whether it was symptomatic or not, so previous TIA or strokes. And the risk for symptomatic stenosis is around 13% the next 2 years, in the stenosis 60 to 69%, and increases in high-grade stenosis up to 30%. And the risk in asymptomatic stenosis is much lower. In over 60%, it's 2% per year. Nevertheless, we might discuss whether this is low or not, and over 10% over the next 5 years. So the different ways of measuring carotid stenosis, you're aware of that, of the NASCET and ECST measurement. You have to know that they are different, and also you have, if you measure the stenosis, you have also to say which system you are using. Nowadays, mostly NASCET criteria are used. Another etiology is cervical artery dissection. It's overall a rare cause of stroke. Only 1 to 2% of strokes are caused by cervical artery dissection. However, in younger patients, it's a quite common cause of stroke. Around 10 to 25% of strokes in the younger are caused by a dissection. The annual incidence is estimated of around 3 per 100,000 patients per year, but is most probably underestimated. And the mean age is in 40s and is much rare beyond 6 years of age. There's no gender predominance. Overall, ICA dissection are more frequent in men, and vertebral artery dissection are more common in young individuals, and here they tend to be a little more likely to be women. Overall, around 2/3 of dissections are in the ICA and around 1/3 of dissections are in the vertebral artery. There are bilateral or even multiple dissection, but these are rare findings, accounting for only less than 2% of dissections. The mechanism of stroke in dissection is heterogeneous. It can be hemodynamic, it can be embolic, or a combination of both, although embolic strokes are the most frequent, leading to stroke, TIA, retinal infarcts, or just amaurosis fugax. So what's the prognosis? There is a very good clinical prognosis. 70 to 85% have an excellent recovery on the best medical treatment. Disabling deficits are rarer than in large vessel occlusions, 10 to 15%, and also death is rarer. There are some predictors for good outcome: young age, lower NIHS score, vertebral artery dissection tend to do better than ICA dissection. And if we look at intracranial dissection, non-transmural, intramural hematoma not leading to subarachnoid hemorrhage have also a better outcome. The risk of recurrence of a dissection is quite low. It's 0.3 to 1% per year. And if it happens, it doesn't mean that it has to necessarily be the same vessel, but it can be another brain supply vessel that is affected, leading or pointing a little bit to an underlying predisposition. Recurrent strokes are also rare, 0.6 to 1.4% per year, and it may occur with or without localization of the ICA. The next group of infarcts are lacunar infarcts. So there are different definitions of lacunar infarct. There's the Oxfordshire Community Stroke Project classification from 1991, which defines a lacunar infarct as an infarct confined to the territory of the deep penetrating arteries. So it's a purely anatomical definition. And there's also in the TOES classification definition of the lacunar syndrome, where also the size of the lesion is being taken into account. It has to be less than 15 millimeters. So what about watershed and border zone infarcts? Again, we have to keep in mind the territory in order to be able to distinguish border zone infarcts just from distal embolic infarcts. It's defined as ischemic lesions in the area between two neighboring non-anastomosing vascular territories. And there are two broad categories. There are the external or cortical watershed infarcts, and there are the internal or subcortical watershed or border zone infarcts. Watershed infarcts are rare. They account for only about 10% of all cerebral infarcts. This is the typical pattern of an external cortical border zone at the junction of the anterior, middle, and posterior cerebral artery territories. It's quite a typical distribution, a typical finding, keeping the territories in mind. And this is a typical distribution of an internal or a subcortical border zone infarcts in the areas between the lenticulostriate perforatus and the deep penetrating cortical branches of the MCA, or the deep white matter branches of the ACA and the MCA. They are paraventricular in the corona radiata and supraventricular also in the centrum semiovale. The pathophysiology of border zone infarcts is not as straightforward as we might think, and it has been described here in this paper by Louis Kaplan, a famous vascular neurologist who pointed out the selective vulnerability of cortical border zone to micro embolic infarcts, and he coined the term of the impaired washout. You have, of course, an effect of hypoperfusion, for example, due to an underlying stenosis, which leads to hypoperfusion, decreased blood flow, but this also impairs the clearance or the washout of emboli that also might arise from a carotid plaque proximally in the brain supplying vessels. And so you will have this kind of mixture between watershed, purely watershed, hemodynamic infarcts, but also embolic infarct, which are due to the decreased capabilities of washout in these areas. This is an example of a clinical case, a young male, NHS 022 with a Horner syndrome. The clinical syndrome was some kind of fluctuating. He presented with this MR imaging. We see an occlusion of the ICA, no intracranial occlusion, and the hypoperfusion of the whole left hemisphere due to his disposition of the circle of Willis without the ACOM and the fetal PCA. So the whole left hemisphere, ACA, MCA, and PCA territory is supplied by the left ICA, which is occluded. And the reason for occlusion is a dissection. You can see here the wall hematoma. And he has now here some punctuated diffusion lesions. Now we might discuss, is this hemodynamic? Maybe here, but also maybe there is also an embolic aspect. It's hard to tell. We didn't treat at the point and put him in the stroke unit, kept his blood pressure high. The next day he deteriorated clinically. We repeated the MR, and you can see this blooming of this diffusion lesion. These are no new embolic lesions, but this is a blooming of pre-existing lesions due to the hemodynamic stress. Until he was out of the scan, he was again completely asymptomatic. The next day we waited. The next day the same issue. He deteriorated, and we can see now how these lesions increased due to the hemodynamic stress. At that point, we took this patient to angio and recanalized the ICA due to this hemodynamic impairment. This is another case, a 70-year-old male. For 1 week, he has some gait disturbance and ataxia, but he has problems longer, even more, since years. Every 2 weeks, he can only stand or sit for a duration of 10 to 15 minutes. He is complaining about visual field deficits, anopia and flickering, and which is objectified in the clinical examination, and also double vision, and it gets better when he's lying. So what does the MRI show us here? This small DVI lesion is probably embolic. However, here, these lesions bilaterally between the territories of the superior cerebral artery and the anterior inferior cerebral artery are suggesting of a hemodynamic problem. So they're also watershed infarcts in the posterior circulation, in the cerebral circulation. And this is the reason he has no PCOMs. His left vertebral artery is occluded, and the right one has a high-grade stenosis. And this explains this perfusion deficit in the posterior circulation. You can also nicely see that the right PCA is a fetal variant, so we don't have a perfusion deficit in the right PCA, but a massive perfusion deficit in the cerebellar and left PCA territories. And here again, to show you that there are also this kind of watershed infarcts in the posterior circulation. Now to embolic infarcts affecting one territory. The etiology is usually arterial, can be atrial fibrillation, especially if it's cortico-subcortical, but also a carotid stenosis or carotid plaque, as we said. And here I think more and more plaque imaging is being applied. It has already been shown in this old study that in patients with a cryptogenic stroke, so no obvious reason for the stroke was found, almost 40% of those patients had ruptured plaque on plaque imaging on the ipsilateral side, but not on the contralateral healthy side without infarcts. There are other studies pointing in this direction. Here also patients with cryptogenic stroke with non-stenotic eccentric plaque was also found in 20%, more than 20% of cases, and this is of course a potential source for distal embolism. A clinical case. This is a 76-year-old male. He has some vascular risk factor, and he had a transient right brachioacral sensomotoric hemisyndrome on the 22nd and the 24th of March. This was his MRI when he came to the hospital on 26th. You see this punctuate embolic lesions in the left MCA territory, and again it was symptomatic on the 27th. You see the new lesions more cranially. He underwent all the workup. Nothing was found except for this hemorrhagic plaque on the left ICA. And we might now discuss whether it's worth treating that or not. At the time, we decided to stent this patient. And he didn't have recurrent stroke symptoms, but of course, this is a matter of debate, and this for sure a current discussion whether this is a good indication for stenting or not. The last group are embolic infarctions in more than one territory. Here the etiology is usually cardioembolic. Aortoembolic can also be tumor-associated with tumor-associated coagulation disorders or other coagulation disorders. And for atrial fibrillation, there is a whole clinical workup. I don't want to go into the detail for the sake of time, and also there is a discussion what kind of monitoring is needed, how extensive should it be to have the best yield to detect an intermittent atrial fibrillation, for example, as a potential cause of stroke. Aortoembolic, you can see here these plaques in the aortic arch. They're also known to be a source of embolic events to cause stroke. The risk has been shown to be increased when they're 4 millimeters or larger, if they're ulcerated, and whether there is already a positional thrombus there. The risk seems to be smaller if there are calcification. And also here there is some data supporting this. Also again, in around more than 20% of cryptogenic stroke, such vulnerable plaques can be found, and this might be a potential source of stroke in those patients. It's also interesting to look at the descending aorta. If we have a plaque there, is it still possible that a plaque from descending aorta is embolizing retrogradely to the brain circulation? And there are some studies nicely showing that yes, we have in the diastole, we have retrograde flow in the aortic arch. Here in this study, they could nicely show that they had retrograde flow in this left subclavian artery in almost 60% of cases, in the left common carotid artery in a quarter of cases, and even in the innominate artery in more than 10% of cases. And of course, this can be a source of stroke, and then here further explanation for a previously cryptogenic stroke. And here is this flow measurements from this study, where you can see the backflow in the diastole, the retrograde flow, potentially being a source for embolic lesions. Tumor-associated coagulation disorders is also something common. In autopsy studies, we can find in 15% of tumor patients some kind of cerebral thromboembolic events. The prevalence of tumors and strokes is, depending on the etiology, overall it's around 15%. It's most in colorectal cancer and is much less likely in lung cancers, but it's almost a 1.4-fold increase risk of stroke in ovarian cancer for women, for example. So if we put everything together, we end up with around 20% of arterial, 20% of arterial fibrillation, 20% of aortoembolic, and 20% of tumor-associated lesions, and the remaining 20 to 30% are so-called cryptogenic. And this is a little bit tricky because what and how far should those people be examined? Because it's a relevant issue, because it may change the therapy and it reduces the risk of recurrent stroke to know the etiology. And also, of course, from a cost, socioeconomical point of view and cost effectiveness point of view, it's important. And to stress this, the cryptogenic stroke working group proposed a new term, not to call it cryptogenic anymore, because this is kind of, we don't know really what's going on, but rather to call it embolic stroke of undetermined source, ESUS. So it's positive wording implicating that we're looking for something. These are patients where no lacunar infarct can be found. They don't have a stenosis of the ICA bigger than 50%. And all the cardiac examinations have been negative, and also no other cause has been found. And then you can go through this scheme. So you see, you have a stroke patient and you do all the examination, then you have a known cause. Or if you don't have a known cause, then it's a ESUS. If it's in one territory, small, multiple, it's infarct, it's likely. So my audio is back. So it's arterial, and in those patients, we would recommend to go further to see with plaque imaging. If it's larger and cortical, it might be cardioembolic, so you may increase or further evaluate cardiac examinations with further ECG examination or even a cardiac MRI. If multiple territories are involved and the D-dimers are elevated, look for tumor and cardioembolic for tumor screening. If the D-dimer is normal and in older age, look for aortic arch with further imaging in order to find more sources. Thank you very much.
Thank you. It was a classical topic and classical lecture, and for me and for the others, very important. And my question would be, speaking about the unidentified sources, and should we evaluate everything what we removed from the artery? I mean, using the histology, and I mean that's also a lot of money to do that. And do you think this is a routine practice? Should be done only in selected cases? What's your practice?
You mean the clot? The clot
histology of the clot.
The problem with clot histology is that it's quite unspecific in most of the cases, unless you do some special, you may do some special examinations for special markers, which might point you in one direction. But I think at the moment, this is not practically in a systematic way. We do it in selective cases when we really think this is a strange clot. This looks like heart valve or like a tumor, and we were able to prove or to fish tumor embolization, heart valve embolizations, and then of course this helps you to point out where to look. But I think currently in everyday practice, in a systematic way, we don't do it, and probably for most of the patients we won't be able to be too specific. However, yes, this would have a potential if we find the right markers. Yeah.
Mm-hmm. So only selectively in patients based on history, and if it looks funny, I mean it's a whitish or something little, not the red one. Okay. Since we had the experience that not from the brain artery but from the coronary artery, they removed the cancer cells. Was a tumorous thrombus and so on. Okay, what's in large artery occlusions? You mentioned that the classical division about the arterial cardioembolic. What's the proportion of the angiograms that you don't prove the occlusion which is seen on a CTA? it means that if patient is given IV thrombolysis and without any improvement or just mild improvement, but still having significant neurological deficit, and go to angiography, and you don't see anything on angiogram, no occlusion. How often this happens?
I don't quite understand. So the patient,
if you see the negative angiogram,
yeah, so all the vessels
on the patient who was sent to you to the angio room based on a positive CT angiogram.
Well, it depends on the quality and also on the interpretation of the CTA. I mean, a good quality CTA and a good interpretation. Let's say what is critical in an acute case is whether you have an intracranial occlusion. That's what you mainly point to get into the angio suite to do a thrombectomy. There are certainly some doubts if you have this kind of pseudo occlusions, and there we usually do an angio to prove that it's still a channel there or that it's really occluded. Yes. This is not that often. I mean, these are cases, they exist, and sometimes you cannot even say with ultrasound whether there is still a lumen or not. I think what is more frequent, which maybe goes a little bit in this direction, has to do with the interpretation of CT image, and I think this is important to know. If you have a T occlusion, and if you do a monophase CTA, you might have a contrast stagnation in the proximal ICA. And then you may think that the whole ICA is occlusion, but it's not like that. It's just the tip of the ICA, the carotid T, and there is no flow there. That's why contrast is stagnating in the ICA. And this is important to realize that this is rather a carotid T than a carotid occlusion, because your technique for a carotid occlusion would be different. That's more than just a thrombectomy. You would suggest that there is an underlying stenosis or dissection or a large thrombus. So it's a kind of a different intervention in planning that. So I would say this is the most sometimes tricky to distinguish between a true, let's say, a true tandem occlusion with a cervical artery, a cervical ICA lesion, and an isolated carotid T occlusion, which may mimic an ICA occlusion on CTA.
We noticed that you used for evaluation MR. Is that your regular practice? And since I doubt that we would be able to diagnose such a tiny infarctions on a CT, on the native CT, since we usually don't see them.
Yes, when I was working in Bern we had the infrastructure to perform MRI in the acute phase, and we tried to do MRI in the acute phase whenever possible. But of course, this is very much depending on the availability and infrastructure. And I think in this case, as I showed you, it shows you very nice, first of all, the diagnosis. I think in many of those cases, a plain CT wouldn't have given you, shown you those lesions. So this shows the beauty of MRI. It gives you the diagnosis. Yes, it is a stroke. It's not a stroke mimic. Yes, there are diffusion lesions. There is infarct. So it's a stroke. So very simple. It's the diagnosis. And second, it can also give you already a hint on the possible etiology, so that you know, okay, this might be a cardiac lesion, or this might be something else, to already point towards the further examinations.
Okay, so thank you so much. And since this is your last lecture on this course, so thank you also for your contribution to this. And I mean, nobody knows that you broken the elbow yesterday, and in spite of that, you deliver all lectures. So thank you also for that, and I wish you soon and good recovery.
Yes, thank you very much, and
thank
see you soon. Bye.
Bye. And there are some questions which we haven't answered yet, and they are technical, and we will concentrate on them in the last lecture this afternoon. So I mean, don't worry that we will skip them. And now we have a planned lunch break, and we will be back in 1:30 p.m. of Central European time again. Okay. Welcome back in the afternoon. We have a first session, 1.5 hours, and the first speaker is Jens Fieler from Hamburg. And okay, you can hear us. Okay, welcome and good afternoon from Prague. And the topic which will be discussed today is patient selection for endovascular therapy. So Jens, go ahead, please.
Thank you. So just 1 second.
We have currently connected more than 58 doctors online, and there's lots of questions this time.
Okay.
So that the audience is very sensitive and active.
Okay, that's very good to know. And it was yesterday the case already. We enjoyed the discussion. Yep. Okay, then let's start. Thank you, Tony. Clinical patient selection. Same as yesterday. So this is what I'm going to talk about. The EXMINT guidelines over and over again, this time for the clinical patient selection criteria. What are the criteria? Time from symptom onset. We discussed this yesterday already, but now in a bit more detail. Stroke severity, NIH stroke scale score, pre-stroke function, age, outcome versus therapy effect. I think, again, a point that needs to be stressed. And patients with IV contraindications, should we wait for TPA failure? I think this is all very important for decision making in acute stroke patients. So please download this guideline. It gives you a lot of answers if you want them, but they are not short. So it's a very detailed analysis of the evidence until 2019 and really the recommendations. We hope we will have a new guideline next year, but so far this is the valid guideline. And obviously it also covers clinical criteria in all those PICO questions. So you have this PICO question outside of a comprehensive stroke center versus inside and things like that. So it can be all found. If you summarize all of this in a very simplified way, something that we discussed already, that you have clinical criteria for the optimal golden patient and imaging criteria and the clinical criteria. Obviously, the earlier you are, the better it is. But as discussed yesterday, there's no final limit. We should just speed up, but there's no reason to stop at a certain time. But ideally, within the first 4.5 hours. NIH 8 to 20, but there is no cutoff, but we will discuss this later on. Pre-stroke MRS of 0. Of course, the chances to have a 0 in the end is much higher. You won't improve a patient who has an MRS of 2 to a 0 just by thrombectomy. Younger patients have better outcome, but not necessarily better therapy. So this is what we discuss. And why do we need those guidelines? They are efficient. You don't need to go through all the literature yourself. You can do it, but it's very time consuming, most likely incomplete. You might make more errors than a team of experienced clinicians, and it's maybe biased based on what you want to find and what not. It has a higher credibility, so you have an interdisciplinary group of neurologists, anesthesiologists, neurointerventionalists, and so on. You can present them to your government, and it might help reimbursement in your certain area. So for guideline writing, the most advanced version that is in wider use today is the so-called GRADE process. You start with the so-called PICO question. So with PICO means patient, intervention, comparator, outcome. And if you really start, the easy answer is, let's say, should we do thrombectomy in younger patients? That's the casual question that you are asking. But if you think a bit more closely, you need to be a bit more specific. should we do it means that it's better than something else. And what's the alternative that you compare it to? So you need a comparator. You need to define exactly thrombectomy. What exactly do you mean by thrombectomy? Stent retriever, aspiration, both in combination, or doesn't matter? And then is it better in which outcome? How do you measure the outcome? Infarct volume, functional outcome, maybe health economy questions like, is it cheaper to do it this way or the other way? And then you have a 9-degree scale for weighting the outcomes. You go through a standardized literature search and you define the quality of evidence. And then you recommend against for something, and you evaluate the strength of the evidence as strong or weak. It's a very standardized terminology. So this is what has been done with all the things that we are discussing now. It's not just a gut feeling or summary or something. It's really the result of a very formalized process of the literature evaluation. So the time that we have is the classical randomized controlled trials were enrolling patients within the first 6 or within the first 12 hours. And then we have the 2018 RCTs with 6 hours to 24 hours or 16 hours to 24 hours or 6 to 16, I mean, and 6 to 24 hours. So they had included only patients with a small infarct core, but just last week we had the first study that included patients with good collaterals also in the first 12 hours after symptom onset. So the recommendation says that within this, in the time window of 6 to 24 hours, we should enroll patients who fulfill the selection criteria of Dawn or Diffuse 3. And this is how it looks like. So age-dependent infarct core size, quite complicated, and you need theoretically the rapid software, but the European guideline says you can also use other software if it has a comparable result. So you need to fulfill those criteria if you enroll patients in the late time window, but this is relatively strict. Most likely you can enroll also patients with less beneficial imaging patterns. And there is an expert opinion saying that you can also use other software applications rendering equivalent results as those used in Dawn and Diffuse 3. That's totally possible. So bottom line is enroll patients up to 24 hours, but there are also some reports even beyond 24 hours it works. So there is no reason why thrombectomy should stop working at 24 hours. So essentially, there is no absolute time limit. Pre-stroke function. So all the studies for study internal reasons required an estimated MRS score for pre-stroke MRS score of 0 to 1. So otherwise you couldn't show or find a therapy effect, but this doesn't mean that there is no therapy effect in those patients. So this is an interesting study that also had a look at patients with MRS 2 and 3, and this is the result of the total thrombectomy group here, and they came up with unchanged MRS2, for instance, and unchanged MRS3 in all of the cases in the 90-day follow-up. And I think that's quite interesting to look at. And this is an interesting paper 3 years ago from the Heidelberg group, and they had a pre-morbid MRS3 and pre-morbid MRS4 patients, and a good outcome was considered unchanged to pre-stroke condition. And this was achieved in 20% here and 24% here. So the median was higher. So the lower the pre-stroke MRS, the poorer the outcome. But the rate of good outcome is still considerable. So I think those patients should be considered as well, but this is a highly individual decision. So the guidelines say that no conclusion can be drawn for patients with pre-existing functional deficits, because all of the studies were focused on MRS-01 patients, but they can be considered. It's up to you. Does sex modify the effect of thrombectomy? Hermes says no. So there is no difference in MRS men and women, MRS 0 to 1, women man. So you see that's most likely a random observation here. Mortality and symptomatic hemorrhage. So I think sex does not influence clinical outcome after thrombectomy and does not modify treatment effect of endovascular therapy. So exactly the same, 39% good outcome in women and in men. But now it's getting a bit complicated. We look at this. Does sex influence the outcome? A swift analysis says yes, sort of. If we look at this disability adjusted life years for male and female red, male blue, you see that overall, so this is with the age of stroke onset, that women have a longer life expectancy. So overall, women have comparable functional outcomes directly after therapy, but more years of optimal life because of the overall higher life expectancy. You achieve a higher effect in women because they live longer and they benefit longer from the improved acute outcome in stroke. So if you take this into consideration, thrombectomy is more efficacious in women. This is, if you look at, let's say, a selected age group of 60 years, so the likelihood of good neurological outcome seems to be a bit higher in women. And this is same story here with the disability adjusted life years, so the long-term benefit. The laterality, left or right, does it play a role for outcome? There were no significant differences in MRS 0 to 2 between right and left. Obviously, there are hemispheric functional differences, and most likely MRS is not able to capture these differences. But stroke site was not a prognostic factor and did not modify the treatment effect. I think we should leave it at that. But if you want to go into more detail, obviously you would find something localization specific. That's for sure. But we shouldn't take this into consideration for decision making. So in a large cohort of patients, doesn't play a role. Now age. Age, I think, is a very interesting one, maybe the most interesting one of this presentation. So patients aged 80 years or older were allowed in 7 RCTs, but overall only approximately 200 of these 1,200 patients, so 15%, were aged 80 or more. A clear benefit of thrombectomy was observed for those patients with a better functional outcome of 3.68. So the odds ratio 3.7. So given that we take them from the same patient population, we have a even higher odds ratio compared to the average study result here. So it seems like the old patients, look at them, have a higher therapy benefit than the younger patients. So how does this work? So it doesn't make a lot of sense because we think that maybe we shouldn't even treat the old patient because they have such a poor outcome. Yes, poor outcome, but the treatment effect is the difference between the comparator, so the alternative outcome, no thrombectomy. So thrombectomy is way more important for the old people than the younger people, but lower life expectancy. So if you put all of this together, it's again a different angle for looking at things, but the sheer 90-day outcome comparison between treatment and non-treatment is most beneficial in the old patients. So the patients aged of older than 90 years were actually only 5 out of 600, so less than 1%. We'll come to that in a minute. So this is the patients in the later time window who are older than 80. You have a very high therapy effect. So odds ratio of almost 5. It's very convincing. So it's definitely a beneficial treatment, even for the elderly. And I think that's a very interesting analysis of the Hermes data. We have a look at the different aspects groups. So small infarct, mid-size infarct, large infarct for younger than 75 and older or equal to 75. And we have a therapy effect size between endovascular and control, upper row endovascular, lower row control, 26%, 15, 17%. And in the older group, there's a smaller difference actually, but we are talking about the low aspects patients here, where the age plays an important role in determining the outcome and the therapy effect. So just look at this. This is the rate of good outcome here and the rate of good outcome here. So age is very important in making a difference in the rates of good outcome. But if we look at this lower graph with the large aspects, we have a very high mortality. So 2/3 of the patients die even after thrombectomy in the patient group with the large infarct, aspect 0 to 5. So probably not very effective to do that. So it seems like the mortality is even higher in the endovascular group versus the control group, but that's not the focus of this analysis. So we have a huge difference in age. And if we look at the patients older than 90 years, we see that modified ranking scale at discharge is very poor, but it improves a little bit after 90 days. So we have a shift within this MRS 0 to 2, 0, 1, 2. So it's 15% and then 16% after 90 days, but we have a shift in the one category. So a lot of the 2s at discharge become 1s at 90 days. So there is a lot of delayed improvement in those patients. And if we look at the effect of reperfusion, so upper row unsuccessful recanalization, lower row successful recanalization, actually we have a real effect here, even in the very old patients who are older than 90 years. And again, we need to stress this point that there is a huge difference between good outcome and therapy effect. And this is a very old publication on the Mercy device, which was not observed to be effective in the 2013 studies. They had a so-called Thrive score. It's still applied at times. So age of the patient, comorbidities. So 1 point for hypertension, diabetes, atrial fibrillation. So the more points here, the more comorbidities, and the more points here, the higher the neurological deficit. And if you have a Thrive score of 0 to 2, the rate of good outcome is relatively high. and Thrive 69. So all of them almost applied. You have a very poor rate of good outcome. So if you have a Thrive score of 0 to 2, you recanalize, you have a rate of good outcome of 80% and 27 without recanalization. But if you have a Thrive score of 6 to 9, you have a rate of good outcome of only 18%, which is worse than the recanalization in the Thrive 0 to 2. But without recanalization, you have no good outcome at all. So still, creating recanalization in these very poor patients here creates a therapy effect of 18.5%. I think that's quite impressive, and I think it's extremely important to overcome this bias. All these old people, they don't benefit because we have a low rate of good outcomes, but without reperfusion, there is virtually no good outcome. So something we should always consider specifically regarding the ages. So the recommendation, the official one in EXMINT guidelines says that patients aged 80 or more should be treated. So there is no justification for any age limit. So stroke severity, high NIHSS, it says that there is no evidence of the heterogeneity of treatment effect among severe strokes. So no upper limit, low NIHSS. So there were very few patients enrolled with very low deficits, like Mr. Clean allowed NIHSS as low as 2. If there was sufficient uncertainty of thrombectomy benefit. But from the 1,916 randomized patients of the large studies, only 14, less than 1%, had an NIHSS of 0 to 5. So we don't have good data on those patients, and there are some studies ongoing, like ENDOLO, who aim at enrolling those patients. And if we look at the summary analysis of the Hermes data, we see here that there is no real heterogeneity in treatment effect. If there is something, maybe in a very low NIHSS, there is not a super straightforward proof for therapy effect, but I don't think we should exclude those patients from therapy. So the recommendations say we do not recommend an upper NIH stroke score and the low stroke severity NIH 0 to 5, they should be included in randomized controlled trials. What should we do with IV contraindications? Should we wait for TPA failure? The therapy effect remained consistent with this in the subgroup with IV TPA contraindications. So if you have patients who have contraindications for IV TPA, these patients should still receive thrombectomy. That's absolutely clear. There was one study, Revascat, who waited a minimum of 30 minutes to assess the clinical effect of IV TPA. And it's also likely that this occurred in the Mr. Clean trial in a number of patients. But if you look at the group or the control population and interventional population and patients ineligible for alteplase and the patients who received alteplase, so the interventional population, there is virtually no difference in the rate of outcome. So we could look at this in more detail with aspiration, and stent retriever has been published very recently that it seems that if you do aspiration only, those patients do only good when they receive IV TPA. This doesn't seem to be so important for stent retriever patients, but this is a bit too complicated for our discussion right now. So what you see here is the control group, obviously. So ineligible for alteplase, so the therapy effect seems to be slightly higher, but this is not significant at all. Alteplase, yes and no. You can see it for yourself. no difference whatsoever in the effect size of thrombectomy. So mechanical thrombectomy should not prevent the initiation of IV TPA. This is still true because there have been several studies, so 6 of them have been published in the last 2 years, 2020 until late last year. And if they compared patients who could receive alteplase, but they were either given alteplase or not, because thrombectomy alone could be beneficial as well. And the summary effect of all those studies is that you have 2% poorer outcome in MT alone. So the combined IV TPA plus thrombectomy seems to be 2% better than thrombectomy alone. And the confidence interval ranges from 6 to plus 2%. So theoretically, thrombectomy alone could be even 2% better, but at the same time, 6% worse. So bottom line is that we should still give IV TPA in all thrombectomy patients if they are eligible for IV TPA. Again, this would deserve a separate discussion, but that's the bottom line of these expedited recommendations. You can download them of ESO and ESMINT, and it's a very detailed analysis and rationalization of what's going on. So to summarize, the golden patient, less than 5 hours with IV TPA, NIH 8 to 20, no upper limit. 0 to 5 should be enrolled into trials, pre-stroke MRS 0. We can also treat patients with MRS 1, 2, 3, maybe even 4. Less than 80 years is good, but very robust therapy effects also way beyond 80 years old. So no need to have an age limit. Okay, so we are always talking about the therapy effect, not necessarily the rate of good outcome. To exaggerate a bit, if we want to have a very high rate of good outcome, we should just do thrombectomy, you with me and I with you. We would have a very high rate of good outcome, but absolutely no therapy effect. There is no upper time limit for thrombectomy. Age limit is not justified. There's no general reason to exclude LVO stroke patients with a very high or very low NIHSS, but the low ones should be considered for a randomized controlled trial if possible, and give IV TPA if it does not delay thrombectomy and if it's indicated. Thank you.
Thank you, Jens. And I have here one question that good results in old age after mechanical thrombectomy, possibly due to atrophic brain. That's, I mean, the topic which we can speak about 1 hour. And
yeah, I don't know, but I think it's the clinical outcome is the point, and we have a very large difference between treated and not treated. And this is consistent over many, many studies. So you have the randomized controlled trials, you have single arm registries, and this is really very convincing. So no age limit.
Yeah, my opinion is that in these elderly patients, we have to be as much active to finish the procedure with very good recanalization. In a young patient, and I'm not saying that we should somehow finish in the middle in a young patient, since they recover anyway from the stroke somehow, having a reserve. But I mean, these reserves are not in these old patients. And if we have good recanalization, this is the main condition that they somehow can survive and recover and have a reasonable quality of life. If there is no recanalization or just the medium recanalization, these old patients, they usually have a poor outcome and low quality of rest of their lives. That's something
Agreed.
which, if atrophy is something which changes the game in this aspect, I don't know. We know that the volume of the brain in these elderly patients is not the same. Inside that, not so many neurons as in young population. But I mean, in volume on CT, it looks the same. So to me, I mean, we can count the volumes on perfusion CT and work the same officially. But I mean, the tissue is a little bit different.
Yeah,
maybe
I think we can treat all of this as a black box, if you will. So because whatever happens in between, whatever the reason might be, outcome A, outcome B, and it's very consistent. Yeah.
And regarding the mortality, if this early mortality is usually due to the brain death, and if it is late, that's usually due to medicamental or medical complications. That's a little bit different from the younger population.
Yeah, this is what we also saw with discharge MRS and the 90-day MRS. It took a long time, and I would expect even beyond 90 days, a lot of improvement, or not a lot of, but as a significant amount of still potential to improve in these elderly patients.
Do you think that the economy plays a role in certain countries in selecting patients with the upper age limit or any? I mean, you know, that's the sort of capacity of the hospitals, capacity of intensive care units, and
yeah, actually, I think so. I would not expect, let's say, order from the government, you must not treat patients older than 85 or something. But there is a kind of hidden agency from the physicians that feel, okay, we will find a reason on a management level not to treat this patient because of is a bit late or whatever. So we know all how it is. If we have a kind of reluctancy to treat somebody, we will always find a justification. And this might be the case. And or for instance, if you are just one interventionist or two interventionists and you do a lot of stroke treatments, maybe you say, okay, this is now the third patient of this night, and this is a 30 or 87-year-old patient with morbidity. Maybe I find a reason not to treat this patient. I think that's a kind of hidden process.
Yeah. And do you think that in the past published several prognostic scales just to label the patient in certain prognostic scale and score? And do you think that it works in a practice? Since I mean, 7 years ago we wanted to use them, I mean, just to predict what would be the outcome.
Yeah.
However, today, I mean, it's completely forgotten.
Yeah, I think so, because there are so many scales that are difficult to memorize and to apply. So there are several tools as well, some apps also. But I think in the end, if you have enough resources, we will end up in treating every patient. So if we compare it to another disease, what's the patient selection if you have a let's say myocardial infarction? So there is no, so you are just treated because you are sick. So just with stroke, we do this fancy selection stuff.
Okay, so thank you for now, and we'll be back in 30 minutes with you. And I like to switch to the Calgary, to Canada, and invite Petra to speak about, which is very attractive topic, the trials, and quite recent trials. So I'm wondering what's going on. So Petra, can you hear us?
Yes, I can hear you. Hello, everyone, wherever you are around the world and joining this course. Good morning from Calgary. This topic is actually a moving target, I would say, because every year you have a new data, new clinical trials are finished, and which are eventually changing the guidelines. This is supposed to be a brief overview, what we already learned, So let's start what we know. So I thought that the first revolution in stroke treatment actually was in 2015. Before that, until 2014, the IVTPA was the only evidence-based therapy of acute ischemic stroke, which showed a benefit and clinical outcome. However, with the intravenous thrombolysis, only about 30% of the patients achieved the full recanalization, and the effect of the thrombolysis is dependent on the clot length, localization, and the clot permeability. So we know that also intra-arterial thrombolysis works as the primary treatment. That was also the treatment which was tested and largely used. And we had the data on the efficacy of urokinase for large vessel occlusion strokes from PROACT data, which actually showed an improved outcome by 15% of those patients, and also improved recanalization. So yes, also intra-arterial thrombolysis was tested and it worked. So it also showed improved reperfusion in this meta-analysis. At that time, it's not a mistake. We didn't have the fancy and improved TICI score, but we still used the TIMI score, which is adapted from myocardial infarction, which eventually showed an effect for the interventional group. So the question is, so it works, why we are still using it as a primary treatment? Well, it takes time to give the intra-arterial thrombolytics. You give a little bit, you have to wait, then do a control DSA. So it's pretty slow. And in the meantime, there was a huge involvement and development of industry to work on the stent retriever stents. And in the end, we all want to feel like superheroes and have the recanalization achieved quickly. So as I mentioned, also the thrombolysis is dependent on the thrombus length. And it's known that if the thrombus is longer than 8 millimeters, the effect is significantly decreasing and there is a less chance to recanalize that vessel or dissolve the thrombus. So based on these data, the interventionalists believed that the mechanical thrombectomy is the way to go. However, the first results from IMS3, Synthesis, and Mr. Rescue actually showed no benefit of endovascular treatment when compared to intravenous or intra-arterial treatment. So it was a big disappointment at first, but there were identified the reasons why it failed. First, the patients with large ischemic changes were not excluded. Also, they use no CT angiography as a baseline to really know if the patients have the occlusion or where the occlusion is located. And also there was a mix of the treatment techniques. So stent retrievers were used only in minority of cases, and the dominant technique was still the intra-arterial thrombolysis. So based on that, the new trials were designed, and then we know what happened. So in 2015 happened the second revolution of stroke treatment, when it started with the Mr. Clean, and the other trials quickly finished the enrollment of the patient or preliminary terminated, because Mr. Clean showed a huge benefit of endovascular treatment. So ESCAPE, Extend IA, Swift Prime, and Revascat followed. And all these trials showed clear benefit of endovascular treatment over intravenous thrombolysis alone. It also decreased mortality in 90 days, and there was no difference in the symptomatic intracranial hemorrhage. So these are the results. So the first in IMS3, actually there was almost zero benefit of endovascular treatment, but here we have all these other trials showing a clear benefit of endovascular treatment when compared to standard care using intravenous thrombolysis. So since then, we actually established the mechanical thrombectomy to be a standard care. And it didn't stop there, because it was just the beginning of the new era. At first, so we have these data from the multiple trials. Do we know if it works in a large population? Because those were relatively selected patients. So based on this, all these data were put together, meta-analysis as called Hermes was performed, And again, it just showed a clear benefit of endovascular treatment in this population, and with the number needed to treat of less than 3 patients to achieve actually improvement on MRSK in 1 patient, which is one of the most effective treatment in medicine so far. And it also showed that most patients benefited from the treatment regardless of age and also regardless of aspects or NIHSS. So what followed? So we knew it works in the early window. Does it work also when patients present after the first 6 hours? So this answer was, or this question was answered by Dawn and Diffuse trials, which were published in 2018. Diffuse 3 actually included patients between 6 to 16 hours, and the inclusion criteria were based purely on perfusion mismatch. Dawn included patients up to 24 hours, and the inclusion criteria was a clinical perfusion mismatch. So there was a difference for patients based on the NIHSS and the size of the core. However, both trials again showed a clear benefit of endovascular treatment when compared to standard best medical treatment in these patients with no intravenous thrombolysis, because they are presenting after the 6 hours. So thanks to this data, the guidelines changed again, and AVT was recommended for selected patients who present in the treatment window. So we didn't stop there. So we know it works in the anterior circulation, but we were missing the evidence-based data for basilar artery occlusions. And this is what happened this year. So at the ESOC, the data from the 2 Chinese trials were presented. First is ATTENTION, which actually randomized patients within the first 12 hours. Intravenous thrombolysis were used in approximately 30% of these patients. Maybe if you're not aware, in China is actually a bit different. So patients have to pay for intravenous thrombolysis, and that's why just 30% of them usually got the thrombolysis in both arms, even though they were presenting in an early window. They actually, nevertheless, this trial showed a clear and huge benefit of endovascular treatment when compared to the control group. 46% achieve a good clinical outcome defined as MRS 0 to 3 when compared to control. There was a slightly higher incidence of symptomatic intracranial hemorrhage, but was not statistically significant. And also, there was a clear decrease in mortality when compared to the control group. So this was the ATTENTION. The BAUSH actually also looked at the benefits of endovascular treatment in basilar artery occlusions, but included patients up to 24 hours. So, and again, it showed a clear benefit of endovascular treatment, where the good clinical outcome was achieved in 46% of patients when compared to the control group. Again, there was noticed a mild decrease in symptomatic intracranial hemorrhage. However, still there was a clear decrease in mortality in these patients when compared to the control group. So we are extending the mechanical thrombectomy further, and right now the ESO and EXMINT are working together to create the guidelines for basilar artery occlusions treatment. So there will be some more guidance and clear recommendations how these patients should be treated. So as I mentioned before, so nowadays the mechanical thrombectomy is actually the most effective treatment in medicine as far as we know, compared, for example, to myocardial infarction. You have to treat 45 to 90 patients to actually achieve a good outcome, in contrast to 3 to 7 patients treated with acute ischemic stroke to achieve the good functional outcome, which is extremely low number, how you can improve the life of your patients. However, what we need to be aware for these data and these data from clinical trials, at first we were pretty much selecting the patients, which is actually shown on in these scales. So the more we were selecting, for example, Mr. Clean Escape and Extend IA, selection was based on presence of large vessel occlusion. The number needed to treat was 4 to 8 patients. When then compared with selection criteria were based on penumbra, you are actually decreasing the number of patients which you need to treat. So it means it's more effective, but it's more effective in more highly selected population. So we need to be aware of that, because that we were pretty much selecting the patient. So what are the new advancements in treatment? Well, we're still working on expanding the criteria for endovascular treatment. We are now investigating whether patients with low NIHSS or with very mild neurological deficits can benefit from the treatment, whether patients with low aspect or large core are benefiting from endovascular treatment, which is the tension, LASTA, and Tesla. The new target for endovascular treatment are medium or distal vessel occlusions, which currently ongoing trials are Escape Nivo, Distal, and Discount. And so based on this expansion of the criteria, we already know a little bit. So what's the importance of the ischemic core? So although it is important for prognostications of the patients, as actually the size of the core does not modify the benefit of the thrombectomy, and it was shown in the SELECT trial, and also in this data from the Australian group. They actually showed that there was a clear benefit regardless of the size of the core. So the upper rows are actually showing benefit of the endovascular treatment in ischemic, when the ischemic core was less than 70 milliliters, but the rows below actually are showing still a clear benefit of endovascular treatment, even if the core is larger than 70 milliliters. Yes, those patients don't achieve modified Rankin scale 0 or 1, but they are still getting quite a good benefits, and there is a definitely decrease in mortality of those patients. However, it needs to be noted, if there was no mismatch on perfusion, which means there was no penumbra presented, there was actually zero benefit from endovascular treatment. So yes, actually the perfusion could be a useful tool, but it should not be actually restricting the mechanical thrombectomy. It can help you to give you the prognosis of the patients. And these were the same paper or similar paper looking at the data. It was a meta-analysis of data from Hermes, Pistre, and Trace, which actually showed that based on the both perfusion or diffusion MRI, that even patients with large core were still profiting from the treatment when compared to standard therapy, even though with the larger core, the proportions or the likelihood of achieving good outcome were decreasing. So, and it was shown with that every 10 milliliters of increase in ischemic core, you reduce your odds for favorable outcome by 20 to 30%. So of course, the smaller the core, the higher the chance for the good clinical outcome, but it doesn't mean that patients with a large core can't benefit from the treatment. And this data also showed that actually when you have a core of 100 milliliters, there was still a chance for, or the absolute benefit to achieve the independent outcome was more by 24%, which is still pretty impressive. So how we use the aspects in stroke decision making. Well, the effect of age and aspect was also retrospectively analyzed in Hermes data, and actually it shows that endovascular treatment was effective in all subgroups, regardless of age and regardless of aspects, even though it has to be noted that in older patients with the low aspect score, the benefit was smaller, and there was a still majority of those patients unfortunately died. So this group is doing poorly in general, even though there was still some benefit of the endovascular treatment. But there's a question which actually also Jens Fuller was addressing, that these patients might be benefiting, but then there is this question of brain frailty and how to actually treat those patients so they can benefit from the treatment. This is actually the first BEARD, which is answering the question whether patients with the low aspects can benefit. It's the data from Rescue Japan Limit trial, which included patients with aspect score 3 to 5, which were, they were two groups. First, patients who were presenting between first 6 hours from last known well, or with the known symptom of onset between 6 to 24 hours with negative flare. It means there was no abnormality on the flare scan. They included 200 patients and actually showed a clear benefit of endovascular treatment, which was achieved like a good clinical outcome, MRS 0 to 3, in about 30% of patients, compared to 13% of patients who had the best medical treatment only. When compared to safety outcomes, there was a increase in any intracranial hemorrhage in the endovascular group. However, the symptomatic hemorrhage was relatively comparable, and there was not shown any statistical significance. And then again, they showed numerically lower number of patients who died when compared to the control group. So these data are promising, and the Tesla, Tension, and other trials were almost completing the inclusion and enrollment of patients will further hopefully support this finding. So improvement, how can we improve the endovascular outcomes? First, we can talk about how to use the thrombolytics. Either we can, the window for use of thrombolysis could be extended. We can consider withdrawing the TPA. Now there is the upcoming data or the changing of the approach with the tenecteplase. Or we can also again go backwards basically and consider again the use of intraarterial thrombolytics. We can simplify the imaging selection. First, we can take patients directly to angio, or we can also just consider whether trip and ship versus mothership is beneficial, or how to simplify in other way the imaging criteria. One question is non-contrast CT and CT angio actually sufficient in late window? There is a question of neuroprotection, and we can also discuss how to improve the technique. So extending the treatment window, well, we already achieved that. The data from EXTEND, ECAS, and EPITET trials showed the clear benefit of patients presenting between 4.5 hours and 9 hours with perfusion imaging actually benefited from the alteplase. So now we know if the patients still have some mismatch on the imaging and presenting in late window, it's safe to use thrombolysis, and those patients still can be treated. The same was basically the base for wake-up trial, which determined the effect of alteplase in patients with unknown time of stroke onset, which actually looked at the DWI flare mismatch, and again showed a significant improvement in functional outcome in patients who had DWI flare mismatch when compared to the placebo group. Next question, how we can improve the outcomes, is whether we can withdraw TPA. I will just briefly go through this. Jens was discussing this already. I just mentioned this. I wanted to just mention this, that we need to be aware what is the non-inferiority when we are talking about all these trials, that if we want to show that the new tested treatment is actually better than the standard treatment, then we are testing for superiority, and our effect estimate with confidence interval should be above the 0. If we are crossing the 0 but not meeting the non-inferiority margin, then our new treatment is non-inferior to the standard care. If we are actually crossing both our 0 line, neutral one, and as well as our predefined non-inferiority margin, then the data are actually non-inclusive. And if our new treatment is actually below the non-inferiority margin, then actually, unfortunately, our new treatment is inferior to the current data. So the bridging therapy, it all started with the Asian trials, DIRECT-MT, SKIP, and DEFT, which actually showed the DIRECT-MT and DEFT showed non-inferiority of endovascular treatment when compared to bridging combined therapy of IVT and endovascular treatment, and the SKIP trial, which was run in Japan, was inconclusive, which actually didn't show any benefit of withdrawing the IVTPA. So the Asian data were followed by European trials with Mr. Clean No IV and Swift Direct, which actually, again, didn't show the non-inferiority of the direct mechanical thrombectomy when compared to combined treatment of intravenous thrombolysis plus mechanical thrombectomy. And last week at the World Stroke Congress was presented the results of the meta-analysis of all these bridging trials when they combined the data. Actually, so they ended up having more than 2,000 patients in this meta-analysis. Unfortunately, they didn't show any clear benefit of direct EVT when compared to endovascular treatment and thrombolysis. So they were not able to show non-inferiority of direct endovascular treatment. However, there was an improvement in final recanalizations rate in the combined group in the price of mildly increased rate of any intracranial hemorrhage. So it seems like that intravenous thrombolysis and together with endovascular treatment helps to improve final recanalization rates in a cost of mildly increased risk of intracranial hemorrhage. However, these data can support the thinking if you have a tandem occlusion and you are considering to give the patients dual antiplatelet treatment, you might have now a background that it should be safe to withdraw the endovascular treatment, take patients straight to cath lab and start aspirin, give the stent, and you don't have a thrombolysis on board, so the risk of intracranial hemorrhage might be decreased. Use of tenecteplase. So there are now coming the data from the trials proving that tenecteplase is actually non-inferior to alteplase and could be interchangeable. The ACT trial was a large Canadian trial which actually included 1,500 patients around Canada and proved the non-inferiority of tenecteplase to alteplase with no difference in symptomatic hemorrhage or mortality. So these are very promising data, and we all know the benefits of tenecteplase. It's just a single bolus. You don't have the running infusion for 16 minutes, and it's also a potentially it's a suitable alternative, especially in Asia, because tenecteplase is cheaper than alteplase. So hopefully more patients would be able to afford the treatment. Intra-arterial thrombolytics, as I mentioned at the beginning, we knew it worked as a primary treatment, even though it never achieved such a high rate of recanalizations when compared to mechanical thrombectomy with stent retrievers, but could be an option to give intra-arterial thrombolysis as an adjunctive treatment. And we have data from CHOICE trial, which actually showed a huge benefit of intra-arterial thrombolysis in achieving an excellent outcome, MRS 0 to 1, showed no difference in infarct growth or final infarct volume. what is actually interesting in these data is that the huge benefit was actually seen in the patients with complete recanalization on DSA, which kind of suggests that the intra-aortic thrombolysis might be targeting micro occlusions which are not identifiable on DSA. However, we need to be cautious about these results because there are certain limitations of this trial. First, there was lacking of precision. They had a relatively small sample size, and we know there is a certain overestimation of the treatment effect when the trial is permanently terminated, which is the case of a choice trial. And they are potential confounders because if you look closely into the data, basically the patients in the IVT treatment group were treated faster than the patients who did not receive the intra-arterial thrombolysis by 40 minutes. And we know the time is brain. So potentially those patients were just treated faster than in the control group. And another thing to consider is that actually it allowed premature termination of intravenous thrombolysis. So it's possible, there's a certain possibility that some patients actually didn't receive the full dose of intravenous thrombolysis, and then the intra-arterial treatment might have been just replacing this withheld thrombolysis, and therefore we've seen that huge treatment benefit. Simplifying imaging selection, so direct to drip and ship versus direct to angio. So we have some data available, which actually is showing a clear benefit of direct transfer to the comprehensive center, specifically saving time on the inter-hospital transfer. So actually, we don't want to delay the treatment. So the retrospective data from SWIFT Prime actually were in favor of direct transfer to comprehensive center. However, the RACECAT, which was a randomized trial in Catalonia, actually did not show any clear benefit of direct mothership transfer when compared to drip and ship. And but what this trial showed was actually that they were very well organized and they achieved very short door in and door out time in the primary centers. And I believe that might be the way, not to avoid the primary centers, but just work on the overall management and just get the patient very quickly from the primary centers and transfer them to comprehensive centers, and don't lose time while waiting for the ambulance to come and transfer your patient. So direct to angio, this is an interesting concept to avoid going through CT or emergency department and taking patients straight to the angio suite. There are data again from Barcelona, which actually included 170 patients and showed that actually direct to angio protocol decreased the overall workflow time and quickly achieved reperfusion. And in the end, they actually showed some benefit also in the clinical outcome. There was a meta-analysis of almost 2,000 patients, which again showed significant decrease in treatment times. However, they were not able to show any benefit on the clinical outcome. So there is again how we can improve the treatment, how we can improve the patient's clinical outcome. One solution might be mobile stroke units, which are actually showing that patients who receive thrombolysis right in the mobile stroke units are actually achieving a better clinical outcome when compared to patients who are transferred by the standard ambulances and receiving the thrombolysis in the primary or comprehensive stroke centers. So this might be another way how we can improve the overall outcome of patients. So is CTA sufficient for selecting patients in late window. So far, based on the diffuse and dawn data, the recommendation was to select the patients based on the perfusion. However, looking first BIRD to showing that probably might not be necessary was the retrospective analysis of ESCAPE-NA1 data, which look at the data from patients presenting between 6 to 12 hours. And when the outcome was compared to diffuse and dawn arm, actually the outcome was comparable. And ESCAPE-NA1 did also used only CT and CT angiography and collateral assessment for patient enrollment. And the biggest data available right now were presented last week at World Stroke Conference, Mr. Clean Late, which actually again enrolled patients between 6 to 24 hours from last known well. The only imaging inclusion criteria was the assessment of collateral flow, with the fact that they wanted to include maximum of 100 patients with poor collaterals, but otherwise they include patients through the whole spectrum. There were no aspects restrictions. And what's interesting, they actually excluded patients that would be meeting dawn and diffuse criteria, because those are supposed to be treated anyway. So those patients got treated. So it means that actually Mr. Clean Late look at the patients with the larger ischemic core than in the dawn and diffuse trial, and they showed a clear benefit of interventional arm when compared to the control arm. So this actually means that maybe we were actually, and this is proving that we have been over-selecting the patients, and we can just indicate the patients based on the CT and CT angiography. The question of neuroprotection, you all heard about, I believe, about ESCAPE-NA1, which was the first trial testing the effect of neranetide on clinical outcome. Unfortunately, in the overall patient population, there was no clear benefit of neranetide when compared to the placebo group. However, looking at the data more closely, in the patients with no alteplase, there actually the benefit was shown, and there was actually proven the interaction between the neranetide and alteplase. So these data were unfortunately affected by the thrombolysis. And so in no alteplase group, we can see that there actually was improvement in the clinical outcome. And there was actually also the significant decrease in mortality, and there was a significantly smaller infarct volumes. So this data or sub-analysis of no alteplase group actually led to the design, the ESCAPE Next, which is looking at the effect of neranetide only in patients who are not receiving alteplase. And actually the data from ESCAPE Next will be available next year, because the trial is just finishing the enrollment. So improving the technique, this is what Jens Fieler has been discussing. We can then discuss what is better, standard weaver alone or aspiration. The COMPASS showed that aspiration works as well. ASTER 2, we're looking at the standard weaver alone versus combined treatment of aspiration and standard weavers, again showed that both treatments are effective and can achieve the good recanalization. How to further improve the technique? There is another question whether we should use the general anesthesia or conscious sedation. The first data from Hermes actually were showing that general anesthesia might be harmful to patients. However, those patients were there was a selection bias, because patients who were treated under general anesthesia were basically more sick and doing worse. That's why they were treated under general anesthesia, and there was no standardized protocol how to manage the blood pressure and so on and so forth. And in contrast to that, a couple of randomized trials actually showed that general anesthesia is either comparable or even mildly better. And this question is again valid, because especially in treatment of the distal occlusions, you might be considering the general anesthesia because you need to get a good DSA map to navigate in the periphery, and when the patient is restless, then it's becoming more challenging and you are increasing the risk of perforating the vessel. So the general anesthesia is again the question we are discussing, whether it's beneficial in patients with MEVO and distal occlusions. So this is just a brief overview of the ongoing trials. So low aspect, low NIHSS with narrow protection work, medium distal vessel occlusions, and the effect of tenecteplase, which is a techno trial in the intra-arterial tenecteplase for non-complete reperfusions. So this will be trial looking, basically repeating the choice, but with the tenecteplase and only in patients with incomplete reperfusion. And Tempo 2 trial, which is looking at the effect of tenecteplase in patients with low NIHSS. So as I started this presentation, endovascular treatment and mechanical thrombectomy and treatment of stroke is a moving target. We are getting better and better, but there is still room for further improvement. Thank you for your attention. I'm happy to answer any of your questions. And if you are starting a research or you are interested in stroke research, just visit the Collavidence, which is a new platform for collaboration and improving the funding of the stroke research. Thanks.
So thank you, Petra. That was a complete survey of ongoing trials and the previous one and the 3 stages of revolution in this therapy. And I do believe that the stroke therapy is a very well studied topic. And my question is, speaking about the tenecteplase and alteplase, that's as I am correct, that it's manufactured by one producer. Is that right?
I'm not sure about it. I think you might be right, but you probably know better than I. I just am aware that actually the tenecteplase for some reason seems to be cheaper and more available than alteplase. And there are those benefits, as I said before, the tenecteplase is just one bolus rather than running the alteplase.
Easy to be handled and it's promising. Yeah. And, you know, from time to time there are news that the alteplase will not be available for a while, since that they have a problem with logistics, which makes me scary a little bit. And
That's
okay,
true.
so if you have any questions, since you have another lecture about the MR in stroke, so we will postpone since there is a little bit delay on the YouTube. And since we are a little bit behind of schedule, we will switch to another speaker and we will see you in 1 hour.
Okay, sounds great.
Thank you. Thank you. Now I will turn to Hamburg, to Jens. And this will be a very philosophical lecture about how to do, and I think like a deep diving into the design of these studies. And so, I mean, gives you maybe how to prepare for studying in your own hospital and your own group of patients. So Jens, please go ahead.
Yep. Thank you. So I'm trying to be a bit short if I'm able to do this. It's, as Tony said, it's very complex subject, and I removed already some slides and just share some thoughts with you about what we can learn from studies. So why do we need studies at all? Because if we just look at things, we can have surprising results, just like this. If we make the correlation between the per capita consumption of cheese and the number of people who died by becoming tangled in their bed sheets, it seems to be a very close connection between the two of those. So eating cheese seems to be super predictive for people who died by becoming tangled in their bed sheets. And another similar analysis, a number of people who drowned by falling into a pool per year is very closely connected with the films Nicolas Cage appeared in. So just looking back and see what's going on cannot can tell us some strange stories. So we need to actively design studies with designs and control groups to really make sense of things. All the rest of it is just exploratory. I think that's very, very important. And we don't have a very glorious history in terms of clinical studies. So if you think about the glorious past of neurointervention, so you had a few heroes who decided what's right and wrong, and that was just it. So we had very few studies. So the first studies we had in neurointervention was the ISET study, and it was the single most important study for a decade. And we have this other problem in neurointervention that Chris Cognac called the Viagra effect of neurointerventional case series, that we have a kind of competition. Who has the lowest complication rate? Who has the highest success rate? There is no external data monitoring. And then you have those eloquent opinion leaders. And then we start to believe ourselves how good we are and how great we are. And then we end up in a big mess, like in the Semprus study with intracranial stenting, where we believed we were much better in our results. And then we ended up in a disaster that like intracranial stenting was almost abandoned in many parts of the world because we designed the study in a wrong way. And this is not new, because this is what they call the comic opera of surgical research. And it was published exactly or almost exactly 100 years ago, that statistics of operations is actually very difficult, and surgeons are not necessarily the people who are most interested in statistics. And we end up with studies like those ones in 2013 that were designed not by neurointerventionalists, that oftentimes not even required the proof of an intracranial artery occlusion to indicate a thrombectomy. So very disappointing results. And then we had this conclusion by some commentators that IV thrombolysis should be the first-line treatment within 4.5 hours, even if imaging shows an occluded major intracranial artery. And it's always, or oftentimes, explained as we are the guardians for the evidence and take care of what's right and wrong. But who guards the guardians? That's an age-old question, thousands of years old. And we need to take care of it ourselves. So there is no other way than we need to be involved into designing the studies. It can be frightening at first, but we need to learn it. So beware of surgical trials organized by non-surgeons. And this is, as I said, a very well-known subject. And it has also to do with something like academic seniority. So this is a very nice, fun formula. The volume of hot air in evidence-based medicine is dependent on the distance from a patient, academic seniority, and time from graduation. So the longer time from graduation, the higher the volume of hot air. So then we were, I think, essentially lucky with Mr. Clean that we had stent retrieval, and they were so overwhelmingly effective that even in the study that was not necessarily designed in a very straightforward way to be a winner trial, it was a very wide pragmatic study design, and it was still successful and was hugely influential for our subject. But still, we have the problem with participation in randomized controlled trials. It's either uncommon, that's one of our major problems in neurointerventions, patient preference, so there is no real equipoise, surgical preference, and some methodological issues. So maximum of less than half of the surgical questions can be answered by randomized controlled trials, but we should focus on those. So another question is always, why do we need less proof for devices than for drugs? but it's really more difficult to do. So medical devices are not just administered. Who administers the intracranial stent? It requires a lot of skill and training, and this is heterogeneous. And who gives you the aspirin probably doesn't matter too much. And then the research and development models are different between devices and drugs. So you have medical devices are evaluated for efficacy and safety, and they have also shorter product life cycles. Typically, you have a life cycle of less than 2 years, and then you have another type of stent or another detachment system, and it's iterative, unlike a drug that has a life cycle of 10, 20, 30 years without any modification of the chemistry. I think it's just a different area, and this is a subject that requires an additional discussion, but it makes things more difficult for us, and we need to be more agile with our studies in the field of medical devices. If we now think about study statistics, and I think that's one of the major slides of the presentation here that you might try to memorize. So the confidence in the trial result is the signal by the noise. So a very high signal can tolerate a lot of noise. This is what we have in Mr. Clean. We have a very high treatment signal, and even the heterogeneity of the patients, the noise, no restriction by aspects and so on. Even then, we had a very high confidence because we have a high signal. And this is modified by the sample size. So the larger the sample size, the higher the confidence. But this is the square root of the sample size. So as I mentioned, the noise is the uncertainty, the sum of all factors, the sources of variation. So if we want to be confident in the treatment effect, we want to typically decrease the noise in a study, like narrowing down just aspects 8 to 10, only 3 hours after symptom onset, only M1 occlusion, only patients between 18 and 60 or something like that. And this reduces the noise, but at the same time, it also reduces the sample size. So this is always a balance between more homogeneity in the data and fewer patients that could be included. So if you think about designing a study, you want to create a high confidence, and you need to balance these factors, and doing some simulations might help with this one. One other problem, and this is what I mentioned already with the interventionalists who are an important part of a study, is, for instance, the ASTER study. So the ASTER study was a randomized controlled trial comparing aspiration with stent retriever as first-line therapy. Success was higher in the stent retriever group than aspiration group. After all, there was no superiority of aspiration. This was the trial design. But what's the problem, let's say, with the ASTER study? Let's say you include a physician or a center who have a preference for stent retriever. They have a good reperfusion, 73%. And if they have to use aspiration, even if they don't like it as much, they have only 56% within the study. Other center aspirators, super aspiration specialists have good rate of reperfusion with aspiration 76% and only 63% with stent retriever. And as a summary study result, you have 68% stent retriever and 63% aspiration. So what do you do with that? What does it help for those stent retrievists and aspirators? So this is really a complex thing. And if you think about the treating physicians in the trial, it really depends on the composition and the treatment preference. So aspiration physicians are in the minority here. And you probably will have a superiority of stent retriever outcomes. And this is specifically true if you have a new method that is not widely used And you start with using this method very early in the development of this method, and you end up maybe with a randomized controlled trial that shows the inferiority of the new method just because physicians are not trained for it. So the results of the trial could be completely different if you do it in 2012 or 2019. And this is, I think, a major concern for new therapy. And they did it correctly, for instance, in the COMPASS trial, which had a balanced center preference. So 6 had a preference for aspiration, 6 had a preference for stent retrieval. And you are probably not surprised with the outcome. Unlike the ASTA study, there was a very similar rate of good outcome in both groups, and a very similar rate of T2B or greater in the first pass, because centers were used to both methods equally. And in general, if you think about designing a study, so I mentioned this already with the guidelines, you have to take into consideration the patient, the intervention, the comparator, and then the outcome, and then finally also the time. So time plays a very important role. When exactly do you include the patient into the study? When you insert the device, or before the patient is treated at all, or even with some studies after the fact, the patient needs to give the approval of being enrolled into the study after the treatment has been done. So the data are submitted only if the patient agrees. What does it mean? Only patients who are able to agree are included. So there is a mortality of 0. So this is extremely important if we think about the study. So I think this P code thing makes a lot of sense to think about what the characteristics are of the study that we are designing. And then one word now, it's not really mathematics, but I think it's very important to understand this, the famous odds ratio. So this is what was published for Mr. Clean. The adjusted common odds ratio was 1.67. What does this mean? I am trying to explain. So this is the probability of 1 out of 6. And if you roll the dice, and the odds are the 1 by 5 chance. So probability is 1 out of 6, and odds are the ratio of 1 or one of the other 5. So this is different, probability and odds. Okay. There is a different meaning of odds with bet. This is different for the US and UK, for instance, but I don't want to go into this detail. So let's just use Swift Prime as an example. So they enrolled 191 patients, 91 into thrombectomy and 93 into IV alone. And the rate of the good outcome were 59 here, 33 here, poor outcome 39 and 60. So we have 59, 39 poor outcome, 33 IV good outcome, 60 poor outcome, 89. Okay, so if we look at this now and we compare 59 versus all of this, this is now the risk. The risk of good outcome is 60% in thrombectomy and 35% with IV TPA. And this is the risk ratio, 0.60 by 0.35. The odds are 59 by 39. Remember the dice. And then you have the odds here of good outcome is 1.51, and the odds of good outcome here are 0.55. And now, believe it or not, you have the odds ratio. The odds ratio here is 2.75. This is the odds ratio. Okay? So the relation between good and bad, and then the relation of the relations, because that's the odds, and this is the odds ratio. So if you subtract 60%, 35% from 60%, you have an absolute risk reduction of 25%, so therapy efficacy, and the number needed to treat is 1 by 0.25, so it's 4. 4 patients need to be treated to have one more good outcome. So let's compare this to a hypothetical study. 11 good, 39 bad, 4 good, 89 bad. So 15 good, 178 bad. And the risk is 0.11 and 0.04, and the ratio is 2.56. And now, what do we have? Odds ratio of 2.75. It's exactly the same like here. So the absolute risk reduction is 7% only, to compare this, and the number needed to treat is 15. Okay? But the odds ratio is the same. So we should be very careful in saying this study has the same odds ratio like this study, therefore the therapy efficacy is the same. So please don't overestimate the odds ratio. I think it's actually not a very good choice for a statistical variable. You have a number needed to treat of 15 versus 4. Super effective here, limited efficaciousness here. So please, my key message, you don't need to understand all of this, but just see that same odds ratio, widely different therapy efficacy. So I think I skipped this part. So the basic study result expressions are the relative risk is the share of good or bad outcome, and the odds is the ratio of good versus bad. So this is share of the whole thing, and this is the ratio of good versus bad. So think about the cube 1, 2, 5. Odds ratio is the ratio of ratios, and the absolute risk reduction is the difference in the good in both arms, and the number needed to treat is 1 by absolute risk reduction, is the number of patients to be treated to save one of them. I think if you take this away from this presentation, this would be, I would be very glad to see that, because most of us are not very interested in this kind of stuff. But maybe if there's one message, don't compare odds ratios between studies. It's overly sensitive. Some other things that I would like to mention very briefly. So intention to treat versus per protocol analysis. So example, how would you deal with patients in a thrombectomy trial where vascular access is not achieved and where thrombectomy is actually not performed? In the intention to treat analysis, you would enroll all the patients, also the ones where you didn't even get anything in. And in the per protocol analysis, you would only you would analyze only the patients who actually received the thrombectomy. And this both has advantages and disadvantages, but the standard is really to use the intention to treat analysis, because then otherwise you could have a selection bias. And this is what I would like to mention briefly here as part of this presentation. A bias is a systematic error. It's not random, because the study is biased in a way to show something. This error encourages one outcome over the others. And the potential effect of bias is that investigators will come to the wrong conclusion about the beneficial and harmful way of intervention. So I skipped this part. So one of the biases that I would like to mention is something that we discussed yesterday, this survivorship bias. You remember this time thing that when I said, if you include only the patients without infarct, time is not important. But if you include all the patients, also the ones who developed infarcts over time, then time starts playing a role. You have this time reset effect in this subgroup. And it's really important to understand that with certain trial selection criteria, we include or introduce a lot of bias. Other biases are selection bias, detection bias, attrition bias, denominator bias. But I don't want to torture you with this kind of stuff right now. Just to summarize, structured observations studies are a different thing compared to experience, because this can be way misleading if we just look at uncontrolled data. They can be valuable if done correctly, but a study is just the next level. So trials actually change the world. I don't need to tell you, this is most likely the reason why you are participating in this course, because all the trials have been positive and all the thrombectomy treatments are now done on this planet. Trials of interventions are a different thing than drug trials for several reasons, because of the interventionalists and also because of the different development, let's say, habits of drugs and devices. P-code, so patient intervention, comparator, outcome time, are the most important factors for designing trials. There is a huge difference in intention to treat versus per protocol analysis, and beware of bias. And again, the one key message, don't compare odds ratios between trials, because they are just not really comparable. Thank you.
Thank you, Jens. That's, as I predict, was very nice, and we have to be aware of that and start to think about these trials, and don't trust to anything, and just that something which is, we stay on the surface and not go to the deep in these data. And what do you think will be the future in stroke? Yesterday we a little bit mentioned this topic, and it seems briefly that we extend the indications, and what the task for next 2 or 3 years in endovascular stroke therapy.
Yeah, so I personally think that we will further enlarge our indications. So large core patients will be enrolled, late time window patients will be enrolled. But at the same time, we will consider also other concepts, like giving additional IA, TPA, like in choice trial, neuroprotective agents, and other things that maybe require, again, patient selection, not for thrombectomy, but for these additional treatments. Because first we need to be narrow. Remember this physiological statistics formula. We need to be relatively narrow with applying these maybe very expensive drugs in the beginning. And if we see that they are working, we can gradually expand their application. So my prediction is we will have a very wide indication for thrombectomy. Almost every patient with an LVO will be treated with thrombectomy, and beyond that, also the distal occlusions more and more. But we will have the next wave of therapy coming, where we need to narrow down, not for thrombectomy, but for the other therapies. This is my thinking.
Okay, so I have here not a question, but just maybe the message, which is coming from Robert. Amazing. So thank you, and this was your last lecture, and thank you for joining us and for your contribution to this course, which you started with also from the beginning, and see you probably in the next part in Prague.
Oh, I would very much looking forward to this. Thank you, Tony, for all your all your support for this course. Wonderful. Have fun. Thanks.
Yes, we will.
Next time with beer.
Yeah. I personally enjoy it pretty much. So, so thank you once again. And now we will have a 20 minutes coffee break, and then we'll be back with better about the MR and stroke, MR diagnosis and stroke. Hello, back again, and we are ready to start the last session of this afternoon. And we will have a very important topic about MRIs, already discussed with Pascal Mordassini, since they used MR as a first choice imaging technique in a stroke. And I don't need to introduce Petra Simflova from Calgary. So she will speak about MRI in stroke, in ischemic stroke. So Petra, can you hear us?
Yes, I can hear you.
Right.
I hope you can hear me and see my screen. So hi again. I hope you had some coffee and refreshed yourself. So we will talk about the stroke imaging. I will start with the basic question. Why we actually need a stroke imaging? Well, we all are aware that the time is brain, and with every minute of lasting ischemia, we are losing about 2 million of neurons. And how to prevent that? We can revascularize and preserve this brain at risk. But to do that, we should actually know, identify those patients who are actually having a stroke and target the treatment. So what do we do with the MRI protocol, which might be comparable to CT? First of all, based on the guidelines, although it's known that DWI is more sensitive than CT, it's actually it is considered not to be cost effective in a majority of patients, and CT is still preferred method. However, MRI is highly recommended in selected patients during the 6 and 24 hours from the last known well who have large vessel occlusion in the anterior circulation. I would actually enhance and widen this statement, because there are definitely centers who prefer MRI and who actually, and we can discuss what are the clear benefits of MRI over CT. So basically, the essential questions what to define on MRI are same as for CT. So we want to detect ischemic changes. We want to exclude the presence of hemorrhage. Ideally, with the vessel sign is present on MRI, we can also identify that, and we want to know where the occlusion is. So we need to know what is our target for treatment. So comparing the CT versus MR, well, on MRI, the ischemic changes actually could be detected within the first minutes after the stroke onset. When contrast to CT, you are aware that actually when the patient is coming very early after the symptom onset, there might still not be any changes visible on the CT, which are actually detectable after first 45-60 minutes. MRI is unfortunately still slightly slower when compared to CT, but with the evolution of the technique and further advancements, the protocols are getting faster and the times are all getting to be comparable. Still, the CT appears to be more available. The majority of centers still have the CT available 24/7 in majority of places, and it's less restrictive because we still need to be aware if the patient has a pacemaker, it can be examined with MR in the acute phase. There is no radiation in MRI when compared to CT. And these are the clear benefits of MR over CT. It has a better or high detection of strokes in the posterior fossa. It's also much better in detecting small lesions and distinguishing the stroke mimics. When we look at the angiography, actually, it has a benefit that we don't need to use the contrast in majority of cases for intracranial vasculature. However, it has a slightly worse resolution when compared to CTA. Here we have one exemplary case when we can look at the benefits of MR. This was a 72-year-old patient who presented with diplopia. He had in the past a stroke in the vertebrobasilar circulation. His admission MRI was originally reported as negative, and with the time he developed paresis of the right abducens cranial nerve. And he had a follow-up MR in 3 months, and you can notice this little tiny punctured lesion with a high T2 signal, which is also detected on FLAIR. So, and it's actually in the exact location where there is a nucleus of the abducens nerve. So could that be, it would actually arise the possibility that there was actually a focal infarct within affecting the nucleus of the abducens nerves, which would also explain his clinical presentation. And looking retrospectively back on his initial MR, even though it's very tiny, and if you don't know where to look, you might not notice, but there actually was some mild signal change in this area and restricted diffusion. So MR is really good in detecting even there's such a tiny lesions, but sometimes could be tricky, and you might actually identify your lesion backwards. So with the diffusion-weighted imaging, this scan is based on the measurement of random motion of water molecules within the voxel of the tissue. So that means that actually highly cellular tissues, such as some high-grade tumors or lymphomas, will have less or decreased diffusion, or the cellular swelling will exhibit a lower diffusion. That means basically the principle of detection of ischemia on DWI is in detection and visualization of the cytotoxic edema. Because with the ischemia, the cells are unable to maintain the sodium-potassium membrane pumps, which leads to actually accumulation of sodium within the cells, which along the osmotic gradient pumps the water together with the chlorine inside the cells, leading to the cytotoxic edema. So then actually the water molecules in the extracellular space can no longer freely move around, which leads to restricted diffusion and increased signal on DWI. So that's our principle. And with the always comes together with apparent diffusion coefficient, which is a calculated map, which expresses the magnitude of diffusion and actually reflects the degree of diffusion or restricted diffusion. So how the stroke evolves with the time. In the acute phase, the ADC parameter reaches its lowest or maximum reduction within the first 24 hours. DWI signal is very high. So that's the bright signal on DWI and low signal equaling low values of ADC. With the time and the subacute phase, the ADC values are rising and returning close to the baseline. However, the DWI signal remains high due to the vasogenic edema, which evolves together with the cytotoxic edema or shortly after, and this is the effect of T2 shine through. So there's no longer present the cytotoxic edema, but it's majority of the vasogenic edema around the ischemic lesion. In the chronic phase, sorry for that, actually ADC values still remain high or switches and remains high because the infarcted tissue actually turns in, there's evolving encephalomalacia and there is a lot of cerebrospinal fluid within that area, which actually enables the free movement of water molecules there. So that's why the ADC value is actually high. So it's not restricted diffusion, but more likely free diffusion in that area. And DWI signal progressively decreases. So this is how we can also use DWI and ADC to establish the age of the infarct in patients who might have a multiple embolic infarct, and you actually see the differing aging of the lesions. Some might be very bright, some might have a very low ADC values, some might be already normalizing. So then you know it's a very mixed pattern. Not all infarcts are acute, and you can then search for your source, for the source of those infarcts. Fluid attenuation recovery image, or T2 flare, is the sequence which actually removes the signal from the cerebrospinal fluid due to the long inversion time. It's a great sequence to visualize the brain edema, which appears as a signal abnormality, doesn't distinguish cytotoxic and vasogenic edema like DWI can. So any edema on flare will have a bright signal. Signal abnormality in stroke occurs usually between 6 to 12 hours after the stroke onset. And we can also use FLAIR to identify FLAIR vascular hyperintensities. So because of the slow and stagnant blood flow, it will result in a loss of flow void within those vessels. You can see it in this image in the left hemisphere. So the more extensive collateral circulation can be noted, and it could be indirect sign of the vessel occlusion. This vascular hyperintensities are actually also used as a marker in moya-moya disease in children. When you can define these slow flowing and stagnant blood flow within the collaterals on the affected hemisphere. And not only you can use the FLAIR to actually see how is the stroke evolving, it's also a great tool to evaluate the burden of the underlying chronic white matter microangiopathic changes. And as you already heard and as you are aware, thanks to the differences of occurrence of the ischemic changes on DWI and FLAIR, we can basically establish the tissue window in contrast to the time window when there is a signal presented on DWI, but there is still no change in signal on FLAIR, which was actually used in a wake-up trial, which was already discussed. Also, I mentioned it as well, which evaluated the treatment effect of alteplase in patients with unknown time and showed a clear benefit in patients who had still the DWI and FLAIR mismatch. So here we have examples of the FLAIR mismatch on the left. So there is already seen a restricted diffusion represented with a high signal on DWI, but there is no signal abnormality on the FLAIR. So based on this, we can establish the time of stroke onset between below the 4.5 hours, 5 hours. And on the other hand, on the right side, we have restricted diffusion on DWI and already abnormal signal on FLAIR, which means that this stroke probably occurred more than 6 hours ago. T2 gradient echo sequence or susceptibility whitened images are used to identify calcifications or blood products. This sequence is actually based on the fact that either paramagnetic, diamagnetic, or ferromagnetic elements are distorting the local magnetic field and eventually results in the loss of signal in these regions. So whether we have their blood or calcifications, they appear very dark because there is no signal from these areas. And it's used therefore for detection of these compounds, and we can also use it for detecting the thrombus, which is called so-called susceptibility vessel sign, because the thrombi with a high content of red blood cells also distorting the local magnetic field and will appear as this focal loss of signal. And it was shown in this paper by the French group that actually the susceptibility vessel sign is comparable to hyperdense vessel sign, as it also represents the clots with high content of red blood cells, which is a useful information for interventionalists, that they know that most likely the standard viewer technique might work, that they are not facing the high rich fibrin thrombus or thrombus with a high content of platelets, which usually we know that it's might be difficult to approach and might be better to use aspiration or combined technique or standard viewers which are dedicated for fibrin-rich clots. So MR angiography, there are 3 different techniques. First is time of flight, which is the most commonly used technique for intravascular, for imaging of the intracranial vasculature, sorry. So it's a non-contrast technique, and it's actually based on the inflow of unsaturated spins into the tissue. So at the beginning, as we know, if we place the tissue into the magnetic field, all spins are synchronized. After the pulse, after the radiofrequency pulse within the slice, there is a distortion and desynchronization of those spins, which are slowly returning back to its baseline state. However, as the blood is a moving target and flowing medium, there are actually the new and fresh unaffected spins coming to this area, and result in a higher signal from the blood vessels when compared in contrast to the surrounding tissue. So that's the base for this technique. It is dependent on the flow direction, and it could be therefore influenced by slow flow or turbulent flow, which might lead to some artifact. And it tends to overestimate the degree and length of the stenosis, so we need to be aware of that. And because of the dependence on the flow direction and the magnitude of the flow, the distal vasculature might not be accurately visualized. So that's a limitation of time of flight, for example, to identify the M3 and M4 occlusion or occlusions in the periphery. Another method is a phase contrast angiography. It's also a non-contrast technique, which derives contrast between flowing blood and stationary tissue by switching the phase of magnetization. Here is the video. So we have this mobile spin of the blood, and then we switch the magnitude. And because we have now two different values, because the stationary spin is less affected by the switch of the magnitude, and the mobile spin actually creates this phase shift, and that's the source of our signal in phase contrast angiography. It's a very useful method for venous thrombosis detection and for venograms, because there is a significant signal loss due to the turbulence flow or intravoxel dephasing phase. So that's why the phase contrast is used more for venograms and detecting the venous thrombosis. The third method is contrast enhanced MRI, which is actually independent of blood flow, therefore has a less artifacts from turbulent and slow flow. So it's mainly used to visualize extracranial vasculature and to detect cervicocarotid and vertebral artery disease. And here we have an example of multifocal stenosis, both affecting the anterior and posterior circulature. And all these methods or advances in MR angiography, basically the standard angiography, both in MRI, actually assess the luminal abnormalities, which means we are looking at the whole of the donut, but the vessel imaging actually enables to look at the dough of the donut itself, because we can then say more about the etiology of the disease rather than just saying, oh, there are changes in the caliber of the lumen, or the lumen is irregular, so we can better identify what is actually cause of these changes within the lumen. For vessel imaging, it actually requires very high spatial resolution. So it requires the high magnetic field strength. So it's currently performed either on 3 Tesla or in 7 Tesla MRI. The technique used for vessel imaging actually suppresses the signal from the flowing blood. So it's called a black blood sequences, together in combination with suppressed signal from surrounding tissue. So fat saturation within the neck and suppression of CSF signal intracranially. And based on the vessel imaging, it actually enables to distinguish the etiology of the changes, such as atherosclerosis, vasculitis, RCVS, which is reversible syndrome, or vasospasm syndrome, dissection, intracranial aneurysms, and moyamoya disease, based on the eccentric or concentric thickening and also on the pattern of enhancement. So atherosclerosis typically have eccentric thickening and heterogeneous enhancement, in contrast to vasculitis, or which is actually has a concentric thickening and concentric enhancement. RCVS does not enhance. And for example, dissections also have eccentric thickening due to the intramural hematoma, we can identify the intimal flap. And dissection is tricky because it can enhance or doesn't have to enhance. So sometimes it still could be challenging to distinguish dissections and atherosclerosis. However, if you're uncertain of the etiology, the vessel wall imaging might be really useful for further management of the patient and for differential diagnosis. Here we have another example with how what we need to be aware in vessel wall imaging. So the example in the upper row, so on the left is a pre-contrast, on the right is a post-contrast image. Actually, it's showing like a concentric thickening and mild enhancement of the vessel wall, but those are actually just reactive changes after mechanical thrombectomy. So be aware of that after the stroke treatment, that actually the standard weaver is irritating the wall and what might lead to or is leading to temporary changes of the vessel wall. In the row below, we have this thickening of the wall and actually eccentric enhancement, which is typical for atherosclerosis. With the vessel wall imaging, we are also moving forward with carotid plaque characteristics, which can be distinguished. We are able to distinguish rich lipid core, fibrous caps, or calcified plaques, which is on the post-contrast scan, the lipid core is not enhancing. On the T2 fat saturation scan, we can distinguish better the eccentric thickening. This is the time of flight. This is what I mentioned before. The time of flight actually just shows you the luminal changes. So we just see the whole of the donut, but we don't really know what's happening with the wall. However, it still could be useful to see any intraplaque ulcerations. And on the MP range, which in this case appears completely dark, that's the sequence which actually identifies the intraplaque hemorrhage. And in case if there is a hemorrhage present within the plaque, it will appear as a bright signal on this very heavily lighted T1 scan. So what we need to be aware with MRI imaging, you probably heard about this phenomenon, which is DWI lesion reversal. It actually occurs in approximately 1 in 4 patients, so almost 1/4 of patients might have some partial reversion of DWI lesions, which affects about 20% maximum of the final size of the lesion. A complete DWI lesion reversal is very rare, less than 1% of patients, and it usually is related to very small lesions. This reversal actually occurs and is associated with very rapid and complete recanalization. So particularly in patients treated in a very early time window or very shortly after the stroke onset. And the physiology beyond the DWI reversal actually comes back to the DWI, comes back to the technique, because the DWI hyperintensity is occurring already when the cerebral blood flow falls to 20 to 30 milliliters per 100 grams per minute. However, the irreversible injury is around 18 milliliters if the occlusion persists. So in the area when the cerebral blood flow might be 25 to 30-ish, you quickly recanalize the vessel. So that actually means there was not irreversibly injured tissue, and therefore the DWI signal can be normalized. And it's associated, as expected, with early neurological improvement and better clinical outcome. Where else could the MRI be useful? This is more related to follow-up scan, because we can better distinguish on MRI the involvement of the white matter versus when the white matter is spared in the infarct, which is actually associated with better clinical outcome. And sometimes it's very difficult to distinguish whether white matter is affected on the CT, on the early follow-up scan, because there is also a compound, not only the cytotoxic edema, but also the vasogenic edema, which actually makes the whole area to be hypotense on CT. But with MR, we have a better chance to distinguish whether only gray matter is predominantly affected or whether the whole territory is affected. I also should mention venous infarcts, because that's the area or where MRI is very useful and usually indicated. So the venous infarct actually results from impaired venous drainage, which leads to fluid extravasation in that area. Together with the increasing venous hypertension will eventually lead to cerebral infarction as well. Venous infarcts are often hemorrhagic. They tend to be adjacent to venous sinuses and cortical and deep cerebral veins. They don't really, not necessarily follow the vascular territories or arteriovascular territories. And yes, crossing the borders between the arterial territories. And how to identify them on MR. So beside looking for the venous infarct, then we perform either MR or CT venogram, with which will show the filling defects within the sinuses or cortical veins. So here we have a clinical example. It was a 48-year-old woman presenting with a severe headache. This was the FLAIR scan, which actually shows the vasogenic edema. That's also typical for venous infarct, that it, at the beginning it presents as vasogenic edema, which is sparing the cortex, so predominantly involving the subcortical and deep white matter. Here we have increased signal in one of the cortical veins at the convexity, which also shows susceptibility signal loss on the gradient scan. And sometimes, which could be indirect sign of venous sinus thrombosis, are these corkscrew appearing vessels, which is the result of overall venous congestion. So if you see this, then search for other signs and look for the venous sinus thrombosis or the thrombosis of cortical veins. I would briefly touch the stroke mimics because, as mentioned, MRI is a great tool to identify and distinguish stroke mimics from the real stroke. You had a lecture about the stroke mimics in the morning, and this part is more focused on the imaging. So you heard it's already occurring between 3 to 10%. Sometimes it could be a diagnostic challenge to distinguish stroke mimic from the real stroke. They occur more likely in younger patients and more often affecting women. And the clue to identify the mimic is first proper clinical examination, but there is a very crucial role of imaging and also laboratory findings. And we can see on this data that actually most common stroke mimic is seizure followed by syncopes and so on and so forth. So I would start with the migraine. So the majority of patients actually can have a normal CT on MRI scan, but there could be abnormalities seen on perfusion imaging. So compared to the stroke patients, the perfusion deficit also doesn't follow the arteriovascular territories. In migraines with aura, it was shown that there is an increase in mean transit time and time to peak. However, this increase is lower than in stroke patients. And with the episodic migraine without aura, there could be observed interictal hypoperfusion. So here we have one example how the patient with migraine, which has no restricted diffusion on EWI, but on perfusion imaging, there is an area of delayed time to peak. And looking at the vasculature, there is a completely normal finding. Here we have, there is a specific case, which is a hemiplegic migraine. In these cases, it can be noticed hemispheric venous dilatation on the SWI, which is demonstrated as a prominent vessels on the affected side, which also shows affected perfusion, and there might be a regions which actually shows restricted diffusion eventually because of the prolonged venous congestion in these regions. So what is happening during the migraine? So this was also the migraine without the aura, the episodic one. So as mentioned before, it can lead to focal hyperexcitability at the beginning, which eventually leads to spreading depression and hypoperfusion in this area. And if this state persists, it actually eventually may lead to a small cortical infarct. With the seizures, those are the most frequent stroke mimics. They could be focal changes, there could be hemispheric changes, there could be diffuse changes or no changes on the MRI. And in status epilepticus, we can see regional vasogenic or cytotoxic edema. So we might have changes on DWI and flare, and we can also notice some cortical swelling. There is a local hypoperfusion in the affected areas or in the at the areas which are the sources of seizures. And there could be some post-ictal finding, which can be seen as prominent arteries on angiography or on SWI. So what is happening during the seizures? So there is a hyperperfusion at the beginning, which actually eventually leads to vasogenic extracellular edema. And if this state is prolonged, it will lead to cytotoxic intracellular edema and the changes on the DWI as well. So, and these are the typical findings in status epilepticus or in a prolonged seizures. So we might see changes in the signal within the hippocampus and thalamus. There could be also some cortical changes which are not following the vascular territories, but the affection of the or involvement of the hippocampus and the thalamus is the most common. So, and during the epilepticus status, there might be different patterns of hypoperfusion with either absent vessels or, on the other hand, prominent vessels. So, but what is the message from here? There could be different patterns, but usually doesn't really follow the pattern of the ischemia. So search for either unusual hyperperfusion or hypoperfusion if the patient has an MRI with focal changes in the cortical veins. Another stroke mimic could be hypoglycemic encephalopathy. This was a 30-year-old female which was presenting with decreased conscious state. For hypoglycemic encephalopathy is typical the involvement of the posterior limb of the internal capsule and the splenium of corpus callosum, which is called a boomerang sign. There also might be changes involving the cortex, but the involvement of the basal ganglia and specifically of the posterior limb of the internal capsule is very typical. These changes are actually reversible, so it's not a real stroke. And it's just caused by the focal vasogenic focal edema. Here we have another example how it could present. So there could be changes within the basal ganglia. Also, the hippocampi can be involved as well as neocortex. Primary brain tumors, I don't think I have to explain to you how to distinguish brain tumor from ischemia. Sometimes it might be confusing, but so if you see that there is a focal mass effect and plus some calcifications within this lesion, then on the MRI, you clearly see that there is a mass lesion with the surrounding vasogenic edema and calcifications. Same applies to metastasis. Usually it doesn't, the edema which is seen on CT doesn't involve the cortex, and on MR we will see some ring enhancing lesion with extensive vasogenic edema. Demyelination could also be another stroke mimic. Sometimes it could be tricky to distinguish the demyelination from acute stroke, especially when there is just one focal lesion, which can have restricted diffusion in the acute state. And in case of active lesion, there would be this incomplete ring enhancement, but we know that also the stroke may enhance in the acute state or subacute state. So with this, then how to distinguish? Well, clinical examination, search the spine as well, and then follow up the patient. So cerebroamyloid angiography is another stroke mimic. How we can distinguish this? Usually the patients is a very extensive white matter changes with some lacunar infarct, which may also show restricted diffusion in its periphery, plus the pathognomic finding are the microhemorrhages in the periphery of the cortex, and in contrast to chronic cerebral hypertensive encephalopathy, which actually involves the basal ganglia and brainstem. And Press syndrome is one of the last stroke mimics I wanted to mention, which actually you usually see bilateral changes, which are predominantly affecting the parietal occipital regions. There might be some focal restricted diffusion, but it's pretty rare. The changes are predominantly seen on the FLAIR scan. There also could be microhemorrhages within those areas, and this change is also reversible with the normalization of the blood pressure. So what is the take-home message? MRI is actually a recommended technique in selected patients. It's used for diagnostic tool to detect stroke mimics, small infarcts, and infarcts in the posterior circulation. So thanks a lot. I hope you now know how to use the MRI in stroke.
Okay, so thank you, Petra. It was excellent. And I have here 2 questions. Should the FLAIR positivity not be interpreted as a surrogate for infarct progression, and not age, not the time? What do you think about? Can you make a comment on that?
Yes, that's correct assumption. It is a surrogate that the ischemia has developed already, but it can tell us that it's already evolved. So as we know that the signal on FLAIR is occurring after 6 hours approximately, we can also, based on that, establish or give an assumption that this stroke is probably occurred quite some time ago. In contrast to the fact, if we have no changes on the FLAIR, it means that the stroke is not, or infarct is not established there yet, and we might still try to treat the patient and save the penumbra. It's more about the safety, because if you already have DWI lesion with the FLAIR, then you know the infarct is established, and then you might have a higher risk of hemorrhagic transformation if you give patient the TPA. And that was the purpose of Wake Up Stroke, to look into that. So that is my understanding. It also comes a bit tricky, because sometimes when you will say there is no definition what is already FLAIR abnormality, there might be some very mild increased signal on FLAIR, or in contrast to clearly high signal on FLAIR, and no one actually explained if that is if that should be already considered as a mismatch or not. So there are a few questions related to this. However, I still believe it's a useful tool when you really want to treat your patients and give you some brief idea when the stroke has started.
Would you make just a brief comment about the MR perfusion, since there is a question dedicated to this from Michael?
Okay, well, MR perfusion, it actually was the first, or it was first established on MR, especially in stroke treatment. Then it's expanded to CT. So with MR perfusion, there are also different techniques. And we are basically comparing the perfusion lesion, which is our penumbra, to ischemic core, which is defined by DWI. So the mismatch on MR is based on DWI and perfusion mismatch. However, we can also discuss about the core. What is the core? That's also which is also a question, and which is challenged in these days. If the lesion on DWI is the real ischemic core or not, but it applies to CT as well. So,
yeah. Okay. So thank you for now. And this was your last lecture on this course.
yeah.
So thank you for your contribution to this, and have a nice afternoon or noon to Calgary, since we have an evening in Prague.
Thank you. Thanks again for inviting me. It's always a pleasure to participate in this course. And I wish all the participants to have a great rest of the week and learn some new stuff.
Okay, so have a nice day.
You too.
And now we will continue with just a little bit practical lecture, and which it's called the technical overview, and that's the announcement of me that this lecture is dedicated for those who have had no experience with cerebral catheterization and mechanical thrombectomy, since I mean there are participants having no catheterization skills, and but I mean we still are happy to have them here, since we need more doctors to provide this therapy around the world. Basically, this is the NGO room, and they're describing what everything is here available. Beside the CR and protecting the shield devices, which are already been discussed yesterday, angiographic table, monitor. It might be different. I mean, this one is monoplane, and this is pretty much the standard. And what I like to stress here is the clock, and in every operating room the clock is very important, and they should be seen by the operator, since you may know that longer procedure is usually more complicated, and we should be aware of time all during the case. So first we'll start with arterial puncture and sheath placement. This is the drawing from the old textbook of angiography, and 97% of the pointer is not working here. 97% femoral arteries are running in the medial part of the femoral head, and just minimum of them are in medially to the femoral head. So I mean, if you cannot puncture the artery, don't feel the pulse, you can switch to fluoro and look. There is a femoral head, and you see the puncture supposed to be in across the femoral head. It's we can puncture it below or as well. However, as soon as you use a compression to stop the bleeding after remove the catheter, this is much more effective than if it is the compression against the bone, not against just the muscles and soft tissues. And if you puncture above femoral head, you might be in the intraperitoneal part of the artery, and as soon as you remove the catheter, there must be severe hemorrhage. So the puncture has to be against the femoral head. We like to use ultrasonography to navigate the puncture, and it's easy to see. Here is the needle, and in each catheterization lab we have an ultrasonography machine, and somehow incorporated in the angio machine. And so definitely this decrease the number of complications from the groin. Sometimes we have patients who are extremely obese, and this is the problem to be safe even in these patients, which create lots of technical complications. And sometimes they recommend to use a radial approach, which was also discussed today. in questions which we haven't had answered yet, but I mean, I like to discuss some of these topics during this technical overview. So extremely obese patients probably could be done safely from a radial approach if you are experienced in radial approach catheterization, which is domain of the cardiologist. If we place the guide wire, always advance the guide wire under fluoroscopy to look where it is going, and if the position is supposed to be in the abdominal aorta and not in some strange or funny position. So then you advance guide wire, watch its position. That's rule of the thumb. Sometimes the guide wire can enter the circumflex iliac artery, and if you push too hard, and you can create vasospasm, and you can remove the catheter, you can remove the guide wire, and it might be painful and it's technical complication. In this particular case, you see that the flimsy or the flexible part of the guide wire create the loop and enter the external iliac artery. The ultrasonography is good also for appreciation of the atherosclerotic disease at the puncture site, which might be symmetrical and sometimes create the problems with introduction of the guide wire. And as soon as you use the closure devices in such setting, this might lead to subsequent thrombosis of the artery, and the patient has to be revised by vascular surgeons during the night. So the ultrasonography is very highly appreciated in the stroke therapy. There are several studies or reviews comparing the transradial and transfemoral approach. This will be discussed during the course again. And the advantage of the femoral approach that you can introduce easily large bore catheters like a 9 French sheath, 9 French guiding catheters, and balloon catheters. So I mean, this is not the case of radial approach. And the radial approach is utilized especially in tortuous anatomy of vertebral arteries if you treat in occlusion in posterior circulation. The radial approach is more technically demanding, and as you said, as you heard in Jens' lecture, if somebody is experienced in this or that and prefer that, it's upon the decision of the operator to make it using radial or femoral approach. If we have a complication as a pseudoaneurysm which occur the day or day 2 after the procedure, this is treated under ultrasonography using the probe and the puncture of the pseudoaneurysm and injection of the thrombin. You have used some compression to close the neck of the pseudoaneurysm, and it shows you immediately hyper echogenic material inside that pseudoaneurysm with no flow. So that gives you a proof that the pseudoaneurysm is closed. So I mean, it's good to know this technique, since you can treat your complication by yourself and not ask another doctor. This is one of the closure devices we've been using. It's utilized almost in 95% of our cases, since these patients are under after thrombolysis, intravenous thrombolysis, and especially in obese patients and patients who are old, elderly patients, that the risk of bleeding this is minimized. And I mean, there are some additional expenses for that, but I think this is today pretty much the standard to close the puncture site using the closure devices. There are a whole bunch of these devices. Aortic arch will be a lecture about that tomorrow. And it's another step. Basically, there are different types of aortic arch depending on elongation of aorta. And especially in the patients who suffered from hypertension, the position of the origin of the carotid arteries and subclavian arteries moving towards the heart. So it might be difficult to catheterize it. So type 3, it's more difficult to catheterization, but I mean for experienced doctor, it's the routine. So for that, we to select the catheter, we have a chance to see the aortic arch on CT. So you can estimate which type of aortic arch is present in a particular patient. Sometimes we can appreciate or assess the atherosclerotic disease at the origin of these arteries as well, which has to be crossed with the catheters. And if you have an aortic arch like this, I mean, definitely that's the reason why these procedures, thrombectomies or carotid stenting, takes longer time than if you have a nice straight course of several arteries. I mean, you should look on the different shape of these cerebral catheters, and also look on the length of them. Some of them are 90 centimeters, some of them 100, even 125 centimeters. So if you select these, you have to compare this catheter maybe with the guiding catheter, depending on the technique which you use, and was already addressed by Philip Zillars in the coaxial and multi-axial systems. I mean, this is the easy aortic arch type 1, and for that they use the Bernstein catheter, which is something quite easy and usually fast as well. For type 2 or type 3, we use a Simmons and place the guide wire into the cerebral artery and common carotid artery, and if possibly to the external, just to be sure that we don't do any injury during the exchange over a wire, the catheter for the guiding system. Here you see the Simmons catheter, which is quite often used for cerebral arteries, and this is Kerber catheter or VTEC catheter, which is more universal, can be used for type 1 or type 3 aortic arch as well. So I mean, depending again on your practice, you can select these. Angiography already been discussed that we use shutters to decrease the field of view, and I mean, for stroke we usually use the frequency of the frames 2 per second, and guiding catheter placement has to be flushed and already been discussed today. And that heparinization, if the procedure is long, and if you place the routinely heparin in your high pressure flushes, the dose of heparin which is given to the patient during the procedure could be significant. And this was the group of Mr. Clean study. They proved if they used heparin, sometimes 5,000 per 1 liter, sometimes 2,000, and sometimes just the 500 units, and some centers have no heparin, just to use the normal saline. So the number of hemorrhages decreased, intracranial hemorrhages after stroke therapy decreased if they used just the minimum or no heparin. So I mean, that's something which should be accepted in our routine practice, and ask the nurses and all that, be aware how much of heparin is in the flushes. balloon guiding catheters. This is something which we would like to promote in your practice. We say it's crucial, it's reasonable to use it according guidelines. However, there is no prospective randomized study comparing that. And the practice is that we place the balloon catheter, and there was a question from the audience today, when to inflate and for how long, and when to deflate the balloon guiding catheter. So we use the guiding catheter with no inflation to manipulate the microcatheter and maybe the aspiration catheter and stent retriever into the intracranial vessels. And as soon as we are ready to remove the stent retriever or to aspirate, we inflate the balloon just to close the flow of the artery, not to do angioplasty with this, compliant balloon. And just the volume should be just enough to close the flow. And during the removal of the system, we apply aspiration. And the purpose of that is to aspirate or clots fragments, possible clot fragments to the guiding catheter, which occurs almost in 50% cases that we reveal some pieces of the clot in the syringe from the blood which was aspirated during the removal of the stent retriever or aspiration catheter. So I think this is important, and this system can be criticized that it's more rough and can create the injury. Surprisingly, this is not so frequent, and on contrary to the benefit that it can reveal in the aspirated blood, the almost 50% volume of the blood clot we removed from the head, that's the beneficiation of that is quite clear. And sometimes you see that these clots, if you flush the blood. There are several balloon catheters that have an inner lumen. If they have large inner lumen and 8 French, then the wall of these catheters is thin, and the catheter is very flexible. So you need something to support that. And sometimes they use the 80 centimeters sheaths, which are placed first in the common carotid arteries, and then through that sheath is placed this softer balloon catheter. You can select among these. I mean, first generation of Mercy guiding catheters is something in between, and is also resistant to kinking. Here you see the fragments of this was experiment from this publication, that the pieces of the clot can be aspirated on this experiment, that the clot was opacified with contrast medium. Also, as I said, was an experiment, and removed by aspiration. In spite of that nice publication, the survey of role of balloon guiding catheter from South Korea, and I did just a questionnaire about what is using in thrombectomies in Czechia, and last year we collected almost 1,300 cases, and only in 50% cases the operators used the balloon guiding catheter, which is a very low number to my mind, and I would expect that to be more. So what are the properties of the guiding catheter? Stiffness, especially proximal stiffness, which should keep pushability, especially in tortuous anatomy in iliac and aortic arch and thoracic aorta, and trackability. So some of these catheters, they are hydrophilic coated, then they can be easily advance into the carotid artery. There are the other balloon guiding catheters, and I mean, in this anatomy like this, sometimes you see what's possible over the guide wire, which is placed into the internal carotid artery using the Simmons catheter. In such a tortuous anatomy, you can, over this, you can introduce the system of 5 French catheter and 8 or 9 French balloon guiding catheter like this. So, I mean, still this is the position in the patient with very, very tortuous anatomy and difficult aortic arch. In some of these patients, you can use the direct puncture, which has been already reported to as well, and the puncture is done under ultrasonography. But what we recommend to do it in intubated patient, and however, that sometimes that's the only approach which is effective if you want to recanalize the M1. Intracranial catheter placement already been mentioned, and the sizes should matched, and sometimes it's a little bit confusing since there is no normalized custom how to put on the cover these numbers, and there was a paper which was written by Patrick Brewer, and they faced the problems which are about reporting the sizes and diameters of this. And I like to, I mean, the French, that's like a free French is 1 millimeter, and it comes from a Charrier, Joseph Frederick Charrier, from the 19th century, who developed this system, which is wide used today, and sometimes we should use the millimeters as well. So I mean, what would be fine if all companies or manufacturers would give us the inner diameter, proximal outer diameter, distal outer diameter, and minimal diameter needed for introduction in receiving catheter. And if you see these are images from this paper that sometimes it's quite confusing. Length matters too, as you heard today already in the coaxial and multi-axial system. Ideally, one should use the shortest length necessary to do job. So I mean, try to avoid the long distal access, since sometimes you might run the problems as you see here with a red arrow. The interventional neurologists love to combine access catheter like a coaxial double triple, and they create something which we call tower of power to have enough support to push the devices and finally micro catheters into them. That's the Joseph Frederick Charrier from 19th century, who developed the company making surgical instruments and also the rubber tubes for urology. In Czechia, and that the same survey we did about 1,300 patients last year. So about 28% operators reported to use only stent retriever. 45% combination of aspiration catheter and stent retriever, which is very expensive procedure, and only 27% only aspiration. So I mean, to give you just, that was a questionnaire, and what's today in 2021 in certain community of interventional neuroradiologists the practice. If you look on the distal occlusions, that's interesting. This paper, which was from 2021, and they used almost the same ratio of stent retrievers like a 27 in M2 recanalization, direct aspiration in 20%, and combined technique of aspiration and stent retriever in 50%. So I mean, it's very similar ratio. And what's important in M2, since I mean, this diameter of M2 is smaller and these arteries are more fragile and then prone to injury. So successful reperfusion was achieved in the combined technique in 82%, which is quite good percentage, with stent retriever alone in 84%, while with direct aspiration only in 66%. So that was fine, that we say that the stent retriever they do better. However, the intra-procedure subarachnoid hemorrhage using the stents in combination or alone was almost 8%, while in aspiration it was much less. So if we combine the complications due to stent retrievers in M2 and injuries, that we have the same results, clinical results, as using much less effective aspiration. So I mean, so that finally this was no detectable difference in clinical outcome in 3 months. So I mean, that's interesting, that it seems that you should use as soft stent retriever and probably 3 millimeters in diameter in M2 or these for these distal occlusions. So I see a tortuosity that's quite frequent, and definitely it prolongs the time of the procedure. Some carotid siphons, which are easy to cross, however, they are on the right side. They are a carotid siphon, which might be difficult, especially for aspiration current. And also tortuosity of M1 segment could be like this. On the left is fine, on the right is tortuous. Again, this makes the procedure more difficult. And you should be aware of the bifurcation, trifurcation, even quadrifurcation of these arteries, and aspiration already been mentioned. And this is something which again was mentioned as a revolution, to place the aspiration catheter without guide wire, without microcatheter into the intracranial circulation. And we do that in posterior circulation as a first choice, and especially the clot, which is whitish, sticky, that's the fibrin-rich clot. And then aspiration, we use a removable valve, and sometimes the clot gets stuck into the guiding catheter or into the sheath and has to be removed like this. While stent retrievers, and this will be mentioned in the first pass effect, has to be a little bit behind the occlusion. So it's better if the clot is in the proximal part of the stent retriever, which is deployed there. There are many stent retrievers, and hopefully in the second part of this course, you will have a chance to see some of them. And you have to be sure that during the loading of the stent retriever, that the tube, introduction tube, which is introduced through the valve, has to be in contact with the hub of the microcatheter, as you see here. Otherwise, you can deploy partially the stent retriever and you can damage it. And also we see here something like a mark. I do hope that you see, since my pointer does not work. And that tells you, then you can switch the fluoro. As soon as this passes the rotating hemostatic valve, then you can switch on the fluoro and see the advancement of the stent retriever like this. Combination of the stent retriever, or it's called also the badass technique, seems to be more effective, and it's part of the strategy of first pass. See the stent, microcatheter, and aspiration catheter. As soon as you deploy the stent, you can release the hemostatic valve, and quite easily, while the stent retriever is deployed in M1 segment, for instance, quite easily you remove the microcatheter while the stent retriever is in the artery, and you in this maneuver you can increase the space between the stent retriever and aspiration catheter, and the aspiration is much more effective. And both that there is larger space and also the aspiration is applied as close to the clot as possible. And this is the rotating hemostatic valve. Other techniques like tiger retriever, that's something which you can actively change the diameter of this device, which is quite unique, and entrap the clot and remove it and use also. And fibrin-rich clot, that's something like a geometric clot extractor having the 3D design. And there are also the tricks how to trap the clot. And it's usually used or recommended to use after 3 unsuccessful passes of stent retriever. And sometimes you can use dual stent retrievers. So clot integration into the stent retriever is a function of delivery technique, duration of device implantation, and clot mechanics. Use all tricks to remove the clot on the first pass, including aspiration via balloon guide, and only comparative meta-analyses are available so far. So I mean, that's the end of that. And I look if I have any questions here. Since do you apply aspiration to both balloon guiding catheter and aspiration catheter simultaneously or sequentially? If we have an aspiration catheter which is played through the balloon guiding catheter, usually there is no space between these two catheters, since we use 6 French aspiration catheter and 9 French, which is the outer diameter of the balloon guiding catheter. So we apply aspiration only through the aspiration catheter, and that's it. And we can, by removal of the microcatheter, you can increase the effect of aspiration, since the space between the wire, delivery wire for stent retriever and the aspiration catheter is increasing for that. The question regarding the inflation and deflation balloon guiding catheter, usually we inflate the balloon as soon as we start to remove the stent retriever with engaged clot, and deflate it as soon as we can freely can aspirate through the guiding catheter. And that means that the majority of clot which is in the internal carotid artery is already out. And you know, there are the problems in the large posterior communicating artery, and you see that the branches of ICA otherwise are quite small, and during the aspiration you actually reverse the flow to the guiding catheter from the brain, which does not make any problem regarding the brain oxygenation, and works well. And about the tirofiban to use to inject after mechanical thrombectomy, we'll speak about that tomorrow. And another more, why does the guide catheter have to have a balloon inflated? Is it to reduce the risk of embolization or for stability of the guide wire? Yes, I mean that we stop the flow. That's the main reason. Sometimes, if you have a large bore catheter, especially in vertebral artery, you can create the spasm, and just by placement of the such a guiding catheter, you'll stop the flow by itself, which is demanded for the clot retrieval. And if you have a retortuous anatomy and have a problems to stabilize and push the microcatheter with guide wire, micro guide wire, you can inflate the balloon and stabilize the system. That works as well. And there was also the idea, since more distal embolization occurs during the crossing the clot with the system of microcatheter and microwire, and that probably occurs distal embolization during this maneuver, which is on contrary to contact aspiration. If contact aspiration, you don't cross the clot and you just catch the clot by aspiration and try to ingest the clot into the aspiration catheter. So you don't cross it. However, that's just the experimental observation and also the theory. And so sometimes they recommend to inflate the balloon catheter during the crossing the clot and then deploy the stent. And as soon as the stent is deployed, you can release the balloon and inflate it again as soon as you, after 3-4 minutes of deployment, you retrieve the clot and the stent retriever. Sometimes it's recommended to do a injection angiographic run while the stent retriever is deployed in the clot to see where is the clot in relationship to the stent position, and also to see if they are in the correct branch, if it is M2 or M3, or if the clot, if there is some minimal flow and what's going behind the occlusion. Are you using any vasodilator in your infusion saline? I mean, for a regular stroke, no. The vasospasm, extracranial vasospasm, occur in, especially in younger ladies, and also can decrease the blood pressure. So in a regular stroke, no, and unless that's something which is a little bit creating problems, and I will speak about that tomorrow, about the medication during the stent retriever. If you get arterial spasm, do you use GTN? I don't understand. That's we use a nimodipine. That's a dilceran for that. Use 1 cc of nimodipine and dilute it in the 20 cc of normal saline. What's the ideal drug for catheter spasm? We've been using this. That's the nimodipine. Okay, it seems that we can discuss some of these questions, and I keep them for tomorrow, especially for perioperative medication and what can be used to finish the procedure successfully. So now, can I ask, since I mean we can make it shorter, and we are ready for today's test, and here is our instruction. So the YouTube is a little bit with delay, so you have to connect to the Zoom meeting. So there are instructions, and click on the test menu on Askaret website and go to current daily test and Zoom meeting, and you can use either this link or the QR code to get to the Slido. And we will keep this slide here, and we will meet in 5 minutes. You will see how many of you are already joined the Slido, and we will start. We have around 30 questions, and we will see immediately the ratio, who was correct, who not, and finally we will see the winner, or maybe 3 winners, best answered doctors of today's test. So I mean, the test, it's for you, and you will see how successful you were, and it just gives you idea about the Friday test, and maybe if you apply for European diploma, you can also see how what type of questions will come. Okay, so see you in 4 minutes. So hello back again, and now we will start with the quiz. So you will see the questions. Seems that we have 29 of them, and that's the first one. Excitotoxicity is late event in the setting of brain ischemia. So that you are supposed to ask to answer true or false. This is the same system and the final test, and the same system as is utilized in diploma. So we are supposed to see the answers. That's the 48 to 52. So I mean, that's quite difficult. This is the false. It's not a late event, it's very early event, since the glutamate is released in the cell and it's damaged by that's something like a suicide. So it's an early event. Next question. The most affected neurons in the early phase of cardiac arrest include the hippocampus and striatum. Okay, you are correct. It's true. They are more sensitive to the anoxygenation. You are correct. So the brain receives 20% of cardiac output. Yes, it's easy. You are correct. 79%. It's true. All the processes that contribute to neural injury after ischemia happen in the first minutes after large vessel occlusion. Oh, it's true. So you are not correct. That was difficult for you. The energy failure is crucial to regulate ionic gradients across the cell membrane. Okay, correct. It's true. Energy is crucial, has been mentioned. The central part of ischemic territory in which blood flow declines below the threshold of terminal depolarization is the penumbra. Yeah, definitely it's false. You are right. Decrease in proportion of oxygen extraction from the blood is an adaptation to hypoperfusion. Yeah, I mean, this is doesn't make sense, so it's false. 70% correct. Blood-brain barrier damage results in cytotoxic edema. This is from yesterday. Yeah, it's false. It's vasogenic edema. Okay, 70% correct. The initiation of and propagation of action potentials places high demands on the energetic resources of neural tissue. Yes, that you are correct, 94% correct. Okay. The ischemic core is rendered sufficiently ischemic to be electrically silent, but hasn't yet undergone ischemic depolarization. Yeah, that's false. You are right, 80% correct. The Alara principle means that even if it is a small radiation dose, if receiving that dose has no direct benefit, you should try to avoid it. Yeah, that's true. Perfect, 98% correct. The skated radiation can be lowered by shielding, distance, and technical improvements. Okay, again, that's correct. 90. the patient during the fluoroscopy should be as far as technically possible from the detector. That's false, 88% correct. Okay. Neurointerventional procedures are without deterministic effects of radiation. Yeah, that's false. These are not, I mean, heavy, but we see them from time to time. Personal behavior and scattered radiation effects awareness have significant role in lowering radiation dose. Okay, perfect. 100%. It's easy question. Now, the mimics. Stroke is a clinical diagnosis that is supported in all cases by an appropriate abnormality on brain imaging. That's false. The available data suggest a high prevalence of hemorrhagic and systemic complications in patients with stroke mimics receiving RTPA. Okay, that's false. Congratulations, 88%. About 30% of patients admitted to the emergency with possible stroke, focal brain dysfunction of apparently abrupt onset. So this was the question to your estimation yesterday from Diana. Yeah, it was true. There was also the answer 40%. I mean, it's 30%. When standard workup is used, the etiology of ischemic stroke is identified in about 95% of cases. Yeah, it's false, definitely. I mean, it would be great, but it's not a reality. In patients presenting with seizures, the diagnosis of acute ischemic stroke can be excluded. Yeah, definitely. 90% is correct. It's false. Cytotoxic edema is pathognomonic of ischemic stroke and cannot be found in stroke mimics like a non-convulsive status epilepticus or hypoglycemia. Yeah, it's false, 84% correct. Causes such as infection, vasculitis, and hypercoagulopathy require treatment distinct from standard therapies to prevent recurrence. Yeah, it's true. 92% correct. Congratulations. A diagnosis of functional disorder can be done whenever the MR study is negative, even in the absence of inconsistency in the neurological evaluation. So it's false, 78% correct. Okay. According to trial of ORC 10,172 in acute stroke treatment, so-called TOAST, classification causes for ischemic stroke are divided into several groups. One of them is CADASIL. Is that right? Is that correct? And the CADASIL is a cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So, I mean, for those who do not know this inherited disease. For a neuroradiologist, it's very well known. So it's false, 58% only. That's too specified cause, so it's not into the among this. There is a strong evidence that long-term use of antiplatelet monotherapy, aspirin and clopidogrel, results in significant risk reduction of ischemic stroke, myocardial infarction, and vascular death. That's true, 87% correct. Okay. Aspirin is a prodrug that reversibly inactivates the cyclooxygenase enzymes, and the oral loading dose sufficient to block platelets is 500 milligrams. So it's false, yes, 80% correct. It's an active drug, and the dose is lower, up to 350 milligrams, enough for loading dose. So clopidogrel is a prodrug activated by hepatic enzymes, and recommended oral loading dose is 300 milligrams. Yeah, that's right. That's correct. 78% correct. Oral anticoagulation is evidence-based secondary prevention of non-cardioembolic ischemic stroke. That's false. So it's cardioembolic prevention. Long-term, more than 1 month, dual antiplatelet therapy, a combination of aspirin and clopidogrel, doesn't increase the risk of minor and major hemorrhages. Yeah, that's false. It's not recommended. There is a significant body of evidence that aspirin use is beneficial in the primary cardiovascular, cerebrovascular prevention. Yeah, that's false, only 32. Since the aspirin is in primary prevention is a failed theory, and it is not recommended now. So 32% correct only. So apixaban, dabigatran, edoxaban, and rivaroxaban are oral anticoagulants used for secondary stroke prevention of cardioembolic origin, e.g. In non-valvular atrial fibrillation associated ischemic strokes. That's true. 92% correct. Ticagrelor is a reversible antagonist of the ADP-P2Y receptor with a recommended dose regimen of 90 milligrams per day, twice a day. That's correct. That's true. 81% is correct. And should be the last question. Addition to clopidogrel to aspirin within 24 hours after the symptom onset of high-risk TIA or minor stroke significantly reduces the risk of subsequent ischemic stroke. That's correct. Yeah, 92% are correct, so it's true. So congratulations to the last question. And the winner, Paul Scott, that's 32 out of 33 correct. This is pretty good. And Y.H. Mack, David Lauer, number 3, Radika Lotikar, number 4, and Frederick van Gool, number 5. So congratulations. And hardest question was all the processes that contribute to neural injury after ischemia happen in the first minutes after large vessel occlusion. That's something which was not answered correctly by majority of you. I put a note in these difficult questions and hopefully to take them out of the test. Okay, if you have any questions, you can write me in the chat, and I will wait a few minutes. And if there are no questions, we will see you tomorrow morning at 8:30 again of Central European time. And tomorrow we will have imaging morning, so it'll be the CT and from Maastricht. Okay, how many questions will have the final test? 100, Friday, 100 questions. And the diploma, European diploma, which is online, that's pretty difficult, 500 questions. And you will be watched by artificial intelligence during the test. So I think, I don't know how many hours are allocated for that, maybe 2 or 3 hours. It's organized by Matthias Gavrica. For the Friday means the 60 answers should be correct. That's exactly, yeah, that's the past mark. How can I see the questions asked today? I mean, they are in archive. I mean, yeah, I mean, the questions during the week are for everybody. However, the Friday test, it's kept in secret, since we have to keep some protection against abuse. And we also, these questions were done by speakers, and we have a bank of questions for the final exams. So we don't like to have any leaks of these questions to the general population. And the final test will be on Friday at start at 10, and there will be just a short training that be sure that everybody is online, and we will keep it easy, don't worry. So I do hope that you enjoy a little bit the test and just have a taste how it to work for examinations, and also learn something. And I mean, the results is just for you, and that's it. Okay, so if there are no further questions, I will finish. Thank you too, and also thanks for all questions, and I sent your thanks to the speakers too by mail, since they are disconnected, and I have greetings from Diana for everybody to enjoy the course. Okay, that was from Walid Abbasi. Respected. I didn't get all the questions. Was facing problems selecting options. In 50% of questions, only saw question for 5, see only. All right, we check it with our technical team here, since I mean behind me is the team of the people supporting all this and organizing. Since at the beginning we have problems, now it's much more easy for everybody, since we already had some experience, and so we will check the same issue that the Ali. Okay, we'll look at that. All right, so it seems that no further questions, since they always delay between you, YouTube, and me, and so I mean, therefore, we finish the discussion, and sometimes I received more questions, which I try to answer later or during the lecture, which is on a similar topic. Okay, so have a nice days in your countries, and see you tomorrow at 8:30 a.m. of Central European time.